Joining us today. This is a very interactive teaching course, so we'll be very happy. If you have any doubts, you should ask in between the sessions, and we'll definitely deliberate on those questions, and all suggestions are welcome. So today, throughout the day, we'll be showing many 3D videos as well as a few 2D videos. All these videos will be giving certain I would say techniques or tricks or certain messages, and these are structured in such a way that we all understand what is happening in these cases, so that we build up our concepts based on that. So the first video which we'll be showing is actually a very usual scenario, or nowadays I think it has become more common problem as we are dealing with more and more soft cataracts. So the first case I will be starting now. Lights off. Audio hai?
This video is part of PhacoTips 3D teaching course.
So this is a kind of a deferred live surgery where I am tackling a soft cataract. You can see there is a posterior subcapsular cataract. The AC appears deep. So these cases where there is a soft cataract and deep AC, there is always a risk of bowl formation, also in cortical cataracts. So here I am doing capsulorhexis under OVD using cystitome. So I have bent the cystitome at two places. I am using the center of triangle rule, which we all saw yesterday during our basic courses. And you can see I am continuously shifting where I am holding the capsular tear. It is always at the center of the imaginary triangle. Once that is done, I am going to do hydrodissection, and hydrodissection is very important for soft cataract, going till the periphery, injecting enough amount of fluid, and you can see the shallowing of the AC and fluid wave behind, indicating that the nucleus is now free. I think this is very critical step in all cases, but particularly soft cataract. If you fail to do hydrodissection properly, you have more problems later. So the nucleus is free, as you can see. I am rotating it easily. The chamber is deep. My plan here is to do a very narrow trench to begin with, and then divide the nucleus. Watch, my chopper is, or this is long Sinski, 1 mm Sinski, which I am holding such a way that it lies horizontal at the depth of the groove there. But this is a soft grade of cataract, and always once you do hydro and start doing this, you generally lose the glow, and that is where the trouble begins, because sometimes you don't get the right depth perception. I am trying to make a deep groove, as I know that in these cases I may land up with bowl formation, and I am trying to divide it very carefully, but somehow the nucleus is not getting divided. This happens when the cataract is little gummy or sticky, where it doesn't break that easily even if you make a deep trench. And also I found that when the chamber is deep, indicating that probably the overall tissues are more elastic. That is where you tend to have more of these issues. Now here I am trying to do a mechanical chop, and now I thought that I have divided into two heminuclei, so I am going to pull this out, but these are still attached. You can see there was no clear central division in this case. So I thought that let me divide, or let me try to take out the other heminucleus. So I have shifted my settings to chop settings, and with bevel sideways I am trying to grab this anterior part, but these two heminuclei are clearly not separated yet, and now I know that I am landing up with bowl formation here. Now though I am trying to grab this these pieces from the anterior part, which is a bit safer, and pull it out, because they are all attached together, I am not able to remove one of these pieces. In fact, all the pieces are closely attached to each other. So here what you have to do is that you have to keep on rotating this nucleus, and this is where the hydrodissection helps, because if you hydrodissected the nucleus, you can rotate it and then start chipping off, from this anterior edge as far as possible. You chip off. So Already I have made a bowl. Now I am making this bowl little bigger so that later I can do viscodissection and flip this nucleus out of the bag. So now the big bowl is already formed. So now the trick here is to do viscodissection and take this nucleus out from the bag. Now the common mistake what we do in viscodissection, just watch, I have injected and now I continue to inject it in the anterior chamber, and that's where the viscodissection fails. So during viscodissection, now I will show, I go into the periphery just like hydrodissection, and you keep injecting the viscoelastic in the periphery. Don't inject viscoelastic in front. We'll just see it again, just like hydrodissection. Continue to inject in the periphery, that is under the capsule, and do not inject visco in front of this nucleus. That's when you tend to again push this nucleus down into the bag. So remember, never push any viscoelastic anterior to the nucleus, and always use dispersive OVD for this. And once you have this bowl out, just attack the anterior edge, peripheral edge of this nucleus and start trimming it down. Most common mistake you tend to do in these cases that you target the center of the nucleus again, but that is not what you have to do. You have to target the periphery of the nucleus which is lifted up and start trimming it down. Even if now the bowl, like the nucleus goes back in the bag, you have a small nucleus, so you can then easily pull it up and emulsify. So that is the trick behind taking out the nucleus after bowl formation. And as I mentioned during the talk, that a couple of risk factors while for creating bowl is, one is soft cortical cataract, and second I found was deep anterior chamber, particularly which deepens after entry of the probe, which indicates that the tissues are more elastic. So rest of the surgery goes well. I am using hydrophobic single piece lens here, acryl toric, and this is a toric IL, so I am using a markerless system here to align the marks according to the markerless. You can see those 3 lines which indicate the position of the IOL inside the eye, and good hydration, and that's the end of the case. So for soft cataracts, this is a very common problem, but I think you can take care of it very easily once you know how to do the viscodissection. Are there any questions about this technique? We have next video also coming up on soft cataract. If there are any questions, then yeah.
Generally what I do is I do hydro again. So the other pole comes out. Are there any advantages of viscodissection over hydrodissection?
No, both dissection techniques are absolutely fine. So whichever you are comfortable with, you can do it. The one advantage of viscodissection is that because one of the common difficulties surgeons face is after you do hydrodissection, when you put your probe again back inside, sometimes it just goes back into the bag, particularly when you have a larger CCC. So if you do viscodissection, because you have used a dispersive OVD, it is unlikely that it will go back unless you aspirate that OVD first. So that is the one advantage which I found with viscodissection technique. And to just re-emphasize, you should always use a dispersive OVD for this rather than a cohesive OVD, because if you use cohesive OVD, the purpose is lost because it will get aspirated even faster than BSS. Yes,
so
sir. There is one more. Yes.
So we are not able to get it outside.
The question is what to do if the viscodissection doesn't work. That is a problem, and usually it doesn't work mainly when your capsular axis is small. So that is the first thing. For soft cataracts, I think just like when we deal with hard cataract, we always emphasize on larger size axis like 5, 5.5. I think soft cataracts becomes easier if you have a larger axis. So at least 5 mm is what should be our target. 4.5 or less, you will land up with these issues where you cannot even hydrodissect or viscodissect, and even in such cases, if you do hydrodissection, there is always a risk of posterior capsular rupture also when the CCC is small. So first thing is you must do a 5 mm rhexis in soft cataract. Don't go ahead with the surgery. The moment you do hydrodissection, the glow is lost, and then enlarging this rhexis is not difficult. It's not impossible, but it becomes difficult. Sometimes you may have to restain the capsule, wash the CCC, and you can enlarge it. But if you are stuck in this step where you cannot hydrodissect, what I would advise is that remove visco, do restaining, wash the capsule rhexis, enlarge the capsule rhexis, and then do hydrodissection. You will be successful in that.
Hello. Sir, in very soft cataract, instead of doing the bowl and all, first of all, you hydrodissect and bring to the AC and eat up the, that's
yes.
it. Is it enough?
That is also a technique. We'll show it in subsequent videos. That is also another technique. In that
Excuse
case,
me, sir.
again, when you prolapse out the nucleus from the bag, again the size of capsulex is very important. And beginners, they tend to do a smaller capsulexis, and if they try to prolapse it out, hydrorupture is a risk factor. So always make sure rhexis size is good.
Hello.
Yeah.
In
Yes,
soft
sir.
cataract, there is a big bowel formation, and sometimes it is not hydroprolapse with water or visco. So that scenario, mechanical chop with the ball dialer
Yes.
simply, and fill the antechamber with visco, then just follow the contour of the equator,
Yes.
and just simple mechanical cracking, that will helpful.
Very good, yes. So that is another trick you can use. What he mentioned is a ball tip chopper, or any, for that matter, a blunt chopper. And just like how you negotiate in case of a small incision cataract surgery where you prolapse out the nucleus, you can imagine that you are doing a small incision cataract surgery and prolapse out that nucleus part. So this technique also you can use in these cases.
So we have a question from Dr. Rajesh Agarwal. So he is asking whether the preferred phaco settings for soft cataract.
Yes, Dr. Deepak, you would like to know?
See, the most critical factor here is the power has to be as low as possible. That's the most important step. Whether you're doing sculpting, whether you're doing quadrant removal, whether you're doing chop is not possible. Even if you're trying to do a mechanical chop, the phaco power use will be 0, and then you're going to use the vacuum to hold it and then do a mechanical horizontal chop. So that is the first important step. And second would be, if at all you're using, you want to hold the nucleus, the setting should be like, 5% in burst mode. That is the lowest possible setting in burst mode. And use it only to just to oppose it, occlude it, and immediately pull it out if you want to pull it out of the bag, the fragments. So that's the most important step.
I think one of the things with vacuum for soft cataract, in most of my cases, I keep vacuum on panel mode where it reaches high immediately. For soft cataracts, particularly you want to prolapse out the heminucleus or quadrant, it's better to have a linear control on the vacuum, because sometimes if you keep the vacuum very high, it tends to just pull a part of it out, and then you are creating more bowl. So before the bowl forms, you can have a linear control of the vacuum, so that you can catch hold of this heminucleus and pull it out without having, because with panel mode sometimes you grab the part of the nucleus and just cuts off, and then the bowl starts. Maybe a linear vacuum will be a better option.
Now, the situation where your rhexis is small and you're stuck with an epinucleus, it is not coming by the visco or this thing, it's just epinucleus. In this situation, see, we need to understand the resistance predominantly is by the rhexis size. The epinucleus size and the rhexis size are not matching, that's the reason you're unable to prolapse it out. So if you're not able to enlarge the rhexis, which is the ideal thing to do, and if you're scared to do it or for some reason, try to reduce the size of the epinucleus just by nibbling at it. Use very low power and just to try to nibble at the epinuclear margin. It's just like chip and flip. You're going to nibble at the epinucleus for 3/4 of the quadrants, the size of the epinucleus comes down, and then it's easier for us to flip it out of the bag. So either you increase the size of rhexis or decrease the size of the epinucleus. That principle you need to understand.
Good morning. In soft cataract, how do we decide the depth of the trench? Because the retroglue is seen, and while chopping there is cheese wiring, and it becomes a very difficult task later.
For trenching, you have to remember that you in soft cataract the basic principle is having a narrow trench and also a deep trench. So you cannot go by red glow in this. It is by the visual understanding that the depth of the trench. Generally, if you are able to reach the depth of the trench, the left instrument very easily, most of the times in soft cataract that is a inadequate trench. I don't know if you can take that message clearly. So I will show one technique of mine, mechanical chop. You can use it if you are not finding your trench and division to be very predictable, or if you want to go into chop for the soft cataract. So a background about this, most of the times when I started, now soft cataracts
This video is part of PhacoTips 3D teaching
NS1 to
course.
2 or NS2 grade cataracts. So most of the time I used to do trench and division, and which was going okay for all the cases. Then for NS3 grade cataract I shifted to primary chop. So I tried doing that technique in the soft cataracts also. But as most of the surgeons face that there was cheese wiring and problem. Other technique that we use, like if there is only PSC, then we use the carousal technique. Hydrodelineation is good, so we can get it. But sometimes we are not able to get a hydrodelineation even in NS1 grade cataract. And also the prolapse part, I was not very comfortable with that. Sometimes it used to prolapse back, or sometimes if the nucleus comes fully into the AC. So this technique I tried. It is not a unique technique, but it has worked for me on the way to graduating to full primary chop for soft cataract. So this cataract is NS1 to 2 grade cataract, and this is, I started the rexis. Again, as already emphasized, the rexis size should be at least 4.5, and if you want to prolapse, of course your CCC size needs to be at least 5 millimeter. So here the size is around 4.8 millimeter, and the technique that I am using is stop and chop, but in the chop I am using basically the high vacuum chop. Again, the hydrodissection part is very, very important. Don't get stuck with poor hydrodissection in a soft cataract. So you have to go into the periphery. Once you get the resistance, you have to maintain and get a good wave. And the nucleus should come up. The chamber should not deepen. And slightly I go for another hydrodissection. And if your rexis is slightly small, then always be very meticulous with the pushing down of the nucleus during the hydrodissection. Now, see this Sinski, it is two-ended, and it is small Sinski on the other side, one side, and this is the 1.5 mm Sinski, which we have started using from the last 1 year, and this has changed a lot of our technique, because even for soft cataract, it is very, very good instrument. So just see the technique. First, I do a trench. Deep trench, but I don't cross the center. The center part is the hardest part, even if it is NS1 grade cataract. Then I aspirate the epinucleus well, so that I know what is the nucleus part where I have to bury. Now in the center of the nucleus, I bury only with the high vacuum or very small power, and then the left instrument comes piercing. The left instrument movement has to be vertical and pierce it. It has to, like, it is a kind of a mechanical chop only, but with high vacuum. Again, I am showing this. I feel that removal of epinucleus so that you can see the nucleus clearly is very important, especially in the softer cataracts if you are trying to chop. Because that is the only resistance that you will get for holding. And for chopping, you have to use all the three senses. You are looking, of course, that then you are burying into the white part of the nucleus. You are hearing the sound of the occlusion, and the third sense is that feel. When you do a very slight pull of the nucleus, it is not very obvious. You will not see that you are pulling into the anterior chamber, but you will feel that you are holding it well, and then your left instrument has to work. Most of the times, if you are not able to even feel that hold, then the left instrument doesn't work that well, and it might be that you are burying in the epinucleus. Now the quadrant removal is simple. Even if you get 2 or 3 pieces in this, it is now easy to now aspirate and do the quadrant removal. It is mostly with vacuum and very low power. But I will like to emphasize the use of this 1.5 Sinskey in the chopping for the soft cataract. After this, the case is the cortex removal is routine. Other change is the hydroimplantation of the lens. I would like to emphasize, especially for the people who are using bimanual for the cortex removal, because removal of the visco with bimanual takes lot of time. So if you can learn, it is not a very high skill technique if you are using only one or two types of lenses. So with the irrigation in the left instrument, we form the chamber, and then ensure that the first haptic goes into the bag. That now you see the irrigation is very high in the Centurion, so the lens is rotating, so the irrigation is reduced, and then we go with the aspiration and push it like in the normal lens insertion on the left side, downwards and centrally. Don't try to rotate, push it downwards and centrally from the left side. Also wash the visco which I was put while putting the lens, while loading the lens. Otherwise that can also increase the IOP next day. Another point that I would like to emphasize in this is the hydration of the incisions after the case. So a lot of times we have seen that the surgeons struggle with the hydration of the incisions after the case, even if the incision is well made. So the incision has to be hydrated, the outer part. And other thing is, while coming out, don't press on the wound, because otherwise whatever you are putting and this zipping motion, many surgeons do not use this, so this has to be done. And while doing any of the hydration, try not to press on the wound. Your hand should be well rested on the forehead so that your cannula is stable as such in the air also. Because if you go in, hydrate, and while coming out you press on the lower lip, all the fluid comes out, and then you keep on hydrating multiple times. So try to be conscious with this for few cases, and then it becomes a reflex. I'll show a few more videos to emphasize that mechanical high vacuum chop part. Especially I think the surgeons who use longitudinal machines, they can try this, because they might have learned trench and divide, but these machines are meant mainly for chopping. So again, after a good CCC and hydrodissection, 1.5 mm Sinskey on the left instrument, then a trench only till the center, then aspirate the epinucleus well, especially in the front where you want to bury, and you can see the wall and the nucleus, and see the left instrument, it is not going like a horizontal chop but slightly in front of it and like piercing it. Actually you have to mechanically pierce it, so it is kind of mechanical chop but using the high vacuum. The vacuum is 450. Sometimes if you get are not able to bury, but you might get only a partial chop, but the left instrument is very useful instrument in this, because it mechanically also breaks it down. So you can aspirate whatever broken pieces are there, and then you can aspirate the epinucleus. In this grade of cataract, even if you get two good pieces, then rest of the thing is easy. Rest of the aspiration, the quadrant removal is also mainly vacuum based with little power whenever the nucleus piece is encountered. I'll show another case also to emphasize the same technique. Another similar grade of cataract. So basically, another messages from this is standardize your technique. for APSC, this is the technique I'm going to follow, NS1 or NS1 to 2, this is the thing I'm going to follow. Then you refine your technique and then you become more predictable. Once in a while, of course, you have to change things. So again, short trench only till the center, don't cross the center. That is the hardest part, where you have the opportunity to hold, and then the left instrument. And left, this 1.5 Sinsky also helps in rotation actually, because you can engage into the nucleus. Sometimes beginners find it difficult to rotate because the cheese wire with the left instrument while rotating the nucleus. So it holds the nucleus from the nuclear part and not from the epinucleus if you keep it vertical. So here this piece was not there, but still if you are able to get 2 or 3 pieces, just go with the well separated piece first, and then rest of the pieces you can just aspirate. This technique can also work if your CCC is not above 5 mm. Okay, now this is the case where I got slightly stuck. Now you notice again the grade of cataract. Here it is soft cortical cataract, hardly any nuclear part. So these cataract, they don't have any nuclear material, so it is difficult to chop. So half trench. But there is hardly any nucleus in this soft cortical cataract, and also they are like a kind of sticky and gummy by nature. So you should expect this kind of thing to happen, where I try to chop. Also there is pooling, so you tend to get distracted by that, and you feel where we are actually holding the nucleus. So I thought I'll do a trench on the other side. But it was a deep socket, and the trench is not insufficient. So it might be one of the common scenarios in deep socket with deep chamber and cortical cataract. So anyway, in this case, I was able to get a chop on the other side, where I had a wall basically of the nucleus. So in the same technique, I was able to get a high vacuum chop. Otherwise, the technique that I would have used is either a trench and divide or a viscor prolapse of one side. One important point that I want to stress is the appropriate power while chopping. You can keep even 0 power if it is NS1 to 2 cataract, or if you feel it is NS1, it has some nuclear power, you can keep 10 to 20 grade power. For NS2, I generally keep 30 power, and for NS3, 50 power, and above that 70 power. But I use a balance tip, so you'll have to modify the power according to your machine. And I use purely longitudinal power. Most of the time for NS1 to 2, we don't require any power. It is only high vacuum chop. So if you standardize your technique, like for NS1 to 2, I'll do this technique, but you should have a fallback technique to rescue you. And if you have the basically the SOP of your cataract, like for generally for PSC, this is the type I will be doing. NS1 to 2, this will I will be doing. NS3, this mostly I will be doing this. But of course, you have to be flexible. If something comes in front of you, you have to change accordingly. But do a standardized technique. I feel that improves your outcomes. Any question?
Ma'am, this question is for you. Dr. Agarwal sir is asking about the safety of air bubble to form the anterior chamber at the end of the surgery.
We already mentioned that we want the chamber to be fluid tight, not air tight, because the air will be lost in one day or so. So if the actually your tunnel is not good, there will be leakage of the fluid from outside to inside, and it increases the risk of endophthalmitis. So you have to ensure that the chamber is fluid tight.
when you do a mechanical chop, whether this vacuum is on panel mode or linear mode?
For chop, I keep it on panel mode.
Ma'am, your suggestions for pre-chopper, like Akoshi pre-chopper in soft cataract?
Actually, Dr. Saurabh tried once, but we didn't find it very useful in our cases. And this is actually different from mechanical chop, because here I am using the foot pedal, I am using the high vacuum. It's not purely mechanical chop.
Since you are using a high vacuum in a soft cataract, is there a risk of suddenly punching through, and how to avoid that?
Yeah, that's what I told, that you don't cross the center of the nucleus. The center is the part where you have some part of the nucleus, and there also you can keep the power 0, no issues. You can keep the vacuum to 350 also, that is not an issue. But I feel slight vacuum helps in holding, and unlike in mechanical chop, it doesn't just brittle off everywhere.
Okay, because you're using 450, I think.
Yeah, but you can keep slightly.
Is it?
It's mainly the left instrument also. The 1.5 Sinsky and the vacuum which is breaking the nucleus.
So what I gather from this is that every individual will develop his or her own technique. So here what she is doing is, after making the half trench which is short of the center of the nucleus, basically that front wall is being used for applying suction. So it's like a suction cup. So the PhacoTip is being used, so it holds on to that part of the wall and then uses the chopper to break the nucleus. So it is like a suction cup. So where it has to be gentle, that means you should not use any phaco energy to break it. Just apply it. So that's what she was saying, that once you have that feeling of hold over the nucleus, you can chop it easily.
Do you take age of the patient into consideration for the softer cataracts? Because NS122 in a 65-year-old and NS122 in a 45-year-old is completely different. It's better to do carousel in younger patients. But getting carousel in a 65-year-old is a little difficult.
Yeah.
But if the patient is 45-year-old, similar looking cataract, carousel is easier there. And it's difficult to chop like this in a 45-year-old, even if the cataract looks similar. Yeah,
So
aging related nuclear changes won't be there.
So I think the carousel works better where you can get a good hydrodelineation and then you can see a small nucleus is there. So there I think the carousel works very well.
Ma'am, in your videos you do hydrodissection and delineation both, or only hydrodissection in soft cataract?
If you are able to get a small hydrodelineation ring which is smaller than your rexes, then there is a point of carousel. If you are doing a 4.8 rexes and you are getting a very big hydrodelineation ring, then you might not be able to prolapse that endonucleus outside.
No, not for prolapse or carousel. I was asking in your all the cases
No,
you have
doing,
shown direct
delineation
chop, you do delineation or not?
No. If I am doing carousel, then I do delineation.
Many times what I have experienced that in this direct chop, while we beginner surgeons, we end up making extra efforts and extra pressure on the bag, and it can lead to sometimes zonular dialysis and show.
No, here the hold is, everything is in the probe. You're holding the nucleus away from the bag. You're not pushing against the nucleus in the bag. That in any nucleus, if you push, you use the bag to do the chopping, then of course that is causing the breakage of the zonules.
So in the afternoon session, now you have seen these 3D videos, right? So you have now sensed how the nucleus is being, pulled or not being pushed. In the afternoon session, we have a video like what you are saying, okay? We'll show that beginner's mistakes where nucleus gets pushed during the same maneuver. So, the technique is same, but how you approach as an experienced surgeon is slightly different, okay? So, we'll keep this point in mind, and when that video comes, we'll, again go back to this and see it, okay, how it is different.
And sir, in softer cataract, if we do hydrodissection and delineation both, and then if we do the proper trenching and divide the nucleus into two parts, and if that half part, if we are able to crack it it's okay. If not, then the whole half part we can grab and eat it up. So that will be also the safer technique, or it will be a good, or we should try the direct chop.
So I think grade 1 or 2 cataracts, where these cataracts, what we are talking about is I think between grade 0 and 1, where the trench divide is also a bit difficult. Where you get a good trench and you can divide it, I think that is the easier technique to follow. So each cataract is slightly different.
Yes, sir. So in high myopes, in my experience, I have faced that in high myopes or in a softer cataract, if we give 2 minutes extra in the starting, if we do a good hydro dissection and delineation, and if we rotate the nucleus both the ways, clockwise and anti-clockwise, then the whole the nucleus is separated, and then we can do easily a good crack also, and we can eat it up. Then the whole cortex remains, and then we can eat that in the epinucleus mode. So like a normal cataract.
Yeah. So there are many techniques, and if I do 100 cases, maybe in 98 cases I may not have any issues, and those are the cases which we are not showing at all. So we are showing the cases where we may have troubles, so you can get it out. So because each case is different, we might be doing few things differently. The tissues might be behaving little differently. So based on this, you don't assume that all cases behave like that. There are 98 cases behind this which behave properly, and like you said, it's very easy to take it out. We are talking about that 1 or 2 cases where you are stuck, basically. Okay.
So we have
with that,
a question.
we'll move on to the next video. After that, we'll take this. So the idea of showing many videos in 3D is also understanding what goes in a 3-dimensional way, in the sense that many times we think about anterior chamber stability and other things, but how it actually looks. So this is a posterior polar cataract, 45-year-old, and you can see there is a pre-existing dehiscence of the posterior capsule, and you can also see the fishtail sign. You can see those opacities in the vitreous, in the anterior vitreous. This is described by Dr. Daljit Singh, and on OCT as well, there was a complete dehiscence of the posterior capsule. Now, Dr. Deepak will be delivering next talk on the basics of posterior polar cataract. What are the basics? The most important thing is to maintain the anatomy as far as possible all throughout the procedure. Okay, so first thing what I am targeting is around 4.8 to 5 mm rhexis here. The idea for this size is basically so that you can do a good optic capture in case there is a dehiscent PC, and here the posterior capsule is already open. So I want a capsule rhexis where I can do a good optic capture and have a center IOL in the post-op period. So I am using Haldipurkar forceps here, and I am using Hylucoat as a OVD. So as we were mentioning yesterday, I will just show, you have to always hold this tear nearer to the capsule rhexis margin, tear margin. So unlike the center of triangle rule with capsule rhexis forceps, you have to always hold at the end of the tear. And now I am doing mechanical dissection. So I am using a simple iris repositor, a thin one, and from one side port I have made so this dissection is basically between the capsule and the anterior cortex. So it should not be going into the cortex, but it should tent up the anterior capsule a bit and then move it around all 360 degree from both sides. So what this does is that it helps little bit when you are removing the epinucleus. In the posterior polar cataract, I think removal of epinucleus is one of the toughest part. So now once I have completed the mechanical hydrodetection, I am going to do just watch, the tip goes in the nucleus matter, and then again in hydrodelineation, make sure that you don't increase the intralenticular pressure. So sometimes what happens, you get this kind of hydrodelineation ring, you become overzealous and try to do multiple rings. So don't do that in case of a posterior polar cataract, because increased intralenticular pressure is also not good for the posterior capsule. Now here I am doing a surgery in a case where posterior capsule is already open. So I have kept IOP of 30 here, and So there are different techniques which we can use here. He is a 45 to 48-year-old man, I think. So he has a slight amount of nucleus sclerosis, not very soft. If it is very soft, you can just aspirate it out layer by layer, very easy. But here there is slight amount of nucleus sclerosis. So I am going to do my technique. I call it sideways trenching technique. So first trench is made deep, and then I make cross trenches. So it is like divide and conquer, but without changing the or without rotating the nucleus. And then I am just separating it very carefully, these pieces. So I separate it more in the periphery rather than in the center, because center part might be attached to that plaque. And then I am going to start aspirating. Again, very low power I am going to use. And the idea is to pull out these pieces. So already we have separated the epinucleus. We are pulling out these pieces into the center and then aspirating. So once you have good hydrodelineation, this part becomes not so difficult, and you can just pull out these pieces away from the epinucleus and aspirate it. Always do OVD BSS exchange. I think that yesterday also we talked about it. So now I am trying to pull out some epinucleus, but it's always difficult with the phaco probe. So I tried to just separate and just see whether it is already separate. Sometimes, like now in this case I am not expecting that, but sometimes in type 1 PPCs you may actually have completely separate epinucleus by this time. Now watch the OVD BSS exchange. Momentarily before I or once I start injecting OVD, this is 2% HPMC I am injecting. The moment I start injecting OVD, I stop the irrigation, and that's the trick, so that the AC always remains firm. Did you appreciate that AC didn't collapse and AC didn't deepen? Okay, that's the idea. If you continue the irrigation while you are injecting OVD, invariably the OVD gets washed out and you will have shallowing of the anterior chamber. Okay, so now here what I should have done is viscodissection, but I thought that the epinucleus might be little free, so I can take out with my coaxial IA. So first thing I am going to approach is the subincial one, because that is the toughest part of the epinucleus, and I am trying to gradually separate it from the capsule. Now in most cases we are able to do that quite easily if you have done good mechanical dissection, but in this case you can see that it's not coming very easily. I am trying to aspirate the cortex around it. One of the key points which I have realized is that just like we showed in the soft cataract, even for posterior polar cataract, viscodissection is really useful. But I think the timing of viscodissection is also important. Now here what I am trying to do is I feel that with my coaxial I can aspirate out this entire epinucleus. So I am trying to do that. But many times, like in this area, what I am doing by coaxial eye is actually I am chipping off their anterior part of the cortex a lot. And once you chip off the anterior part of the epinucleus, the viscodissection becomes little difficult, because you don't have proper place or have a cover under which you can push visco. Now here I decided that I will do some viscodissection, because the removal of the epinucleus has become tedious. And believe me, doing a posterior polar cataract is a not a very fast job. It's a very slow process. Now here I made a mistake. I did a viscodissection, but using 1.1% hyaluronate, which is a cohesive agent. Okay, I thought that I can use a small gauge cannula here, so I can go under this epinucleus and then push. So I was able to achieve some viscodissection there. You can see the epinucleus starts coming off. But as I said, here I realized that using cohesive OVD is not a great idea for doing viscodissection, because you will just find out after I do this viscodissection, the moment I go in with IA probe, okay, the cohesive viscoelastic just gets aspirated and again epinucleus will fall back. Okay, so here I am trying to remove this epinucleus, and you can see that the epinucleus again falls back, because this cohesive OVD gets aspirated much faster. So the take home is that always use a dispersive agent for doing viscodissection. You need a lot of patience while dealing with these cataracts, because you have to always make sure that you don't do some, very violent movements in the anterior chamber. So as I was showing that with cohesive OVD, if you do viscodissection, the epinucleus is now back to the same position here. Now, in this moment, I realized that I can take out this subincisional epinucleus. I got the cleavage there, and as I pulled it out, okay, now this is the moment where when the central plaque is going to get separated. That's the moment when, now in this case there is already PC which is open, but where PC is not open, that is the moment when actually the PC dehiscence can be appreciated. And we have to try to make sure that PC, if it is going to be dehiscent, becomes dehiscent as late as possible, so you can take out all parts of lens matter before that, so it becomes easier. So here you can see the epinucleus is now separated from the posterior capsule. It has come anterior, which you can appreciate here now. And I realized that this is now like a big epinuclear sheet, as we were discussing earlier, and it might be little difficult using the coaxial IA cannula to take it out. Now here we discussed about using bimanual and going with hydration below the epinucleus, but here because the PC is already open, I was in two minds what I should do. So again, now I did the viscodissection using a dispersive OVD, which is 2% HPMC, and with that I could pull up this epinucleus away from the posterior capsule. Now here I thought that rather than using coaxial IA, I will use a phaco probe which has a larger surface, but with 0 power, and I have reduced the vacuum to just 200 and even flow rate to 20. So I need a very stable chamber, but I need a bigger bore so that I can just aspirate out this epinucleus. Now you can see there is already an open PC. Now you will be able to see that under this epinucleus, which we were seeing earlier also, that along the edges of this posterior PPC plaque, the posterior capsule was already open. Okay, you can see that triangular shape on the left side, which is showing the open posterior capsule. So here I realized that posterior capsule is now open, the anterior hyaloid is intact, so I want to be careful here while aspirating the remaining part of the epinucleus. So I decided that I will rather put visco and try to remove this using some other method. So here I am trying to just remove it while infusing the viscoelastic so that the anterior chamber is better maintained. Okay, so I could take out this part. Okay. So now I have stopped the irrigation. I am going to inject OVD here to maintain the chamber. Now here the basic idea is not to allow this PC rupture to go till the periphery, because then I will not be able to implant the IOL in the back. So now here goes the Hylu coat. This is to protect the posterior capsule, which is already open. And now I will remove this remaining small piece of epinucleus. First piece I will just use the Sinski to nudge it out from the bag very carefully, because of course before putting IOL I need this out of the bag. So this one comes off, and then there is always a good technique to use dry aspiration in this case, as we discussed yesterday as well. So I am going to use some, I have just used OVD to just push it out, this free part of the epinucleus. And remaining epinucleus which is there in the bag, I will just try to remove it using the dry aspiration. Now in this case I have given a subtenon block to the patient. So here again I am teasing out the epinucleus from the bag using the blunt iris repositor here. Patience is required in these cases, and the surgeries are usually little longer than your usual cases. So now I am going with the aspiration cannula of the bimanual, and I am going to do the aspiration, dry aspiration. As Dr. Deepak was mentioning earlier, when you are doing dry aspiration, you have to make sure that you always maintain the chamber by injecting viscoelastic repeatedly. And trick here is also to apply the aspiration at the proper place. So don't start aspirating when you are in the middle of the anterior chamber, but start aspirating when you are physically proximity, in the physical proximity of that epinucleus, so that you grab the epinucleus without removing any of the OVD there. So once the bag is clear of all other remnants, now the question comes how I should be putting this IOL. So one option is that I can convert this tear. Now just watch here. Okay, this is just the last part of the. Now you have that horizontal tear of the posterior capsule. Anterior hyaluronic is intact. So one of the option here can be converting this tear into a capsulorhexis, a PCCC. But this tear is big enough. It's almost the size of the capsulorhexis. So I was little worried if I try to convert into a capsulorhexis, whether it will be too big, and then putting the IOL in the bag might become difficult. Here I am just checking whether there is any vitreous there or not. But of course there is no vitreous here. So now just yesterday I think we discussed about this technique. When you are injecting the IOL, I think I skipped the part. I enlarged the incision little bit there. And I am going to put Alcon VVT lens in this case, and just watch how I put it. So my left hand Sinski is there to guide this lens. So I want to avoid any jerky IOL insertion directly into the bag. So that Sinski helps in regulating the movement of the IOL in the anterior chamber. Once this IOL opens up in the anterior chamber, the technique to be used here is by gently nudging this IOL into the bag without any torsional movements inside the bag. So I will be positioning this IOL first perpendicular to the already open capsule. You can see there is a 180 degree PC rupture is there. So I am going to put it in the anterior chamber in that orientation, and then gently with using Sinski I am pushing these haptics into the bag. So avoid putting the lens into the bag and then rotating it in the bag, because that will invariably enlarge this PC rent. So you have to be very careful, because if this PC rent enlarges, you have to explant the IOL obviously, but if it enlarges later, you may have even IOL drop. So you have to be very careful in maneuvering. I have kept it unedited because we need to know how I was maneuvering this IOL with a lot of care. And again, all throughout you can see that I had maintained the anterior chamber, never allowed it to collapse, never allowed it to become very deep. So again the second haptic. Okay. Now once you have placed the IOL in the bag, what we have to do now is removal of the visco. And this is the standard technique in these kind of scenarios that I use. Though we have another option that we can use Centurion with 20 millimeter pressure and just aspirate it out. But what I found that even while doing that, when we insert the probe and remove the probe, there is a shallowing which is involved. So rather than doing that, what I am going to do is I am just going to wash off this viscoelastic by using the BSS. So it may take a long time. It may take around 2-3 minutes further to wash off that visco from the anterior chamber, little bit from the bag. But what it helps us in doing is that you avoid any kind of extension of that posterior capsular rupture which is already there. So I think for all cases where the PC is ruptured or likely to extend further, and you have placed the IOL and you want to just remove the viscoelastic, I think this is the best technique. It will take 3-4 minutes more time, but you can wash off almost all of the OVD and without any deepening as well as shallowing of the anterior chamber. So that's important. The most important ingredient in doing this maneuver is patience. So that's what I was showing. So this is just the end of the case. I will just keep on washing it for 3-4 minutes. Okay. So this is the end of the surgery. You can see. Now you will see the pre-op, photograph, and that was thumb light off. And that was the pre-existing PC ruptured area. And you can see in the after you put the IOL, it is the same area, so it didn't enlarge. And I could remove the entire nucleus from the bag without any enlargement of this pre-existing PC rupture. Okay, you can start the lights now. So that's the end of it. So the idea of this video is to understand in a three-dimensional way what goes when we are operating. Many times when we are watching this particular video in 2D, you will not understand the nuances, how the anterior chamber is all throughout maintained, and that's what we wanted to convey with this video. Any questions there? And in the meanwhile, I will request Dr. Deepak to attach his laptop. So he gives a talk on his tips on PPC management. He has some excellent videos and tips that he will be sharing now. Any questions from the audience?
Hello, sir.
Yeah.
In PPC case, there is a role of the oval rexis.
Yes. So I think Dr. Deepak will cover that. So I have personally not used oval rexis that often, but I think he will talk about that in his talk as well.
I have one question.
Yeah.
So can we diagnose pre-operatively if the PC is intact in PPC?
Yes, yes.
And
so,
also,
Dr. Komal, can you show the PowerPoint presentation? It's there on this laptop.
While it is being set,
I think we'll show it in after Dr. Deepak's talk. We have some OCT pictures. No, I think it will take time to change again.
What Saurabh pointed out that you have to have a very thin cannula to do a visco dissection when you are using dispersive OVD. Okay, a few practical tips. So in India we have got 3 companies which make this viscoat mimics. Number 1 is Hylucoat, number 2 is Orocoat. Orocoat comes in 2 variants, Orocoat and Orocoat Plus. Number 3 is Appa, which makes Supracoat. Hylucoat and Supracoat, they come in a bulkier cannula. Orocoat comes in a thinner cannula, Orocoat Plus comes in a bulkier cannula, and Viscoat comes in a thinner cannula. So in this situation, if you want to use a thinner cannula, you have got 2 options, either to use Viscoat or use to get plain Orocoat. Okay, so remember this. So Orocoat also has 2 variants, Orocoat and Orocoat Plus. Orocoat has got a thinner cannula, so you can use that as a dispersive OVD. So this visco dissection using a dispersive OVD with chondroitin sulfate is specific only when you are dealing with a postipolar cataract. It does not necessarily mean for a regular epinucleus. For a regular epinucleus, you can very well go ahead and use your HPMC. That is fine.
Excuse me, sir. I have a question. First of all, thank you for showing the unedited video. I think it was really important for us to see the struggle of epinucleus removal because most of the videos show a very smooth kind of removal, but actually it proves quite difficult. One thing which I feel is not shown enough is the visco removal. So my question is that you inserted heavy dispersive OVD at the time of when you saw the rent, and most of that must have gone into the Berger space. So when you are just doing the irrigation to remove that viscoelastic, does all of it come out or does some of it stay inside? Because that dispersive, sometimes what I have seen is in a case of PC rent, it stays post-op and causes very high IOP. Patient may have vomiting and all that. So does it need to not be physically removed from behind the lens?
Yes, so probably I edited even further, but I washed it off as far as possible. Now all these OVDs, they are water soluble. All these OVDs. So if you even you take Hylucoat or Viscoat or methylcellulose, you put water in it, it becomes liquid. So same thing we are doing that. So the only main part is patience. So you have to patiently keep on pushing. The other way to do it, just go in with bimanual, like Dr. Deepak has videos where even with a PC rupture where anterior hyaloid is intact, you can go behind and wash out the visco. But I feel in this, like this case where patient wanted a, EDOF lens with the best, lens possible. If I rupture the, say, anterior capsule while doing irrigation behind the IOL with the regular cannula, it's a problem, I cannot keep the lens then inside the bag. So it's better to use this technique. Most of it, if you are patient enough, you can wash it off. That's the thing. But the
so
trick
just
is,
by irrigating it will get washed
yes,
off?
it will get dissolved, it takes little time because these are basically chemicals which are water soluble. So it will take time for it to dissolve slowly, and you need to be patient. If little bit is remaining, as you mentioned, yes, we have to control the IOP post-op. So for this patient also, after I removed the pad and bandage, I continued the patient on anti-glaucoma, though the IOP was okay for next 3-4 days. And generally, what I have seen is that 3 days are important for visco to be absorbed inside the eye. So the first 3 days you have to make sure the IOP is good. And generally these IOPs can be managed medically. I mean, I haven't seen any case where I have to again go in and remove this visco. So we can manage it.
Any experience with viscoat versus these Indian dispersives, whether they cause more rise in IOP or viscoat causes more rise in IOP? Anything like that? Any particular one which we should use in case of PC rent which may not cause a specifically high IOP?
No, all will. So it's like a chemical, So all of these are 3% and 4% combination, 3% chondroit and 4% halonate. But I think Hylucoat is more viscous. They have made more viscous. So probably it may be little difficult to remove also. Okay, as compared to viscoat, which is slightly less viscous. As he was saying, that viscoat we can inject through small gauge cannula, which you cannot do with Hylucoat because the viscosity is more. So more viscous may be difficult to remove. But I think during surgery, we want something which is difficult to remove to begin with, right? So I think it's both things we need, then we need more patience to just wash it off slowly.
Thank you.
But either way, Diamox immediate post-op and monitoring of IOP is mandatory. See, even if I go with the irrigation cannula, only irrigation is being done. There is no aspiration. Okay, very clear about it. So when I say go and remove the OVD, it's only the irrigating cannula. What he is doing is injecting with the cannula. I'm just using the Byman irrigation cannula to go, that's all. But there is no aspiration. Whatever you do, there is still some amount of visco which is going to be left there. It is going to cause raise in IOP. You have to deal with medically. But we have never faced a situation where we have to intervene surgically to reduce the pressure. That is the message here. Regarding difference between viscoat and the pressure difference will not happen. But sometimes our Indian variants might cause a little bit of inflammation. Sometimes, often, we don't know. But otherwise, the glaucoma part is not much of a difference.
Thank you.
Thank you, Zen. It was, I think, very important question. Yeah. Over to Dr. Deepak now.
Okay, I think, can we have my computer attached here, please?
2D.
2D.
Previously described.
So, this is the classification of the PPC which we have to understand. And luckily, most of our cases belong to the grade 1 and grade 2 variant, okay? The grade 3 variant is one which we have a very absent posterior capsule, the PA pre-existing. And as a routine now, what we are doing is most of us, we do a pre-operative OCT like this, and we can clearly see where the plaque is, whether the PC is continuous or not. We can trace the PC, in fact, whether it is continuous or not. So we have a pre-operative guidance like whether we're dealing with an open PC or not. So most of us have access to the anti-segment OCT now, so it is not a very difficult thing to do. Now coming to the basic principles of PPC, I think most of you would have seen my video on when less is more, wherein I demonstrated spontaneous rupture of PPC posterior capsule happening in eyes with the PPC. Because of raised infusion pressure. So, this is more common especially in the younger individuals and who have elastic sclera which can stretch because of a high posterior capsule. So we have these situations where, you just, because of raised pressure, as soon as you enter, you can see the posterior capsule rupturing. So what we realized over in our case series was that this is more common to occur in younger patients or patients who are myopic. The only simple reason was that, just let me go to that animation and before I start the case. So you can have these, all these are spontaneous ruptures of posterior capsule, and The link what we found in these situations was all of these patients were young and they were myopic. And in all these patients, the infusion pressure which I used at that time was on 90 centimeters, which was a routine for most of my cases. So the correlation between the scleral rigidity and the raised pressure is this combination is going to cause the posterior capsular tear. And this is what we see. In the same patient, slightly older, maybe 50 plus, we will not see. Low scleral rigidity is an important factor here.
Infusion pressure is the reason why the pathological posterior capsule split wide open. However, similar phenomenon of spontaneous PC rupture is relatively uncommon in eyes with normal scleral rigidity. But in eyes with low scleral rigidity, the sclera can stretch a little bit, which allows more fluid or OVD to accumulate in the eye, which eventually will raise the pressure inside the chamber. And the weak posterior capsule, it just gives way. Well, what can we do in such a...
So the basic principles we all know now, that we don't do hydrodissection, we operate in slightly low parameters. And now what else can we do now? That is what I'm going to speak now, what modifications which you have done in the last maybe couple of years back. So the one which is recently added is the use of oval rexus. And
Hi, this is Dr. Deepak.
so let me just take you through this. So we all understand this now.
In preventing the breaking of the posterior capsule. She is a 32-year-old lady who has this classical posterior polar cataract. It's present in both the eyes, and today I'm operating on the right eye. The surgery is being done under topical anesthesia. The patient is extremely cooperative and she's having good fixation to the microscope light. The two side port incisions are made. Intracameral anesthetic is placed into the eye under the air bubble, followed by using the trypan blue. Although there's a decent amount of red glow, I still prefer to have a trypan blue stay in the capsule because in certain tough situations it makes my life easier to identify the capsular margin. The chamber is filled with dispersive OVD. Care is taken not to overfill the chamber. I just want to keep the eyeball a little bit soft. The main incision is created, and at every stage of the surgery I want to ensure that the eye is never overinflated because I have realized that overinflation is one of the primary reasons why the incidence of PC tears happens, and it is much more common in younger patients. In this case, I am planning an oval rexus, which I learned from Dr. Kiranjit Singh from Amritsar. The advantage of oval rexus is that you got better access to the epinucleus, and especially in the subincisional area. And this is a step where most of the posterior capsular tear can happen when trying to remove the epinucleus. So just having this oval rexus gives better access and maneuverability to manage the epinucleus. That's the principle. So I'm going to have the longer diameter in the direction where I am sitting, that is temporally, and we have a smaller diameter in 90 degrees to it. So I got a decent sized oval rexus which is worked out pretty well as I'd expected. So as we all know, we're not going to do any hydrodissection. So I'm directly going in with my phaco probe and I'm trying to do a small trench here. So this is a soft cataract, so power settings are extremely less. I'm just using about 40% continuous ultrasound in torsional mode. I'm using the Infinity machine with very low flow rate and a vacuum. The bottle height is set at 50 centimeters, and the idea is to do the inside out delineation as has been taught by Dr. Basavada. This helps us to minimize accidental entry of the fluid into the subcapsular zone, which can increase the risk of PC tear. So the idea is to create a long trench, at least about 50 to 60% depth. Since this is a cataract, I'm hardly using any power. So I've designed a long thinned trench which is about 50 to 60% in depth, and now is the time to perform the inside out hydrodelineation. The hydrodissection cannula is pressed across the wall of the trench as it goes into the substance of the nucleus, and then carefully very small amount of fluid is injected into the substance of the nucleus from the lateral wall of the trench, and this provides us the golden ring, which is not very huge in this patient because she is very young. So we've got a very small endonucleus. I just try to repeat it on the other side. So we've got a sort of an endonucleus which is defined by this partly visualized golden ring. So now is the time to divide this soft endonucleus into two fragments. It's going to be difficult because the lens is very soft and gummy and it might not be easy for us to break it. So I'm just trying to go in with my phaco probe and the lens dialer, and let us see how things turn out. So it's not possible to divide. What I'm trying to do is, using just vacuum, no power, I'm just trying to tease out this endonucleus out of the bag. It's coming out in piecemeal, but nevertheless I'm able to maneuver the nucleus bit by bit out of the bag and into the antechamber. And now with my second instrument I'm trying to mobilize the soft lens matter out of the capsular bag. It's taking a while for me to maneuver it, but in these cases I think patient a great virtue to have. Finally I get the purchase, and some part of the endonucleus is maneuvered out and emulsified. The central plaque is still there. I don't want to mess with it. Maybe it's going to come along with this piece, and as I'm trying to remove this part of the heminucleus out of the bag, I can see that part of the plaque is already come along with it. At this stage I'm a little bit concerned that whether the PC is open now. So let me just aspirate this soft lens matter and let me visualize whether all is well or not. So I'm just changing the settings to the epinucleus mode now. I'm using an ultrasound energy of just 5% in longitudinal mode, and we have a flow rate about of 30 and a vacuum of about 350, and the bottle height is around 60 centimeters, and the epinucleus is out. And now I'm seeing this red ring here. This is actually a good sign. This, although looks like an opening in the posterior capsule, it is not. Now this is a pseudo hole. This is the ring is formed by the termination of all the cortical fiber there. In my experience, I noted that whenever we see this ring or pseudo hole, actually these are the eyes where the PC does not open up. So before coming out, the OVD is injected into the antechamber. So I'm using a dispersive OVD, which is an Oro coat, an Indian mimic of viscoat. The cannula is very thin, it goes inside and we can push it out easily. Now in this red glow we can clearly delineate the area of the what I call the pseudo hole, or this is the marking. And when we see this sign, actually the incidence of PC tear is relatively lesser in such polar cataracts. So now is the time for the cortex aspiration. The epinucleus thankfully has come along with the management of the nucleus itself. Even though I am in cortex aspiration, the bottle height still is lesser than what typically I use. So the bottle height is maybe around 70 centimeters now. Typically I'd be using around 100 centimeters. The flow rate of the vacuum are also reduced a little bit so the chamber stability is not compromised. So slowly but steadily I am going to aspirate each of these cortical fibers out, and actually in younger patients it's not so difficult. So the one part of the bag is cleared off the cortex. Before switching the hands, again I'm going to use OVD to maintain the chamber. The hands are switched. Then the aspiration of the remaining cortex in the second half of the quadrant is completed. Few tiny opacities are there in the posterior capsule in the central visual axis itself. I'm using a little bit of fluid to just flush them out. I'm extremely scared and reluctant to go and do any sort of polishing to this posterior capsule because of obvious reasons. So just leave those specks there itself. I'm deepening the capsular bag by using OVD. Time to implant the lens. The originally planned single piece hydrophobic lens is being manipulated into the bag. Of course, in all these eyes always have a backup of a multi-piece lens to be placed in the sulcus with optic capture in the eventuality of a posterior capsule tear. And thankfully in this case there is none, and I want to orient the haptics into the meridian where the diameter of the rhexis is smaller. so that the haptics are getting nicely and snugly fit into the fornices of the capsular bag. The OVD both in front and behind the lens is aspirated out.
As you can see, it's just the irrigation cannula which is gone inside
The anti-capsule is
to
polished a
remove
little
the
bit.
OVD.
So things are looking all right.
So I think I'll
In
just
these
stop.
young
I'll just show
patients, the
you
sclera
another
will
video.
be
And so this was about 1.5 years back, which I was doing like this, and now I've changed it now. So it has made things are becoming much more easier now. So nowadays I've shifted to using an AC maintainer. Maybe I'll just show you AC maintainer along with an oval rexis now. So that is a new addition which I have done here. And so just let me take you through this again. Young patient. This patient again, this is a type 2 variant which did not have any posterior tear. She's a 42-year-old lady. Again, we are going to do an oval rexis. So it is doing an oval rexis is something it's like unlearning thing. We're so obsessed with performing an extremely round rexis, and now we have to learn this new oval rexis. But see, the most complications happen during polar cataract removal during the epinucleus removal. That is a subincisional epinucleus removal. So the only advantage it provides is that the access to the subincisional epinucleus is is easier when you do this oval rexis. This is a technique which I learned from Dr. Arup Chakravarti many years back, using a blunt iris spatula to just do the mechanical separation of the cortex from this thing. So you're going to use through both the side ports and just cleave the attachments between the antercapsule and the cortex. So as Saurabh was telling, the only thing we should have for this skill is patience. You need to be very, very patient in dealing with these cases. It's going to take a long time, so you need to be patient. So the philosophy of using the iris maintainer is, the only secret I was telling managing this is that you want to have the chamber, not lose the chamber at any stage. So AC maintainer was something which I have never used in my life, and for this scenario for the last 1 year I have begun using this, and we have a case series of about 35-40 cases now. We are presenting this in the ESRCS, and the results have been quite very good actually. So what it takes away is our ability to, you have to always be ready with your left hand to push in the OVD. So that that skill, extra skill which is required is taken off, because the maintenance of the chamber is just taken care by the antechamber at all. So you don't have to bother about it. Just see this. So the principles are same. You've done an oval rexis. I do a long thin trench, and so just note, when I come out, I don't have to go in and replenish the OVD as I was doing with the previous cases. So I'm just trying to widen this peripheral part just a bit so that I can maneuver one heminucleus out of the bag very easily. So I try to divide this into 2 halves and then pull each of the half out of the bag. And in this case, I have not done an hydrodelineation as well, as you can see. So just using vacuum to abut against it and then pull it. So basically, you just have to do a couple of attempts and the nucleus comes out, one of the epinucleus, and you don't have to panic here. Like, if it doesn't come, eventually it's going to come, because, and obviously we are not doing any nucleus rotation. I'm just trying to maneuver this heminucleus out into a more accessible area and then emulsify. So again, as I come out, I don't have to replenish the OVD at all. So there is absolutely nothing. And in this case, with the AC maintainer, I'm going on with my typical bimanual I&A. And if the epinucleus was thick, it's not there in this case, I would have used the visco dissection as I would have done in other cases as well. So it is really, magical the way things happen here. You don't have to be so panicky about the AC shallowing at any stage, every stage. And this is really, I feel, is a game changer in this thing. You can see that, whenever I don't have to bother about filling the antechamber at all. Only critical thing you have to do is ensure that you're not overinflating the chamber. So when I'm putting the lens, what I do is I off the AC maintainer here, and I'm just negotiating the lens into the bag. And again, before for removing the OVD as it is, the AC maintainer is on now. And once the OVD is removed, the AC maintainer then comes out. So this is something new which I've been doing for the last 1 year. So I've done maybe about some 45 cases now. And what I realized is a relatively inexperienced surgeon can manage things well, even by using this device. So what happens if you have a pre-existing PC tear? So let me just show you. This is a recently operated case. About say a month back, I've operated this case. He's a 15-year-old boy, and he presented with 18-year-old boy, sorry. So he has, what is striking feature is, obviously the cataract is white here, but what we can tell is, look at the anterior chamber depth. It is so, it is unusually deep. So when you have an unusually deep chamber, and there was a history of trauma, which he says, I'm not convinced about that, but look at this, it looks like a posterior lenticonus. Actually, if you look at this, it looks like a posterior lenticonus, but without even doing an OCT, you can clearly know that, this patient probably has a pre-existing PC tear. I also had as a similar postipolar cataract, but the PC was intact. Another clue is always when you do an A scan, look at the AC depth here. Okay, the lens thickness, the interchamber depth usually is anything above 3.5. You should be suspicious, especially when a clinical picture is obvious like this. So again, you're going to stain the capsule, and in this patient, I've given a peribulbar block and massaged the eye gently, and then this is Hylocoat which I've used now. So again, the same principle. In this case, the plan is to use a multi-piece lens. So when you're doing an oval rhexis, what is tricky is the shorter span should be should be 5 millimeter at least. Should not be more than 5 millimeter. That is the trick here. And in younger patients, because the capsule is elastic, sometimes controlling it can be a challenge. But ideally, when you have this thing, again, you're not going to do any hydrodissection here. I'm just using the same flat spatula very gently, just try to do it. This step might not be necessary in this young patient because the adhesion is quite easy to aspirate this lens matter in these young patients. Now again, in patient, again I plan to use the AC maintainer. So putting the AC maintainer, I had a learning curve. It is you have to learn how to put it. So it is not a very difficult thing to do, but it can cause few side effects and potential complications, so one needs to be aware of it. So the bottle height of both the AC maintainer and your Phaco Phaco infusion, all is maintained at 30. Whenever I come out, you can see I don't go and infuse any OVD inside. So once the epinucleus is out, I'm just trying to aspirate using the thing. At this stage, I realize that the anterior hyaloid might not be intact because I can see this thing. You can see a fiber here, strand here, which is there at the level of the posterior capsule. It is not above it. So my ability to aspirate the cortex is still not affected. It is not affecting the flow or the aspiration. You can see this is the area where the vitreous fiber is still seen. So I'm just trying to confirm, whether it is there before I would want to go ahead and do it. So since I realize that it is still not in the vicinity of the rhexis margin or the cortex, I just do it. This is your vitreous fiber. So now obviously you need to do a vitrectomy here. And looking at the margin of the posterior capsule, it looks like it's slightly thickened and looks like it has been there for some time. The sad part of this is, this is the vitrectomy part which I'm doing here. And so look at the corneal folds. When you're getting the corneal folds, it indicates that you are not overinflated. But also you should not get it. It should be like, appearance should be good. So now we know that the vitreous is cleared off, but the sad part is the tear extension is a little bit too much for me to consider doing a posterior capsular rhexis or trying to implant the lens into the bag here. So another tip, I just like to pause here. You saw me extending the incision here. So that is another important thing. Just let me share with you, because when you have a soft eye, we don't want to, this is what extension which I was doing. We don't want to struggle by putting it, because in a soft eye, especially in a child, I would say in a young boy, the sclera is very elastic, very difficult to negotiate your cartridges through this thing. You always have to have, for a 2.8 incision, probably I've extended to 3.2 so that I can negotiate my cartridge easily. At this point, I prefer to keep my AC maintainer off, and the OVD which I've used now to create space is a sodium hyaluronate. There's a cohesive OVD under the iris. So I don't have to place the haptic on the iris and then negotiate it. Directly the space is created and usually maintained well enough. So directly I put it. So at this stage I'm considering whether should I do an optic capture using the push it beyond beyond the posterior capsule as well. So I thought I'll do that here, and as you can see, I'm trying to push the optic beyond the posterior capsule. And retrospect, I realized I don't know whether it was the right thing to do, because you can see the PC tear enlarges there. But nevertheless, it is engaging well in that block, and this is how it was. And then later on, you just remove the OVD, and finally, the AC maintainer comes off. And when you come out, you can see that I'm keeping the irrigation on so that I don't have a shallowing of the chamber. And this was the end of the case. So this is something which I'm doing, and I found it very helpful. And so we are presenting this in this thing, and it's quite promising.
Yeah, so excellent talk. I think a lot of questions have been already answered, I think, through the talk. We'll just show a few cases of posterior polar cataract. I think online also somebody asked about the 2D page. So somebody asked about whether we can pre-diagnose, these dehiscent capsule. So I think anterior segment OCT is excellent tool. And Dr. Deepak already showed in his talk about the 4 types of PPC. And surprisingly, when we started doing these OCT scans, we realized that most of our cases where clinically we diagnose as PPC, they turned out to be type 1 PPC. And type 1 PPC, believe me, there is a very, very, very low risk of PCR, almost similar to a regular case. So this is the type 1 PPC where you can trace the entire posterior capsule all throughout. So generally it looks like PPC, but I feel it is more of a PSC cataract. So this is another case of type 1 PPC. You can see the entire posterior capsule is easily seen throughout. Now this is type 2 PPC where the central part of the PC is not clearly visible. So these are the cases where there is small risk of PCR and you should take more precautions. Again, type 2 PPC, there was no PCR on table, but you can see on OCT that the PC cannot be traced completely. Now this was the type 3 PPC, and the same case I showed, and where there was already a dehiscent posterior capsule. You can see the margins of the posterior capsule are already dehiscent, and on OCT, the multiple scan, you can also see some particles in the anterior vitreous as well. Again, this was labeled as type 3 PPC because the PC appears dehiscent, but again, when we see it carefully, it is more of type 2 and type 3, in between the two, and in this case also there was a PCR which was there. So when you have type when you have type 1 PPC, I think you can just go ahead with your regular surgery. I will show it next case, how generally nowadays we deal with type 1 PPC. I wanted to share a video which was shared by Dr. Amit So he wanted to show a couple of interesting 2D paige. So it is his case. I think he is there. Yeah. So again a PPC case, and he finished the case with intact PC. ते बंद करता का ते? Yeah. And I think at the end of it, he just came out without replenishing the OVD, and in a happy mode, he is just loading his IOL. And while he was not watching the eye, this is happening under the camera. This is like Big Boss, you know. He is still loading the IOL. And this was, I think, contributed by Dr. Kishore Mahajan. Amit, you got the mic? Amit? Mic. So, another case. Just watch, everything is over. Case of PPC. Just hydrating the incision and see. So I think during the hydration of the incision, the AC become more deep.
Yeah, infusion pressure, no? Infusion pressure is raised, and so. Always tell yourself, picture abhi baki hai mere dost. You never know, PC tear can happen even when you close the eye. Okay?
I think we'll move on to the next video, which is on the yeah. 3D ka 3D. After dealing with the PPC, I think what we'll be showing in the next couple of
this video is
surgery
part of
is you know, again we saw a lot of videos on PC rupture, but now we'll be thinking whether we can prevent the PC rupture in, you know, cases that we are getting it. So this is again a soft cortical cataract, toric IOL, Rayner EMB toric is being planned. So I use these single bevel blades, use Hylucode for doing the anterior CCC, and using forceps here. Just watch how the forceps is being used. At the center, we create a tear horizontally, and then we lift it up from the edge of the tear. Idea is to have at least 5 mm central rhexis using the Purkinje image as the center. And as you go ahead, 1 second, any problem online? Audio ekda baga jara online tha. Okay, so we go ahead and we finish off the rhexis. Now goes the hydro dissection. Always decompress the anterior chamber before you do good hydro. Go to the periphery, push fluid. The moment you feel little resistance, I think that is the moment you should push little bit more fluid so that you get the fluid wave. Okay, once that is done, I will start with my phaco. Nowadays I generally use 36 IOP on my machine. So the first part, this is, you can see that grade 1 to 2 cataract is there. So first part is the removal of the epinucleus, make a deep trench. Yesterday we saw the hand movements, the way we do it, and I am just showing the horizontal position of the long Sinski, 1.5 mm Sinski, which I use for chopping these softer grade of cataracts, which really helps because it has better surface, larger surface area to hold on to these soft. Again, the horizontal, that chopper is placed horizontally into the deep groove, so easy to crack. So easily cracked into 4 quadrants. And once that is done, I am going to start the quadrant removal. I use bevel sideways, approach the anterior part of the quadrant here, pull the piece in the center, and then I'll be using full vacuum and aspiration rate. So generally the flow rate I use is 45 when I'm using 36 IOP. And as you can see, the vacuum I have set on linear mode, but the vacuum starts from 200 and goes up to 500. Now I am approaching the last piece here. Always important to rotate these pieces in front of the phaco probe. That provides better fluidics when you are emulsifying these pieces. And I just want to show you here. So I generally shift my retro illumination on for the last piece because I want to see this posterior capsule. And you can watch that there was some amount of fluctuation. I will just want to show it again here. Okay, so just watch carefully as I move on to the last piece. And this is, I think, a good thing to do. Shift to retro, watch the PC, how it is doing. And here you can see the PC is coming anteriorly as I took out that piece. So there was still one more piece which was there in the bag. So here I decided to replenish this AC with the viscoelastic before I take out this piece, because I found those PC fluctuations when I was taking out that last piece. And I'm using Sinski to just pull this piece out of that bag from the equator. Many times when you use heavier dispersive OVDs, you tend to have these pieces stuck sometimes in the angles or sometimes in the bag. And now watch, with the same parameters, you find that there are no AC fluctuations. Okay, so previously with the same parameter for the previous piece, the PC was coming up, and now it's not coming up. So I definitely feel that before you inject, you remove the, with the same setting, you can see, you can appreciate that the PC was coming up and there was risk that PhacoTip would have touched it at this point, and same settings were used later after I injected OVD. Can you appreciate this? Yeah, the PC is coming up. So, and with the same setting, I didn't see any change in the, I found that the PC was quite safe away and the AC was deep with the same setting. So I think the OVD injection before the last piece definitely helps in these kind of cases where you check or you detect these kind of PC fluctuation. And you will not find this in all cases, mind you. So I think back to the previous question, you might feel that this happens in each and every case. This doesn't happen. But in cases where you find this, you should take adequate precautions. Either you inject OVD or you change your parameters and make the surgery safer. Cortex removal is routine. So now I will be injecting the IOL. Light off. Light off, please. And again, in these cases where the PC is fluctuant, you have to be very careful in removing the cortex as well, because these are basically kind of redundant posterior capsules. And one of the common reasons for having these kind of PC is that the anterior hyaloid is already separated in these cases. The posterior capsule is now cleaned up. Switch off the lights, please, of the hall. I'll be injecting the IOL. It's a preloaded IOL, very easy to use. Just inject some OVD. I use generally 1% hyaluronate. Just close that cartridge. And then so this can go through even 2.2 incision. So always in all the IOLs, the first haptic should be going towards the left side. So you have proper orientation. Okay, always keep in mind the first haptic goes to your left and the trailing haptic is pushed in. Now with the markerless system, I am just aligning this. For toric IOLs, I think visco wash is something which is very, very critical, and you have to wash off visco from the bag as well. So hydroimplantation is useful for those who are used to it. Also using hyaluronate. So I generally use hyaluronate, that is a cohesive OVD for injecting these IOLs, so that the washing off of hyaluronate is very, very easy and it's complete, unlike a dispersive OVD. So any visco left in the bag will lead to rotation of the IOL. I think in the afternoon we have a very good session with Dr. Deepak about toric IOLs. We'll look into it further. So that's the end of the case. So from this video, basically I wanted to show how you should be always, curious, or you should be more observant as you are going towards the last piece. And with this, we'll start with the next case, which is another very interesting
This
case.
video is part of PhacoTips 3D teaching course.
Similar case, you can see. Soft cataract, cortical one. I think the first part is same, so I will just pass it. Now I am doing hydrodissection, and you see that instead of hydrodissection, I have done hydrodelineation. Watch it again. So instead of lifting up the capsule, I went by mistake into the nucleus and I created a golden ring, indicating that I have done a hydrodelineation there. And when I rotated, it was rotating. So I think that is one of the mistakes for soft cataracts, particularly if you do hydrodelineation, but you don't do proper hydrodissection, sometimes it creates problem, and we'll see what problems it might create. Now dealing with the nucleus, again, removal of the anterior epinucleus there. You can see that when I rotate, actually it is only the nucleus which is moving and the epinucleus is separate. So I go in with the regular trench and divide it. Alright. So we'll move on to the quadrant removal part. Okay, so I am now removing the quadrants, and I want you to watch very carefully. Did you notice anything? Okay. So I have made a posterior capsular rupture there. Okay, just we'll watch it again in slow motion. Watch the quadrant removal being done. And as I mentioned, just watch on the posterior capsule all the time. Okay, watch the posterior capsule very carefully. You realize at this point that the PC is actually coming up. Okay, you can see the shallowing of the anterior chamber, and still I continued to do that and the PC touched. Okay, so if you see the time that I almost had 6 seconds when I realized that the PC is coming up and I should do something for that, but I continued while emulsifying the last piece, and there it touched the posterior capsule. And caused the PC rend. So both cases kind of similar. Both cases gave me clues that PC is unstable, it's coming anteriorly. In the first case, the previous case, now here I still continue to remove the epinucleus thinking that hyaloid is intact, so I can remove it. But then I stopped and then I managed the PCR now. So I will just show the management of PCR now. But I think the similarities between two cases is that when we start doing quadrant removal, the posterior capsule will always give us an indication where the PC is going to stay back or it's fluctuating and coming anteriorly. So this is what we are doing is cortex removal by bimanual. So I am using irrigation in this case, as we were discussing yesterday, whether we can use that or use do the dry aspiration. So here, because the anterior hyaloid appeared intact, I decided to use low irrigation and remove the cortex. It's always faster than doing the dry aspiration, but you can see because of use of irrigation, the PC rent area is definitely more fluctuating and the chance of anterior rupture is more. So I continued to do that in the area of PC rupture, and this is the mistake that I should have avoided, because when you go nearer to this area of PCR, we have to be very careful and you might pull out vitreous in that area. So I think that part you have to be little careful. Maybe doing dry aspiration in that area is better. But as it happened, I removed the cortex. With that, I pulled probably a little fiber of the vitreous there. Now yesterday I think we were discussing about converting it into posterior capsulorhexis. So whether we should do it before doing antivitrectomy or afterwards. So here I was just checking whether there is any vitreous or not. So using Sinskey sometimes is useful for checking that. And here I think I used the same technique which Dr. Deepak showed, where I went below the posterior capsule. I think Dr. Deepak, this is what you did.
Yeah.
I will just show it again.
So when you go first, the bevel should be down, facing towards the optic disc.
We'll just see it again. Yeah, so the bevel should be down, okay, towards the retina. Yeah, and go. You can see I have gone through the PC rupture area.
And stay there for a little bit longer.
Okay.
Okay. So now immediately you turn. Stay a little
yes,
bit.
Yes.
A couple of minutes longer there.
Correct.
After that, move it a little bit and then turn sideways. Then last anterior.
Okay. So I think you saw it how it is to be done in 3D, because the depth you can now see that I have gone through the PC rupture area, and that is the reason why I could maintain the size of the PC rupture area there. But in this case, you would have done antivitrectomy, or you would have directly converted to?
In this case, I would have pushed up OVD, did the rexis first, because the vitreous hadn't really prolapsed much.
Yes.
You could have pushed it back. Because
So,
you see, the way the capsule feels with the forceps now after doing vitrectomy is different.
Yeah, different.
If you see, wrinkling will happen now.
Correct.
And the way tear is much more difficult now.
Yes. So we'll see. Also, you have to also understand which hand to use. For example, here I tried to use, this is the tear margin there, and I tried to use the right hand, and I was not able to grab it properly. So I think in these cases, being able to use the other hand also helps a lot, because you can approach the area. Now you cannot choose where you are causing the PC rent, so you have to use sometimes the other hand. Grab it, and it's quite easy. Just make sure that you don't enlarge it even further. That's the key. So once PCCC is done, I think we have shown it multiple times. The Dr. Deepak just showed it. So I will just show that 3-piece IOL has been injected in the sulcus, and I am doing now irrigation aspiration. So here, because there is a posterior capsular axis, now I am not worried about its extension. So I can use the regular bottle light. You can see I am using 50 IOP here, and just do all the visco wash. I have already done good antivitrectomy. And once I do the good visco wash, I will be tapping this IOL down so that there is a good optic capture. So tap one side at a time, it's preferable. So you put less pressure on the zonules. And if after doing the optic capture, make sure that the anterior chamber is maintained. One more thing is that if anterior chamber becomes shallow after doing the capture, sometimes it may come off. And if it comes off from only one side, you may have a IOL tilt in the post-op period. So if you are doing optic capture, make sure that it's captured on both sides. So if it is captured only on one side, you may have a refractive cylinder post-op. So at the end of it, always make sure that the AC is nicely formed, and at the same time, the capture is still maintained. Okay, so that's the end of it. So just putting some diluted triamcinolone to make sure that there are no strands, vitreous strands in the anterior chamber. Okay. So I think we'll discuss about these two. Can you switch on the lights? Are there any questions? Yeah, so you are asking about why the IOL was not put in the bag. Yeah.
So is the other case which you're doing with VVT, because here also you had converted it to a PCC.
So actually this patient had opted for the same IOL, that is the 3-piece IOL, which has to be implanted. So one option I had was putting the 3-piece IOL in the bag. Yeah. But I am generally not very comfortable when there is a PC rupture to put a 3-piece IOL in the bag, because 3-piece IOL in the bag usually stretches the bag further. So when you have stretch on the PC, that is something, though I would say I would have been able to do that in this case also. But because I already had 3-piece IOL and I had done a good, nice central rexis where I could do the optic capture, I decided to put it with the optic capture. But if I had a single piece IOL in this case, I would have put in the bag. The reason was that I was just, bit cautious, because when we put 3-piece IOL in the bag, it stretches the PC. You must have seen that when you put 3-piece IOL in the bag, you will have those stretch lines on the PC, which is not usually seen with the single piece hydrophobic IOLs. Yeah, next concept. Quiz. Yeah. So after this, there is a quiz. Yeah.
Sir,
Yes.
it is always better to decrease vacuum when remaining last piece
Yes.
each and every surgery.
Yes, we can do that. So that's why I think one thing I would like to again emphasize is that the cases which we are showing are not in those say 95-97% cases where we may still have very nice deep anterior chamber for the same parameters. We are showing cases where there are PC fluctuations we should be able to pick up so that we change the parameters or maybe use viscoelastic. I think changing parameters, reducing the parameters is a better idea in this case. Or you can have a set.
So,
You can have a set parameter for the last piece, like the epinucleus mode, where you have a lower parameters.
So I have a question. One, when you make the oval rexes, where exactly at the margin do we hold? And while using a AC maintainer, like you showed in your case, while doing the IA, does it remain on the AC maintainer?
Yeah.
And doing the case in IA or continuous, would that make a difference in chamber stability with an ACM, or it wouldn't matter?
No, I&A, when you're doing bimanual I&A, AC maintainer is on.
Okay.
It's on. The first question was,
oval
where do you
rexes.
hold?
Yeah.
The rexes, you have to do the same way as you're doing. Only the shape you're doing is, instead of round, you're doing oval. Okay? There's not much of a change.
Yeah.
So we have one question. So is there any advantage of doing a PCCC if 3-piece IL has to be implanted in sulcus?
No, there is no advantage. So here, when I did PCCC, I had not thought of which IL I am going to implant. But if I had a 3-piece, single-piece IL in this particular case, that was the advantage. But yes, if I wanted to just put, but I think one advantage is that once you have a PCCC, you can do the irrigation aspiration of the visco much more freely, because you are not have any problems of extension of that PCR. But yes, no advantage. If you are just putting 3-piece IL, no need to try to convert it into PCCC, and you can just put the 3-piece IL.
Sir? So yeah.
Yeah.
So what are your thoughts on suturing the wounds in case of compromised PC?
Compromised PC, yes.
Yes.
So the cases which I showed, one case which I showed was done on topical anesthesia. And at the end of it, when I checked, the wound was watertight. There was no leak, so I didn't suture it. But wherever we have blocked the patient, because after block, post-operatively, it takes little bit of time to start the topical medication. Also, post-operatively, there will be some amount of hypotony which goes unnoticed. So in such cases, it's always better to suture the incision.
So one more question. So case you showed of PPC, there was a vertical rent, and you put in the lens perpendicular to it.
Yes.
The forces acting on the rent, when we are putting the lens, it will there are chances it will expand stretch the rent if it is vertical. Sorry, it is perpendicular to the rent. Ideally, we want the lens to be perpendicular to the rent. It is fine. But while putting in the lens, the forces will be exactly perpendicular to the rent. So, the chance of extending would be more. So
I first placed the lens in the anterior chamber, not in the back. And then I rotated in the anterior chamber perpendicular to the rent, and then I pushed it into the back. So the rotation was done in the anterior chamber, not in the back. That is right. What you are saying is right. If it is in the back, if we rotate, it's going to extend. Correct.
I had a question. Hello?
Yes, go ahead.
Yeah,
Yeah, ma'am.
I wanted to ask Dr. Megor about when he used the AC maintainer, and if there is a rent, does that cause hydration of the vitreous?
Yeah, madam, the second case which I showed,
Hanji.
it just exemplifies that even if the AC maintain the pre-existing PC tear with vitreous already disturbed, it was there.
Right.
It doesn't cause money.
Doesn't cause, no? So it's very good.
It is, yeah. The
That was
concept which we are thinking that, if fluid always goes and hydrates and all.
Not there.
The fluctuation of the chamber is far more detrimental to the thing rather than a stable anterior chamber, even with the fluid on. That is the message here.
Correct. And
so what we're so much obsessed that, fluid goes in, fluid hydrates. No.
Nothing. So it's very safe.
So the fluctuation of the chamber is far more detrimental than, either the fluid going in or coming out. That's what it is.
Is the position of the bevel important?
Yeah. So I'm learning, ma'am. So what I have realized, the best position is the bevel has to be facing the angle.
Correct, correct.
The bevel has to be facing the angle. So when you're putting it inside, ensure that the last screw which you're turning, ensure that the bevel is facing the angle.
Correct.
So there are a lot of little bit learning curve in there. You cause a Desmond detachment. Don't ensure that the fluid is on before the entire bevel is gone inside.
Correct.
Ensure that it is not too big or too small. It has to be the blade and the incision and this thing has to be titrated appropriately.
So, which gauge MVR did you use and which AC maintainer? I have never used, that's why I'm asking.
Yeah, so I have tried couple of AC maintainers. We have two variants, one with the screw variant, one without the screw variant.
Okay.
The one which I am now currently happy is the one with the screw variant by the Pricon company. It is 23G.
Okay.
And for this, the Alcon side port, which is slightly smaller, Alcon MVR side port is there. Which is
Right.
slightly smaller than our regular MVR blade. So that is matches.
Gives a good fit.
Good fit.
Okay, sir.
And
Thank you.
one thing we have to understand about the hydration of vitreous. See, the concept came mainly for elderly individuals having cataract. So in those cases, if you have AC maintainer and you have a PC rupture, it will definitely hydrate. Hydrate in the sense, these patients may have liquefied vitreous and these patients may already have some amount of vitreous detachment. Now in those cases, if you go in with the vitrectomy probe and irrigation, you will always find that you cut more and more vitreous. In PPC, we are dealing with younger patients where the vitreous is more formed, where this hydration concept usually doesn't see. Like we do many congenital cataracts where we do anti-vitrectomy and PCCC and all. There is hardly any hydration. In fact, it's more solid and gel. So you have to actually go in and cut. It will not come to the cutter.
I guess even the flow has to be slow.
Slow,
so
yeah.
that
I think he used a 50 centimeter bottle light for that. 42, so
Okay,
very
sir.
low bottle light.
Thank you.
So it's
Thank
like trickling, I think, just
Yes.
fluid is.
Just to maintain, you're not gushing inside anything,
Correct,
it's
correct.
just doing the
Okay.
environment of being calm is inside.
Okay. Thank you, sir.
You
It's
have to
continue, no
continue.
problem. Nothing happens. You continue, the bottle light is low, and you go in with your regular bimanual vitrectomy, and you can do it. No problem.
Regarding the AC maintenance is asked now, you can use this vitrectomy trocar cannulas also as the
Yes,
AC
same principle what you are using. This is the same principle.
Good morning, one and all. I am Dr. Komal. I'll be asking you questions here in the form of quiz. These are not one-liners, so you have to answer in a stepwise manner and elaborately. I'll be showing video clips of short video clips. Watch it carefully. So this is the first question. In this case, there is young myope undergoing cataract surgery, soft cataract grade 0 to 1, and under topical anesthesia. Watch this video. Now with the hydro dissection, the nucleus has been prolapsed. Now the plan is to just go and emulsify the nucleus. Now see what happens. Okay, now as soon as the surgeon enters in the AC, the pupil is over dilated and the patient is feeling discomfort. Okay, now the nucleus is back in the bag. So here the question is, why did nucleus went back in the bag and there was discomfort in this patient? What do you do to relieve that discomfort? You can just raise your hand to answer.
Hello, this is called as LIDARS, lens iris diaphragm retropulsion syndrome. Whenever we are dealing with the high myope patient, never ever enter with the irrigation on. Just put some visco inside the entry chamber. You just go with the irrigation off. Whenever you are entering, just with the side port, lift little bit of the iris and then you on the irrigation flow. That's why never this lens iris diaphragm get posteriorly displaced and the patient is getting pain because of this lens iris retropulsion. So if you lift up the iris with the second instrument and then you on the irrigation, this type of things will never happen.
Anyone else? Why did that nucleus went back in the bag? You can watch the video again. I think just in first two videos, sir explained that how to approach a prolapsed nucleus. Just you can answer that.
Instead of holding the rim, the surgeon is trying to go into the nucleus part of the cataract. If he would have tried to catch the rim of the nucleus, probably it would have come out.
Yes, that's the right answer. So whenever there is prolapsed nucleus, try to approach it from the prolapsed part, the peripheral part. If you go and attempt the middle portion, it will tend to go back in the back. And the first part question was, yes, it is lens iris diaphragm retropulsion syndrome. In a case, this was myope patient, so with low scleral rigidity, it causes more of a reverse pupillary block. So I think the second part was what you will do to relieve that. If anyone else can answer that. Any manual? Okay, there are chocolates for the whoever has answered. I think Dr. Aniket sir will get one chocolate. And one more chocolate for sir. Dr. Amit sir. So in the next video, I'll just show what we can do to relieve that. So with the just Sinski, lift up the iris and you can see that the discomfort is released and the AC is formed. And this is how we have to approach prolapsed nucleus. Just go and try to trim the peripheral part. Yeah, then the entire nucleus will get in the AC and you can aspirate it. Now we will move on to a next question. Here is a beginner surgeon, has finished trenching. Now there are pieces in the bag and just shifted to the quadrant removal mode. And just you can watch carefully what he is trying to do. He is just trying to take out the pieces out of the bag. Watch the settings also. Okay, now this piece is not coming. Surgeon decided to rotate the nucleus and attempt the quadrant removal in next piece. I think this is the most common struggle whenever a surgeon has completed like 50-70 cases and now doing the cases independently. So you can answer here. There can be multiple answers for this. Why there is struggle to take the first piece?
Because he is not holding in the central thick part, he's just trying to catch in the peripheral, which is the thin part.
Okay, someone else?
The pieces are not cut properly. The posterior plate might not be cut properly.
Yes, sir, that's actually the right answer. Here the pieces are not very well separated, and the surgeon is trying to aspirate it, take the first piece. And there can be other situations where your tip is blocked and there is no sufficient vacuum, your piece may not come. And there can be other situations where the attempt to take the piece is in the right position, that is in the upper 1/3 and lower 2/3 portion. If you go to the central part, maybe it won't prolapse in the AC. That's the right answer. The sir will get the chocolate. Your name, sir? Thank you, sir. Now, Dr. Deepak Megho, sir, will continue.
So this will be like, we are involved in a lot of training for younger colleagues and fellows and all. So one of the most common problem which we encounter as trainers is the younger people, colleagues, they really fail to identify the PCR early. So I want you to pay attention to the conversation which is going on between the OT assistant and our fellow as the surgery is happening here. Just this is the most common thing which happens there, It's just please pay attention to the conversation there. I think the audio is not on here.
Optical fiber है ना वो? नहीं है ना? नहीं. Optical fiber है ना वो?
So the surgeon is always denial and the assistant is encouraging him. The surgeon is telling rent nahi hai na, cortical fiber hai. Yeah, cortical fiber hai. See just. So this is actually the rent and the both of them, the assistant and the surgeon, have missed it. So now it's very easy to diagnose the background with the PCR at the background of a red glow. Now, thanks to the technology of the stereocoaxial retroillumination, it's a game changer for us, because we can really diagnose a PCR early enough. Especially this is again a trainee who is doing her third or fourth case. She's so obsessed with just removing the cortex, SICS. You can see the PC tear is already happened. She is not bothered. She's still going on and trying to remove the cortex here. So what you could see is first there is a posterior capsular tear happens, and then the anterior rupture happens, and then there is vitreous. Actually, there's a lot of time available for us to stop and prevent the anterior from rupturing. But the problem is we delay the diagnosis. So I think as a beginner, we should be very well aware how a posterior capsule tear actually looks like. If you have a very good microscope and your eye is very keen to detect, in fact, you can detect posterior capsular tear and anterior haloid, both are different entities. So as you can see there, many times you can see there are two rings which we can actually see here. So this is actually the PC tear here. There is one more ring which is appearing. This is the anterior haloid rupture. Another you can see here, this is the, on my right hand bottom here, you have a PC rupture is different and an anterior haloid rupture is different. So it is very easy for us to detect it in good retroillumination which we have nowadays. The first thing is to train our mind to identify how a posterior capsular tear looks like, So it is better to be slightly overcautious. And even looking at the shape of the posterior capsular tear, they tell a lot of stories, okay? If you look at this, the tear here, if you can see, the two wings of the tear, the two edges of the tear are not splayed, okay? Similarly, you look at the bottom one on the left side, look at this tear, it is looking straight, okay? What this indicates is that it is not being pushed apart. So this can happen if the vitreous is prolapsing out. It can really splay wide open the posterior capsular tears. Now look at this portion. This is the central, this is quite a round looking thing. But if you look at the edges, they are slightly splayed. Now it is an indication that probably the vitreous has already prolapsed out. So these are subtle signs which can really tell us that, whether the anterior is still intact or not, looking at the configuration of the posterior capsular tear. So just open our eyes and have a close look at it. Well, this is relatively easy to diagnose it against, red glow, because this happens during posterior cortex aspiration. But the real challenge is, how do you diagnose posterior capsular tear when there is an overlying nucleus? So the only thing which we can rely on is, the change in the dimensions of the antechamber. There's a fluctuation in the depth of the chamber. So this is very, very subtle, and this is, they can be varied. Now here in this case, it was a very gross deepening the chamber. When this happens, be rest assured that the anterior halide also is ruptured now. Okay, when this much of a deepening has happened, so the vitreous is already disturbed. You have to be sure that you just have to somehow manage to retrieve the nucleus back at this stage, because even before you can see the posterior capsular tear, the way the chamber behaved surely suggests that the anterior halide is also ruptured. Here, this is much more subtler way of knowing that the chamber fluctuation was there. So whenever you are having a slightest doubt in these opaque cataracts, it's better to resort, convert and remove the nucleus manually. Okay. Now in this case, you can see there is a gross change in dimensions. Obviously, the posterior capsule is ruptured, the vitreous is ruptured. Here you can see the again. Please note the chamber, way the chamber behaves here. There is a sudden shallowing and then there is a deepening. You created a hole. So here let me just replay it. There are two parts to it here, okay? First you created a hole and then you continued. When you created a hole, there was just only a posterior capsular tear here, okay? At this stage, there is only a posterior capsular tear. And if you are detected and probably changed, you continued and then you have ruptured the anterior hyaloid and the antivitreous is already disturbed. So you don't have to go to this stage to really diagnose a posterior capsular tear. So the moment you have a suspicion, just go ahead and inject OVD, make the chamber stable, and then reassess the situation. So the mistake here was there is a hole created, and then you continued with the phaco, then you're going to rupture the anterior hyaloid. So second clue, the first was the change in the chamber depth. That is one clue. The second is always when the anterior hyaloid is not ruptured or the vitreous is not prolapsed out, or even in the anterior hyaloid is ruptured and the vitreous is not jelly, it is very fluid or degenerative type. That time you may not see this sudden fluctuation in the chamber. Okay, so one clue would be one of the fragments could be at a deeper plane. Just have a close look here. You can see that one of the fragments, it is not very evident. You have to be very alert to these subtle changes. So one of the fragments is slightly at a deeper plane here, and it has disappeared now. So you can realize. So again, you can see there is a soft epinucleus which is just vanishes down. These are all subtle signs which clearly say that there is a thing. Then obviously the second would be when the nucleus tilts. The phaco is not started. You have just done a rhexis. I'm just trying to check the mobility of the nucleus. Now I'm going with the phaco probe and try to remove the epinucleus, and the nucleus now starts to tilt. This is another situation where the nucleus is, you're finding it difficult. The nucleus is not rotating very easily. This is a mature cataract. This had to come out very easily. Then again, you have to be very suspicious. Here, I'm trying to chop the nucleus. Let us see what happens here. The left-hand nucleus appears slightly to be at a deeper plane. The chop looked all right, but now the nucleus is slightly tilted. It looks like it is slightly at a deeper plane. So this was an opaque cataract. We don't know what was the pre-existing state of the nucleus. And as I remove the first piece, it becomes very evident that this piece is definitely at a lower level than the other heminucleus. So there is no reason for it to be at a lower level. So this should be, an ominous sign for you that something is wrong here. Okay? So in this situation, just believe that, there's something wrong and convert. This is, this is not a very good sign to rely on, because what does poor fallibility indicates is that you have already delayed your diagnosis until the vitreous is prolapsed. Why there is a poor fallibility? It is because the vitreous is clogging it. So your diagnosis of the PC tear is so much delayed. You're already trying to hold it. It's not getting hold because there is a posterior capsular tear happen, and you can see there is you can see a small ring which is appearing. And as we were discussing in the morning, PC tear can happen at any stage of the surgery. Now this happens during OVD injection in a piece, just because of excessive infusion pressure, the posterior capsule just gives way right in front of your eyes. So, and this is another very unusual sign which I can say, you're just trying to irrigate, and the pressure builds up, and suddenly you can see that the pupil snap is happening here. And this is not even happen. This is even before you're putting in. Now this is rhexis which has gone radial. These are the eyes wherein the rhexis can propagate across the equator down to the posterior capsule, and we can see we have a posterior capsular tear in the same eye where the rhexis had enlarged and it has gone out to the equator. When you're trying to do a lateral separation maneuver in a dense cataract, this is when you can cause a posterior capsular tear. But again, these are very, very difficult for us to diagnose during the surgery, but this is something which always you can go back and analyze retrospectively. But lateral separation maneuvers in a dense cataract, struggling to break the posterior plate, can cause a posterior capsular tear. Now here, the trainee surgeon is trying to hold the nucleus and pull it out of the bag. But the power which was used was more than what was required, and you can see there is a hole which is created now. But the surgeon has not yet realized that it is at a posterior plane. And this is the hole which is created now. At this stage, there is no chamber fluctuation or anything, but you only realize later on that the posterior capsule is broken in this situation. You can see there is a posterior capsule tear which has happened now. So this was the same case which we saw in the beginning of the case, where the surgeon was in denial mode that the posterior capsule had broken. So this is again, this is the reason why the PC tear is happening, because the probe is at a deeper plane. The probe is in the capsular bag. You're trying to engage the fragment, and this is where you're going to cause a through and through perforation of the nucleus, and then you're going to cause a PC tear. So this is where it happens. So you're not realized that it is at a deeper plane. So this is because you have to just use a little power to levitate it up rather than trying to do it more. So it can happen at every stage of surgery, and you can see that there's still 3 more fragments are there and the capsule is broken. So scleral tunnel and viscoexpression is being done here now. So the probe is again at a deeper plane than what it had to be. It is trying to go in and search for that nuclear fragment. Okay, this is quite common, and this is very avoidable, I should say, by most. So again, you can see the posterior capsular tear which is happened here, and so diagnosing these is much more simpler because you have got a contrast which is available for you to do it. You can diagnose it because there is a clear-cut contrast ring appearing there. And you can see there at this point, let me pause and show. Look at the posterior capsular tear shape, and also look at the vitreous fiber which is clinging onto your pair. So here already, apart from your PC tear, you already ruptured the posterior capsular. See the anterior haloid also. So again, you shouldn't come out, you go ahead and put in visco OVD and then come out. I think these are all similar cases. So let us go back and try to analyze something very interesting now. So let us go to the first situation. So this is the first case which was started now, okay? So what happens now? So they're discussing now whether the PC tear is there or not. So they have come to a conclusion, the surgeon and the assistant, that PC tear is not there, it's just a cortex fiber. They put in OVD, they try to do the cortex removal, okay? So because the chamber is now become deeper, sometimes the tear is not visible. But you can clearly see, let my arrow here, I think I hopefully can show it here. This is the arrow where, this is the demarcation line of the posterior capsular tear which is happening. But you know, mind you, there is, the fluid is going on in full flow and still the aspiration is being done very well. There doesn't seem to be any vitreous disturbance still. There's something to, very wonder about us. So there is nothing, the chamber is collapsing now, still nothing happens. And they're going to switch the hand and again go back. One clue is probably look at this shape of the PC tear here on the right hand side here. That is the one which is now creating suspicion. ये क्या है? The assistant is already loading the lens now. They're ready with the lens now. They're thinking now, and still now the cortex aspiration is still happening here. So we're discussing now with the posterior capsule open, the fluid going in. In this case, you can still see the vitreous has not appeared here. Okay. So at this time, I receive a phone call that something is suspicious. Now, before putting the lens, they just send me a call, and now I have to go in and then venture it. So this is a point of discussion, as I think Dr. Neha was discussing. What happens when we put in fluid there? You could see the entire cortex. They did not diagnose the PC tear until now, and the fluid was there. And for their luck, the anterior-hyaloid was still intact here. The concept of, where the anterior-hyaloid ruptures, where it doesn't rupture, and this is something which I just like to share, where we all do some of the mistakes which we have, and
I think Deepak, you should have asked them to continue without calling you. I think she could have put the lens in the bag nicely, and it would have stayed like that.
Okay. So some of the common mistakes which we do during posterior capsular tear management, I'll share with you.
And this is a mature white cataract with a hard nucleus. The last two pieces are to be emulsified. There is a faint line visible posterior to the fragment, and this was suspicious. Now I am left with just the last piece, but the underlying PC tear is staring at me. In my head, I am thinking I can emulsify this nucleus and there is no need to come out. At the same time, I am trying to understand the morphology of the tear. The edge of the tear on my left seems to be having irregular edges, while the right edge has a straight border. But both the ends of the tear look to have extended up to the equator. At this stage, I am not sure whether the anterior vitreous phase is intact or not. Now, looking at the irregular edge of the PC tear on the left, I thought maybe the anterior is still intact, but the real action happens now. So please don't blink. So did you see? It was like a bomb blast, except for the sound. So let me replay it. The phaco piece comes out and the AC shallows. Now, as the AC shallows, we can see a ring appearing. Now this is the anti-hyaloid rupture happening and the vitreous prolapsing out. This was a costly mistake. If I had not allowed the antechamber to shallow and if I had injected dispersive OD before coming out, the anterior hyaloid rupture and the vitreous prolapse could have been prevented.
I assumed that the anterior was ruptured looking at the configuration of the left margin of the posterior capsular tear, which was incorrect. The rule of not allowing the chamber to shallow while withdrawing the infusion should always be followed. It is sacrosanct. So the moral of the story, the secret is in the chamber. Bimanual anterivitrectomy is performed. And a multi-piece hydrophobic IOL is placed with both the haptics in the sulcus and the optic pushed back behind the rhexis to achieve the optic capture. The second case, again please don't blink. I'm trying to hydropolish, there is a positive pressure, the patient moves his eyes just a bit and then this happens. Well, did you see what happened? Let me replay that. There's a small posterior capsular tear to begin with and then it enlarges, and after a second or two there's another ring developing. This is the anterior rupture and the vitreous prolapsing out.
See, actually, what I wanted to show here was there is a lot of opportunity for us to minimize the complications or to minimize the damage which you could have done. If I detected it in a fraction of a second earlier, I could have stopped. The anterior rupture could have been prevented. But what I did was I continued to irrigate. There is hardly any, speck of PC fiber or something. I don't know why, what I was doing, God only knows. So I was just trying to irrigate and the eye just moved a little bit. In a fraction of 2 seconds or fraction of maybe 1 second, you can see the PC tear happens and then also the anterior rupture happens.
So this case teaches us that posterior capsular tear and the anterior rupture are two independent entities. If we are alert, we can prevent the rupture of the anterior hyaloid in spite of having a PC tear. The only critical aspect is very early diagnosis of the PC tear. Now this is a case of a posterior polar cataract. The posterior capsule is broken, but the chamber is never allowed to shallow. The eye is constantly replenished with OVD and the anterior rupture could be prevented.
So just look at the, the shape of the posterior capsular tear. Again, it gives a
IOL could
clue.
be successfully placed in the bag. This is another case of a traumatic cataract with a pre-existing posterior capsular tear but an intact hyaloid. By injecting dispersive OVD before removing the irrigation, the chamber is never allowed to shallow. Anterior rupture could be prevented and the IOL again could be placed in the bag. To conclude, posterior capsular tear and anterior rupture are two independent entities. We can prevent the anterior rupture. The secret is in the antechamber. Maintaining the chamber equilibrium always is critical. Sudden deepening and shallowing of the chamber should be avoided. This is possible by using low infusion and low parameters. Use of dispersive OVD is critical. It acts like a barrier and it might prevent the forceful entry of fluid which could end up rupturing the anterior hyaloid. Thank you.
Lights on. So thank you, Dr. Deepak. After seeing so much of vitreous, I think we all need some coffee break. So we'll have a tea break. I think to conclude this particular session, and we started with the same message that we have to maintain the anterior chamber all throughout a surgery. And I think we are ending with the same, that always maintain the chamber. So after the tea break, we'll start. Tea break will be there till 11:45 for 15 minutes, and then we'll again start the session.
First video is on rookie mistakes. As you know, we have trainees who are doing the surgeries. So the purpose of this session is not to make any fun or to shame any technique, but it is just to make aware to ourselves that we have to learn from the mistakes that we do. Means there is a saying that failure is a stepping stone to success. But is that true? Means you make a PC rent, so you should will you be more aware or more of the pattern recognition next time? So we would like to modify it to failure plus reflection and analysis will lead to success. So here in this video I will be showing three surgeons rather. The first surgeon has done almost 200 cases, and in the first case there is some difference. There is a trainer sitting along with the trainee, and he is guiding the trainee. And in the second case, the surgeon is around 100 to 120 cases experience, and the third surgeon is more than 1000 cases experience. So we will see the complications are occurring in all three cases, so we will try to analyze the psychology behind it. Volume.
This video is part of PhacoTips 3D teaching course.
So this is the first case. Here the trainer is along with the trainee. Initially in the beginning there was microscope focusing is an issue, so the trainer told the trainee to focus and center it properly. Also notice the left instrument is pressing more on the left side, which causes the visco to leak, and the right sided instrument is also pressing on the side port, so that the visco is leaking every time. And the trainee is trying to fold the flap from very close part, so that the CCC is difficult to do, and also it is trying to extend outside, not holding in the center of triangle. So after the trainer tells, the trainee improves and is able to complete the rexis. For the hydro was not fully complete, although there was a wave, but there was no anterior movement. The surgeon tried to rotate, and you can notice that while rotation there is again pressure on the side port. There is movement at the wrist, as we told yesterday. But of course the hydrodissection itself is inadequate. So the surgeon repeats the hydrodissection, this time with the forward movement of the nucleus, suggesting it is a better hydrodissection, and now the nucleus rotated. Now, one step has been removed in this, where the surgeon has done a good trench and has divided the center. Now the surgeon is attempting chopping. Now keep a watch also on the phaco power. The surgeon is note the depth, very superficial, and the power, not giving any power but trying to mechanically bury into the nucleus by pushing. So nucleus is getting pushed. There is power is set up to 40, but the surgeon is not giving any power, and so there is only pushing. It's a grade 2 to 3 cataract. So the trainer is now telling the surgeon to give the power to hold it better. So the surgeon is able to give power and then bury. Now let us see, after the first mistake, does the surgeon learn from the mistake? Whenever there is any air bubble above it, you better aspirate it so that your view is better. Now the surgeon gives power, buries it, and then chops. Here, the surgeon buries with power, holds it, and then chops. Also, notice the movement of the left instrument. It is again 1.5 mm Sinski. It is coming from opposite side and is piercing into the nucleus, causing the assist to the hold. Now, next case is a surgeon who has around 100 to 120 cases of experience. Let's see what are the mistakes that he does. So it's a soft cortical cataract, we have already mentioned. These are kind of gummy cataracts. Now, now the surgeon has stained, and now he is trying to wash the dye. Now there is overfilling, and so the iris has come out. The concept of inflow and outflow has to be understood. Now once this mistake was done, now the surgeon has tried to put visco inside the chamber to start with the capsulorhexis. But again, because the first mistake was not analyzed, again there is overfilling, and now the already floppy iris again prolapses out. So now the surgeon decompresses and pushes the iris inside. After this, the capsulorhexis was uneventful, but notice the hydrodissection. In 3-dimensional, you can notice the chamber is becoming deep. So the fluid is not going behind, it is rather going in the anterior chamber. The chamber is not becoming shallow, and the hydrodissection was inadequate. Now notice the attempts of rotation. It's too much non-physiological forceful rotation, which is too much damaging to the zonules. The surgeon starts with the trenching. After 1 or 2 trenches, it's a soft cataract, so the expectation, if you are doing in a trench and division, it should be a narrow trench which is there, but it should be a deep trench, especially in the center. The surgeon tries, but there is cheese wiring. And already, you know, the hydrodissection was not good, but this was not realized again, and the forceful rotation of the nucleus is continued. So the division is still incomplete. The surgeon continues with the trench and division. But there is inadequate depth of the trench, and tries to divide, which is again unsuccessful. Now the surgeon tries to do again division by multiple attempts, but without analyzing the mistake. If you keep on doing the same mistake without analyzing, then it is not possible to expect different results. Now the surgeon gets frustrated, and now you can notice the posterior capsular rent. He tries to prolapse the nucleus with phaco power. Now these are basically, you can notice that at this point the surgeon is now getting desperate. And as we have already told, at any point of time, if you are becoming desperate, you have to stop and analyze what is going wrong, what is the better way to do this. Already there is a posterior capsular rent, and there is a nucleus drop. So even if in this case the surgeon would have was able to get, suppose he was able to get rid of this nucleus without having complication, the point was this was not a correct technique and not a repeatable technique. Let's see another case with the third surgeon with multiple experiences, of more than thousands of cases. So it is a hard cataract with small pupil, but probably the surgeon has done rhexis in these cases multiple times. So the surgeon continues with the rhexis without any pupillary expander devices, and does the capsulorhexis slightly below the iris, and is able to complete the capsulorhexis. Now after that, the surgeon does the hydrodissection and rotation, that was uneventful, and starts with the trench. Now there is incomplete visualization, and the trench is not deep enough. There is forceful attempts of division. And now the surgeon tries to chop. The nucleus, the pupil is coming down, and there is attempts of blind chop below the iris. Of course, it is difficult to feel confident to chop below the iris without any visualization. Still, the surgeon decides to just retract the iris with the left hand and does try to chop. And even after that, there is, of course, there is no division of the nucleus. Nucleus is all attached. There is all nucleus is attached. It is a mature cataract. But without any analysis of the mistake, now the surgeon becomes desperate and attempts to, again, like in the second case, pull the undivided nucleus by phaco probe. So the question here is not, it's unlikely that the surgeon, so much experienced surgeon, does not know how to put a pupillary expander device, whether the surgeon cannot analyze what is happening wrong at this stage. But probably, I would like to speculate at this stage, there is lack of now awareness, and our prefrontal cortex is responsible for the conscious decision making. And now that has stopped functioning, I feel, and now it is at the level of the limbic level that we are operating. Now it is just our adrenaline, cortisol, and emotions that we are operating, that we have to get it desperately now finished at any point, by anyhow. So the surgeon is able to finish this case, and after finishing realizes that there is a posterior capsular rupture. So triamcinolone is injected, and then the surgeon decides to do anterior vitrectomy. So most important takeaway point from my this presentation is, whenever you are feeling desperate to do any step in the surgery, it is important that you take a pause. There is no hurry. Even if you take a 5 to 10 minutes break, there will be no emergency. But rather, if you keep on operating on an emotional limbic level with high cortisol and adrenaline, then there will be more problems. And the more problems we create, then it will be difficult to give a better outcome to the patient. So now still the surgeon is continuing and doing anterior vitrectomy, now from the main port with not a closed chamber technique. Side port is not being enlarged, which was an easy way just to enlarge the side port so that you can do a closed chamber technique. Of course, the surgeon knows that theoretically. So the surgeon continues from the main port, because if he or she wants to complete the surgery somehow now. And now we are trying to insert the lens. As sir told, in a hypotonous eye, wound-assisted insertion of lens is very difficult. You might land with the lens through the rent into the vitreous. But of course, now the analytical brain has all stopped. And after the first failed attempt, another lens is loaded, but the main port is not enlarged. And again the same way, but the surgeon is somehow successful in putting the lens in the anterior chamber and then dialing into the sulcus. So at the end of the case, the surgeon, if he or she doesn't have any recording or no analysis of this case, one can easily say, oh, it was a very difficult case, small pupil, very old patient, very hard cataract. But the thing is that the surgeon had all the resources and the knowledge, but what happened that he or she could not apply in a proper way at that point of time. So let us just last few minutes to see that how can we make it better for the next time. So whenever we are feeling desperate, it is important to become aware and to come in that moment. So take a pause. Next step, take a breath. A breath makes you, forces you, a deep breath forces you to come into the current moment, Now you are not going into the future, oh my God, what has all happened? What will this patient land in? I have promised this patient a multifocal or a premium lens, what will happen? So take a breath and come into the moment. Then you reassure yourself that there is no emergency. Even if I close this case and I do not damage this case more, because I am not functioning normally in the normal proper moment, you can, even if you take a 5 to 10 minutes break, it won't make too much of a difference. Then, once you are normally thinking normally, you can now reflect what happened, what is now the current situation, and how can I handle it. Do I have my knowledge and my resources to handle this, or do I need to take a help from another surgeon, or do I need to now close this case and hand it over to another surgeon? And then you respond. Thank you.
So before we move on to the next lecture, I think this is a very important video, particularly from the learning perspective, because I think when we are training many new surgeons, what we are looking into is whether they have developed the analytical skills. So as mentioned in the video as well, that many times your surgical skills or analytical skills are not necessarily dependent on the number of cases you have done so far. You may become very analytical right from the first surgery itself. And what we have noticed is that those surgeons who have come to us for learning, if they have a habit of putting notes down for each and every case, or a logbook where they mention that in this case these steps were okay, but these steps were difficult, and I discussed and I found that I should have changed. I think these kind of the trainees or the fellows learn far better in the same number of cases, and far better, I would say it might be 10 times better as compared to another surgeon who has done same number of cases but not analyzed the results or the process itself. So I think I will request Dr. Deepak to start his video on divide and conquer technique for the hard cataract.
Is it on? The projector is on? Okay. Audio is on? Okay, I'll be speaking anyway. So this is a black cataract, okay? So first disclaimer is, it is perfectly alright to do an SICS in such cases, and it is not at all mandatory. It depends on your preference and skill levels, experience, what you do. So it's perfectly fine if you want to do a SICS as well in this case. So that's the first disclaimer. And if at all, what is my preference in dealing with such a thing is, I shifted over to doing a classical 4-quadrant in these sort of a cataracts. As you can see, the first prerequisite for a hard cataract, as a general rule, is we need to have a rhexis which is adequately big. So smaller rhexis is going to cause a lot of problem. Yesterday we saw in few of the cases when you're trying to do lateral separation maneuvers, you are going to stretch on the rhexis margin, tear it, and most complications happen because of a smaller rhexis. So hydrodissection, you need to be very gentle, use very little bit of fluid just to ensure that the nucleus is mobile. This is an important step here. I want to check whether the zonules are all right. So just trying to nudge the nucleus around and see, because such a dense cataract with a black nucleus and a loose zonules will be a significant, much more serious problem to handle. So in such cases, one change which I do is I expose the tip slightly longer, because it will help us to generate more cutting efficiency in this situation. And preferably if you have a newer tip, that also helps us. The second instrument is always going to stabilize the nucleus as I'm going to do the trenching here. So just carefully watch here. that the nucleus is never pushed at or shooed at, okay? So I'm using 95% torsional energy here, and as it is being done, you can see that in spite of the nucleus being so dense, you can the nucleus movement is very minimalistic. So literally, like, you know, you're using the ultrasound energy to cut through this hard cataract. So once you're done out 50%, I rotate 90 degrees and then perform the other groove. As you rotate 90 degrees, and at subsequent step, you're going to increase the depth. So my preference is always to make a slightly longer groove here, and that's the reason why a bigger rexis is going to help us. So the left hand is going to stabilize the nucleus as is being done. And look at this point. I just like to pause here and see. So I want you to all zoom in your microscopes when you're doing these cases and try to look at the morphology of the posterior plate which you're seeing. Now you can clearly see that the horizontal striations which I'm mentioning here in this quadrant, my arrow is moving. Clearly see the horizontal striations are seen from this up to here, and there is a lack of this. There's a total, very dark zone. And here, this is again at a much deeper plane. The horizontal striations are seen, but much lesser. But here you can see the striations are seen. So in denser cataracts, the most important secret here is to go as deep as possible, maybe 90% or 95%, because you need to remember that complications in denser cataracts happen because of our struggle to break the posterior capsule. Whether doing a direct chop or a stop and chop technique, when you're trying to divide the nucleus into smaller fragments, that is where most of the complications are going to happen. So if you're going to have a very deep pit or a groove, this ensures that your lateral separation physical force which is required is not so great, and you're not going to put so much stress on the bag, zonules, and the anterocapsular margin. So look at these subtle signs. That is going to indicate that whether we are deep enough or not. Most often than not, what happens is invariably we are not so deep enough in a denser cataract as is required. So look at these subtle changes and try to appreciate them. So in this I feel, okay, there is still needed to be sculpted a little bit better. I'm just go and stop exactly at the area where the color change happens. I'm stopping here only. I'm not going up to the peripheral part here. So again, you can see as I keep sculpting, look at those horizontal striations. They disappear now. So you're going to do until those things disappear. And note the color change. The central part is still orange brown. It is still not deep enough compared to the peripheral grooves here. So this is something which we need to recognize, and which I have noted, retrospectively analyzing, it is still not deep enough in the central pole. We need to remember that the lens is a biconvex structure. The deepest portion is always in the center portion. So that creates a problem always when you're trying to do the chopping maneuvers or the lateral separation maneuvers. So we want to use two long Sinskey hooks. It's about say 1.5 or 1.75 millimeter long. You have to be as deep as possible when you're trying to do these lateral separation maneuvers. It all cracks, but it always comes and stops at the junction of the center portion. Okay, so this is what typically happens here. So you're going to place it as deep as possible. The second option is always going to use your phaco probe, and you can engage one part with the phaco probe itself and then do the lateral separation maneuver with a long chopper. It is very important that the second instrument has to be long enough here, because the only way we can minimize this struggle is to be as posteriorly as possible. Literally, touching or grazing the base of the groove and then do lateral separation maneuver. Now, if all the fragments are not totally free, at least you need to ensure that one fragment is good enough free and it has to be pulled out of the bag. And my left hand is trying to go as deep as possible. And once I'm certain that it is free, this is one part which is pulled out of the bag. And then you can see still the bottom part is still not totally free. That's what typically happens. So you're going to emulsify this. Now part of the nucleus is in the bag and part is outside. The portion which is outside is come. And what we can see here is the base of the cross is all attached there at one single point. That is central 1 millimeter. So again you engage. This is a site of a modified chop. You're going to engage the fragment and try to place the second instrument as deep as possible. And if you're struggling at this part, okay, there is a small trick which I'd like to share with you. So you can see that I'm trying to lift that part and try to cut that attachment which is there. So usually what happens, the secret here is the attachment which is there, which is holding these three fragments together, that I'd like to just flip it out. That it is coming out at the level of the rexus margin now. It is very far from the posterior capsule. Now what I do is just flip the posterior part up and then phaco the base. It's a very easy and stress-free way of breaking this attachment. This is a bridge which is holding these three fragments together. So what settings I'm using? I'm just using this sculpt setting. The flow rate and vacuum is very low. Everything is under control. And rather than mechanically cutting at these attachments, I'm just using the ultrasound energy to do this. And then what I do again, the fragments are again pushed back into the bag. They're pushed back into the bag. And now because all these three fragments are free, you're going to pull them out of the bag and then emulsify. Look at the position of my Sinskey hook. It is above the nucleus always. And the trauma to the endothelium is minimized by ensuring that there is minimal turbulence and lens chatter. So again, the last two fragments, you feel that there is some attachment here. So you try to hold it and try to separate. Here the other challenge would be the visualization, because the cataract will be so dark and black, visualization will be a challenge. But the only secret is hold the nucleus well and try to place the second instrument as deep as possible to get the lateral separation maneuver right. Now the trick here to minimize turbulence is ensure that your foot control which you're delivering the phaco power is just adequate enough. Excessive power is going to cause lens chatter. You can see that the lens fragment is literally dancing around the tip of the nucleus. And again, it might be boring enough, come out and refill the chamber with OVD every time. My preferred way always is to first put the dispersive OVD, that is the one which is having the chondroitin sulfate first near the cornea. And inside the bag, this is HPMC which is going inside. This is sort of a modified soft shell technique, which if you may want to call it. The reason is the chondroitin sulfate and the hyaluronide combination is more thermogenic. So if it gets into the tip, it's going to cause you wound burns or generate heat. So what I'm doing is pushing the HPMC in the bag. So our emulsification plane where it is there HPMC is there. So again, a lot of refilling of the chamber with the thing is there. Again, this last fragment, two pieces, there is still an attachment. Again, I'm lifting or flipping up the part. Now this is at the level of the rexus margin, and then you chew it off and eat it off. Now, the only thing, look at the orientation of the tip here, as it was being described yesterday. Tip, I would prefer to keep it on the left side. Either left or right side is possible, is okay. And the position of the dialer, just look at it, it's always on top of it to ensure that some of the fragments which can be repulsing away from the tip doesn't go and hit on the endothelium. So the controlling the energy delivery is extremely critical. So this is how the IOL is placed into the bag. So in spite of using a lot of energy, you'll be surprised that if you take adequate measures, it is you can have clear corneas on the first post-op day. You need to be patient, give long time, and use adequate amount of OVD. Now again, want to share with you that flipping of the base. So for that to happen, you have to remove one quadrant first. So once you remove one quadrant first, you have enough space, put in OVD, and maneuver that whatever attachment it is there upside, and then you can emulsify. So what I'm trying to do is the lateral separation maneuvers are being done. So in some cases, it may not be possible, like this case, to get a perfect crack in all of them. So what I'm doing is I'm just removing one quadrant out of the bag. One fragment is out. Now you can see the attachments are there, and in spite of trying to do it, I am unable to crack it. What I do is put viscoelastic, flip it out, and these attachments are now at the anterior level. I'm just going to use ultrasound energy to break these attachments and then push them back into the bag. So then you are going to easily. So this is possible only when you have space within the bag. So the bridge which is attaching these fragments, that you just pull it out, and now it is exposed in the safe zone, the central safe zone. Now this attachment you can just directly phacoat using ultrasound energy and low flow rate and vacuum, just like your classical what do you do for your sculpt. Just sculpt that attachment, that's all. And then all the fragments are free, so you don't have to exert any pressure. The other secret is you have to have enough space. For that, one fragment has to be out. So that was it, I think. Thank you.
Thank you, Dr. Deepak. Today, the delegates are appreciating, I think after every talk, there is some applause. The volume can increase, of course, for the applause. So we'll shift to 3D now. And yeah, Aniket, I think he has some question.
If at the beginning, if you would have found out that the zonular support is not that good while rotating, how would your plan have changed while managing the same case with same grade of cataract and everything?
That's a different topic altogether, but you will take all the precautions necessary for a thing. Like, in those cases, I would have used a CT or a capsular hook or whatever it is, and then would have still. I think that
we have those cases subsequently. So, okay, so I'll be speaking on the same basically topic on hard cataract, and as you know, there are multiple ways we can tackle these difficult cases. And this is in fact kind of a deferred live surgery where I am explaining few things to my students while I was doing this hard cataract. So it's a pseudo exfoliation. As you can see, the pupil is very small. As we were discussing yesterday about a rigid pupil. So this is how a rigid pupil of PXF looks like. And Dr. Deepak told us about, after injecting visco, it should, how much dilatation it does, we will see. Okay, so this is the first incision. So here I am using the 20 gauge MVR. So you should also know the gauge of MVR, what you are using, because that's very important when you are considering bimanual or you want more anterior chamber stability. So where I want more anterior chamber stability, many times I use 22 gauge or 23 gauge MVR, so that the Sinski from the side ports snugly fits in that. So probably I'm, I'm injecting the trypan blue dye here, and this is how you stain under the iris. So just watch what I'm showing here again. Okay, many times these PXF cases, if you inject the dye, with a lot of force, I think yesterday Dr. Deepak was mentioning, sometimes these fluids can pass through the zonules into the, vitreous. So this dye can easily go behind and stain the vitreous. So we don't want that. So what I do is that, first I have put some air bubbles, and then drop by drop I am just putting it over the anterior capsule. Then I am going under the iris and injecting just little bit dye, and then wait for 30-40 seconds at least. The waiting time is also very important to have a proper staining of the capsule. Just a second. Huh? Can you increase the illumination? This is double bulb you have put for the प्रोजेक्टर ला डबल बल्ब है का सिंगल बल्ब है? डबल करता? I'll just
Saurabh, just to add this, see, one more way of preventing the egress of fluid into the burger space is when you're washing the dye through the canalizer, press the posterior lip down. Okay, yes. So that is very important. Press the posterior lip down, make the eyeball soft, then only
3D and double.
So when you're injecting this BSS to wash out, that force itself can push the dye or the fluid across the zonules. You know what? There is very little space in the burger space. Even just couple of drops can cause a raised pressure. So you need to be mindful of that.
Killer, double bulb, dual bulb on. Okay. Okay, so that is important. I think in the first case that Dr. Nidhi showed, in that case also that, over injection of fluid while washing the dye is one of the common mistakes, so that should be avoided. Okay. Barabar hai? Yeah. Okay, so now I am going to use Hylucoat here, which is my preferred choice for these kind of cataracts. And you can see that there is no dilatation of pupil at all. And watch, this is the test that I do before I start these kind of surgeries. I think Dr. Aniket was asking me about the zonular instability. So how to know before you start whether, I want to do a phaco here or I want to just do SICS. So just watch how much the lens is moving. Now I don't have a particular measure about, how much movement should indicate how much instability, but generally we get a fair idea like how stable it is. Now I am going to do the stretch pupilloplasty. You can watch here and just watch how much I am stretching. Okay. If you see closely, just, you will realize there is little snap there. Should we go back and see one? Little snap there. Just watch carefully.
See that little giveaway?
Just one second, I will. Yeah. Now just watch. Little snap, you can see? Yeah. So that indicated now the sphincter is bit torn. Okay, so that's enough. So you don't need to, stretch the pupil more now, because now from rigid it has become now expandable. So I'm going to use again BHEX. And yesterday I think we showed in a few cases how to inject BHEX. So I will just forward this part where I'm injecting the BHEX. And now we'll starting with the rhexis. I'll just go back and. So here I'm going to do the first nick with the needle itself, because I know the zonules are a little bit weak there. So I started off with that and continued. Now here I realized that I should have better control, so I shifted to micro capsulorhexis forceps. So this is another good instrument to have in your armamentarium. It puts very little pressure on the main incision. You can go through side port also, incision also, which keeps the anterior chamber very stable. So now again here I want a good size rhexis. So almost it's a 5.5 mm rhexis. Now generally I don't do hydrodissection in these cases. So here because as I think earlier we discussed, in zonular weakness cases it's better to have a mobile nucleus. So I am going to do very minimal hydrodissection in this case. So very little amount of fluid is being injected so that the nucleus gets separated from the capsular bag, which might be having loose zonules. Now in these cases I generally prefer bimanual rotation. So when you do bimanual rotation, basically the counter traction is provided by your other instrument and rather than the zonules. So that makes it safer to use in case of zonular weakness cases. So once you have this rotating nucleus, I am going to go ahead with my standard technique, what I use for hard grade of cataracts. Now here again the trick is to have a very deep trench. Now you will find, I just want to pause it here. In usual trenching, what we do is that we go from one end of the capsulorhexis to the other end, and then you go deeper and deeper. But for hard grade cataracts, I use a slightly different technique. I call it vertical trenching. So there are small movements horizontally, but then I go deeper at the same place. Okay. So rather than, I'm just explaining, rather than going like this, because in beginner's hand, when you horizontally push the nucleus, sometimes it leads to zonular instability. So I'm going to do deeper and deeper, and then slowly little bit horizontal. So it is like mining, like they do mining, they go kind of make a burrow slowly. Okay, so I am cutting it horizontally little bit and then I am going deeper in the same area. Okay, so you can see it causes very little push on the nucleus all throughout, but at the same time I can go much deeper. So just wanted to show on 3D you can actually see the depth at which I have gone. Okay, So I have reached quite deep here. And this is something you should experience when you are doing. So if you are a beginner and you have someone supervising you, you can ask your trainer to just check whether the depth is correct or not, or I should go deeper even further. Apart from visible signs, I think on 3D you can understand the depth even better. Now once I realize that the depth is all right, okay, now this is the time I do the chop. So this is like a terminal chop. So I have a central deep trench which has made the nucleus weak. I bury right in front. So the depth of burying of the tip is not, angled downwards. Unlike what you do in primary chop where we are targeting the center of the nucleus, here because I am in the periphery, I know that here the nucleus is not going to be that thick. So it is directed straight horizontal, which is more comfortable in our hands. Once you go in, just push your left hand 1.5 mm longer Sinski into this nucleus and crack open very, very gradually. You can see, just watch how much lateral separation I am doing. Very, very minimal, okay, very minimal. So this is least traumatic for zonules as well as for the posterior capsule. Now you can rotate it 180 degree, and similarly either you can do deeper trench here again, or we can just crack it open in the same manner. The depth of burial again is important, but you can watch my left hand how it is going very deep, okay. And I will show a case later on where I want you to compare the lateral separation there and this lateral separation, okay. So now first this thing division has been made. Now I am going to go to the one heminucleus each. Again here multi-level chopping described by Dr. Vasavada sir, where you can see the hold is still there. Now here I want to tell you that we have enough time holding the nucleus. You don't have to hurry and suddenly try to jump and try to chop in one go. So just be there, and you can see the multi-level chopping. The blunt Sinski goes down, down, down till the posterior plate and separates the piece completely. Again watch the depth at which I have buried. The chopper coming towards the nucleus piece. Again we can bury further if we feel the hold is not good. And somewhere if you have not cracked it till the posterior plate, you can leave it if you feel it's little difficult on that part, and you can just go to the next nucleus. Watch here as I go deeper and deeper. Okay. Now, so one heminucleus is done. I have rotated. Now I am cracking the second heminucleus. You have to be very patient. You have to be methodical, and you have to do the same, repetitive boring movements in all your surgeries. So if you have this kind of cataract, you will find me doing same boring steps. There is no fun at all. So I will do the same, technique in all similar cases, and that's how you improve your, surgical skills. Many times when I, started playing cricket, I used to, ask my coaches that why these bowlers bowl with the same, action all the time. Well, I can bowl, at that time I thought that I am a great player. I can bowl with 10 different actions. But I think the key is in consistency. You should have same steps for particular type of cataract. And now I go to the quadrant removal. So I have already the Hylucoat which is guarding the endothelium, and I am going to take out the first half heminucleus here, okay. Watch my PhacoTip as Dr. Deepak also showed, it's sideways beveled. So bevel is towards one side. I am taking one piece at a time. So that's what I think we also yesterday discussed about flying pieces. So better to emulsify one, piece completely before we move on to the next piece. So you see these small pieces, so I will just emulsify them before I move on to the next pieces, so I don't have any flying pieces around. Once halfway mark is reached, it is a pit stop like they take in Formula 1 car. I call it a pit stop, where I again inject Hylucoat under the endothelium. You already have it covered, and then 2% HPMC. So I think me and Dr. Deepak use the same technique where we inject a lot of methyl cellulose in the bag. This creates a space, And again, what I showed in, one of my first cases in the morning, that once you put this HPMC, the PC goes back, and I feel if there is some fluid accumulation in Burgess space at this point, it will push it outside, it will dissipate that fluid, so will reduce the chances of PC fluctuation for the last piece. So once this pit stop is over, I will again move on to emulsifying the remaining of the pieces. Okay, I will just move on. I think here it's again repetitive movement, which, okay, so I am just emulsifying the last few pieces here. So always, and what we talked about the, plane of phacoemulsification. What do you think is the plane of phacoemulsification here? On 3D, you can clearly see it is at the iris plane. Okay, can you appreciate it? You can applaud if you appreciate it. Okay, so that is most important thing, I think, because on 2D, many times we see many surgeons operating, but we never analyze at what depth you are operating. And once you see that you are operating always at the iris plane, you will have cleaner or clearer corneas next day, you have much less inflammation, and that's the key. So that's what I think Dr. Deepak also nicely showed in his videos, that he was always maintaining the plane of phacoemulsification. But on 3D, you cannot deceive you. I cannot tell you that I am deep enough and I'll be doing much closer to the endothelium. Last piece, again, you can see what I did. I stopped, I changed to retroillumination. So I wanted to check the posterior capsule. Now you can see here, as compared to morning cases which I showed, the PC was nice and tight, no fluctuation of the PC at all at this parameter, so I don't have to worry about PC rent here and can go ahead with the same parameters. And I have no issue, like I am not afraid of any posterior capsule rent here, because I know that the PC is not moving around at all in this case. Okay, so that is something. And yeah, whenever you are using BHEX, you have to be careful while injecting these kind of IOLs or plate haptic IOLs, because you might drag that pupil expansion ring inside. That's something you have to be careful about. So I think I will just end here, because the rest of it is just usual. So that is my standard method of managing a hard cataract. Lights, please. Yeah, any questions? Yeah, please, mic, please.
Hello. Sir, can you tell us the parameters you used for trenching, chopping and quadrant in this kind of a cataract in your machine?
On the one I did.
All the 3 steps, how the parameters were different? Which parameters you used for them?
Okay, so for sculpting, I was using balance tip. So on balance tip, I generally use linear 70% phaco power. Okay, linear means as I press down, more power will be delivered. So 70% torsional phaco and continuous mode. That is what I use for trenching. For chopping, I use 70%, 60 or 70% longitudinal phaco with 5 pulses per second and 40% on time. The vacuum is generally 500 or 550 panel mode, and the flow rate is 45 on panel mode. Okay, with the IOP of 36. This is I am using Centurion. So if you are using Legion, probably I will use say 100 centimeter bottle height with a flow rate of say 40 panel mode, and vacuum say 400 to 450 on panel mode. Now for the quadrant removal, I was using 70% torsional with IP on, and 70% also I was using pulses, 5 pulses per second with 60 to 80% on time. So generally in torsional mode for quadrant removal, I increase the on time while using balance tip. So if the grade is soft, I generally keep 60% on time on torsional modes with 70% power, while for hard cataract I increase it to 80% with 5 pulses per second with IP on. IP is set at 95%. That means when there is a 95% vacuum reached on occlusion, there will be pulses which are sent 90% of the power. So when I have kept torsional power of 70, it will deliver 60% power pulses when there is a occlusion. So these are my standard parameters. Vacuum generally I reduce for the quadrant mode to say 450 to 500, again on panel mode. Flow rate is same 45 on panel mode. But if I see any posterior chamber fluctuation, then my flow rate reduces to 35 and the vacuum also reduces to around 400 to 450 while quadrant removal. Yes, one more question.
As for hard cataract, we are using very high power. Are there any specific guidance for preventing wound burn?
Yes. So for the wound burn is commoner with when we are using longitudinal phaco power. With torsional, it's not common. Though I would say it's not impossible, because if you are using torsional phaco and the tip is occluded, you can still get a wound burn. But with longitudinal, it is commoner. So as I mentioned in the phacodynamic session, with longitudinal power, if you always try to keep the on time 40% or less, you will never have wound burn. Okay, so I think that is the trick to avoid wound burn in case of when you are using longitudinal phaco power. The second, again, in longitudinal power, the commonest cause of wound burn is because of the PhacoTip blockage, which can happen because of if you have not emulsified a very hard cataract with phaco power, then it may just clog the tip, or even when you are using heavier, like higher molecular weight dispersive agent like viscoat or hylucoat, initially you should wash off some amount of that before you start giving longitudinal power, because this viscoat as well as hylucoat can also clog the tip, particularly in trenching when you are using low vacuum.
Thank you. And if it happens...
To add to that, just a second, along with all the things, ask your assistant to pour cold saline on a wound as you're doing. And if you're comfortable, try to do a scleral tunnel phaco in very dense cataracts where you're expecting a lot of power to be used. Sclera is much more forgiving than your thing. Third point, try to avoid a very tight fitting incision, so that the fluid along the sleeve itself is going to cool it off a little bit. But as Saurabh told, longitudinal phaco is vulnerable, so you have to weigh the pros and cons and then decide when you're dealing with a very dense cataract. That's what you can go as cold pieces. But it has to be always been on. Okay, so in situations where even you're doing a direct chop also, then also it can cause wound burn. So always ask your assistant to keep pouring the BSS on your cold BSS on the wound.
No. Primary, the infusion fluid that you are using.
That's what. Everything is cold only. That also is cold, and your pouring also is cold.
Many of them, they keep it at around 10 degrees. They keep it in the fridge.
It will not make a dramatic difference. Let me tell you. If it is the cataract is very hard, it will be dramatic difference. Like you are never going to have wound burn. It is made reduced by 25-30%. That's all.
If the wound burn happens, unfortunately, how to manage it?
Wound burn has various grades. So if you have very mild wound burn and you can seal the incision with just hydration of the incision, then you don't have to worry about it, but you may have little bit of higher astigmatism in that axis. If the wound burn is even more, where there is fish mouthing, then you can put horizontal sutures to close it. If that's not sufficient, you may have to do a Tenon patch graft over it. And if even that is not sufficient, maybe corneal punch graft may be needed. So it really depends on the grade of wound burn. Luckily, with the advent of this torsional phaco, I think we have not seen these kind of wound burns in our practice for last few years.
Thank you. Some of our friends are using earthly machine. The wound burn happens because of the frequency at which the tip oscillates. So even though some of the machines don't have torsional, for example, earthly, I don't have any financial interest, neither I own the machine. But few of our friends who are using earthly machine, they tell that even when they use continuous energy, they don't have wound burns. If any of the audience member is using earthly and if they have experience, they can share. But some of the machine which I have experienced, like I was using Sovereign Compact, and that we used to have significant wound burn in dense cataracts. So even the frequency at which the tip oscillates, that also decides the amount of wound heat which is generated. The best is torsional also, but there are certain things like, even Bosch and Lomb, Millennium also oscillates as a different frequency, lower frequency. Millennium as well as your earthly machine, they tend to generate lesser heat.
With earthly, I have seen that their irrigation part is very good. That means the sleeve size and the tip you know, the bore
that
of,
is the trick there.
I think that there is lot of capacity for lot of infusion, and that I think cools the tip also. So we'll move on to the quiz question.
Excuse me.
Now. Yeah, go ahead.
I just want to add 2 points here regarding the parameters. Whenever you are dealing with such type of hard cataracts and you are in a quadrant mode, now you have separated 5 or 6 small pieces. Now whenever you are keeping that torsional power 70, if you keep the ramp starting from 30 to 70, it will more effectively emulsify that. Means instead of going from 0 to 70, you just begin with the 30 and end up at the 70 in linear mode. That
Yeah,
I found very useful in hard cataracts. And second thing regarding this balance tip, so as you said that you are just facing that towards the angle, but if you balance tip, if you keep it perpendicular, that will work more efficiently than if you keep it horizontally. Regarding cutting and emulsification power.
Okay. For me, I think the tip and the nucleus piece orientation works same way, whether you keep it horizontal or vertical. When you put it horizontal, be well, the fluidics are better as compared to when you put it vertical. That's the only difference. But otherwise, emulsification power I find same with both. And very good point of starting from 30 to 70. So that's what I was discussing with one of the delegates. In usually the longitudinal power, the effective power is usually linear. That means if you increase from 0 to 100, it increases linearly. While in torsional, what I have experienced is that it's kind of exponential. So for lower percentages like 20-30% of torsional power, it hardly gives any effective, you know, emulsification. But as it goes towards 70 and from 70 onwards, it, you know, exponentially increases. So I would advise not to use power above 70% with balanced tip. Because I have seen that the cornea has become much more hazy because the amount of energy delivered inside the eye is much higher. Even if you keep, you know, 80% or 85% power with balanced tip. So I generally stick to 70%, very occasionally 75 and 80%. You have some question?
Yes, sir. In white cataract, there are 2 types of cataract. No, sometimes the nucleus in first is softer and phaco is easier, and the other one is harder nucleus. So how can we predict in slit lamp examination whether like what I am going to face? Like we will be prepared for the way.
On slit lamp, you can see the color of the nucleus. If you
many
can see,
times it is
if it is
liquefied
completely white,
quarters.
you cannot predict.
Yeah,
Just
sometimes
like
it is not difficult to do it, no? It's difficult to predict. So once you puncture the capsule in the cortex aspect, then only you'll be seeing a brown cataract there.
Yeah.
So it is, everybody has the same problem.
Okay.
Yeah, same. So we'll start with the first quiz question.
So here in this case, it is intermittent mature cataract, moderately dilated pupil. This is about capsular excess part. Just watch it carefully, find out what are the mistakes. Now the rhexis is continuing with the cystitome from the main port. Now the surgeon has switched to microcapsular rhexis forceps. In slow replay, you can see that again. Here the rhexis has ran out. So what was the mistake here and how will you proceed further? You can raise your hand, we'll give you mic.
The force had to be towards the center of the pupil. Pulling of the rhexis.
Not holding the margin of rhexis properly, and it should be one quadrant and then.
Initially, it is a mature cataract, So the first target is decrease the intralentricular pressure. So the cruciate incision and little bit aspiration of that fluid. So that will be, next step will be very easy for the CCC.
Yes.
On and extension of the rhexis margin, speedy snap, that will be prevent the extension to the equator.
Yes, I think the main mistake, I think this is the right answer. Main mistake was this surgeon didn't attend PhacoTips, and that's why he didn't realize how to decompress the lens. Okay, so we'll move on to the next part. I think I'll be showing a case, and after that we'll be discussing few things about the dynamics. So this particular case, we have already seen a part of it yesterday. I just wanted to show it again today because I wanted to understand, just discuss certain dynamics that you can switch off the light, please. So all of you just now saw my technique, how I was using for hard cataract. Now
this video is part of PhacoTips 3D
and the amount of
teaching
lateral
course.
separation that I was doing. Now we'll just see this video again, a hard dense cataract. I am using a small Sinski here. And now watch the amount of lateral separation I am going to do in this case. Okay, so I am using a small Sinski. I am holding these pieces in the anterior part of that crack and not deep enough. Just watch here. See, I am holding at the anterior part, and that's why I need lot of stretch, and still the posterior part is not cracked. Okay. You might find it's okay. I mean, something is happening. I am still able to crack little bit, so it should not be an issue, right? At this point, I can still continue to do the same thing. You can watch my Sinski. It's not deep enough. It's just anterior. Now these are the subtle tricks you have to pick up while watching these videos. Okay. So as Dr. Nidhi also mentioned that not complication is not done in a particular surgery doesn't mean that that surgery was done perfectly. There might be moments in the surgery where there were increased risks of complication, but somehow by luck we avoided those complications. So here you can see the amount of lateral separation being tried. Yeah, and now see what happens. I think everyone noticed it, what happened there. Okay, and I continue to do the surgery. So you can see that subincisional area, the capsule, anterior capsule is torn, and the nucleus will be now slowly tilting down. I think we saw this clip yesterday as well. But the idea here is to tell that you will never be able to recognize that a particular step is wrong unless you very closely watch whether it is going to affect, how it is affecting the anterior CCC, how it is going to affect the posterior capsule as well as the zonules. So always make sure that you keep on fine-tuning your surgical skills by picking up these kind of points from the surgical videos. So let's move on to Dr. Deepak's talk now. Deepak, you are ready? Yeah. So we just now saw the anterior capsular tear there. So Dr. Deepak will be explaining the principles how to go about managing these cases where there is an anterior capsular tear whether we can go ahead with Phaco when we should do SICS.
The first disclaimer is it's perfectly fine to convert to do an SICS in such situations, okay? The decision whether you want to continue to do Phaco or not depends on multiple factors. The surgeon's skill level, surgeon's experience, the backup which he has at his institute, the density of the nucleus, and so many coexisting pathologies in the eye, like small pupil or bad cornea. So multiple factors are going to decide, and it's a highly individualistic decision whether you would want to continue or not. But if you want to continue with phacoemulsification, what are the principles one has to follow? That is what I'm going to share with you today. So now is the situation where we have a TPC tear, and how are you going to decide now? Okay, so this is an elderly 65-year-old lady. The cataract is slightly dense, and I'm trying the Worling technique here, and it looks all right, and it is not so good enough. So I'm just trying to decompress the bag here, and so I'm just here, the nick which I gave was a little bit too bigger, and rhexis has gone radial now, and this is a situation where I'm stuck in now. Do I do Phaco or MSICS? So in this situation, I have decided to proceed with phacoemulsification. The goals are, don't want to put any stress on the already torn margin. So one of the first ways to do that is to have a bigger capsular opening. So my goal is to enlarge the rhexis. Now what I do is, I make a nick on the other side and try to enlarge it. The idea of enlarging the capsular opening is just to ensure that during your nucleus manipulation, the stress on the weak part is enhanced, so it's not enhanced. So now the nucleus, again, division technique is up to your choice, whatever you are comfortable, but the basic principle here is you shouldn't cause any stress on the capsular bag during any of your maneuvers. So I'm just creating a small central pit, and then I'm trying to do the chop. The important point to know here is what is the state of this flap which is there, free flap. And yesterday in one of the cases it was shown that when it extended beyond the rhexis margin, if you could have noted, it had become stiff and flat. So this is a anterior capsular flap fluttering sign, which is described by Dr. Rohit Om Prakash. You can have a close look at it. It has to be always everted, that is facing upside and freely floating. That is one indirect clue that the tear has not extended beyond. So ensure that you're chopping and at multiple levels. The most important step, once you have got one free fragment, see, there's no hydrodissection, there is no nucleus rotation, you're just manipulating as it is. You've done the first chop, you created a first free piece, and then you're going to pull it out of the bag and then emulsify. This is very important. So once the bag is, you have got some space within the bag, that's the only time when you are able to rotate, or allowed to rotate, I should say. At this moment, again, please look at the flap. Keep looking at this flap, and it should be fluttering. And once you have enough space within the bag, you have removed the two nuclei which are directly opposite to you. And now because the bag is empty, again, you're not allowed to shallow the chamber, go in and fill in OVD before coming out. And now you can rotate the nucleus because there is space within the bag once half of the nucleus is out. And even at this stage, keep a note at the position of the orientation of your free capsular tear which is there. The flap is everted up. And slowly but surely are going to emulsify each of these fragments here. So the principles are, you're not going to allow the chamber to shallow or deepen. Again, you're coming out, injecting OVD before coming out, and a little bit of cortex which is remaining, you are going to aspirate it out. So again, the chamber is being filled with OVD, the bag is inflated, and the
IOL is being placed into the bag. So the OVD is both in front and behind the lens is irrigated out. The irrigation cannula is behind the lens. And you can note the orientation of the haptic. The haptic orientation is such that it is away from the capsular tear. So rest of the maneuvers will be the same thing. So this is again in an elderly patient, and you are in a situation where the rexus has gone radial, and this is a situation where what would you do? Again, the principles are going to be the same. The first thing what I would want to do is I would want to enlarge the capsular bag, capsular opening. But before that, I would want to decompress the bag. In this case, I'm using the bimanual IND to just aspirate the overlying swollen cortex here, so that when I do, or when I want to enlarge the capsular opening, I shouldn't end up, losing that as well. So that's the idea of decompressing it. Switch hands, use OVD to do this, and once the bag is decompressed, I'm using micro scissors to make a small nick and then trying to enlarge it. So you're going to have something like a C on either side of the split. Because this is a denser cataract, you want to have an adequate sized opening because you don't want to pressurize on this. In this case, I just want to demonstrate that I'm going to do a stop and chop technique here. The central trench is being done. The central part of the trench is much more deeper, and I'm doing lateral separation. And again, keep looking at that everted flap. Okay, that is the sign which is going to tell you that everything is okay as of now. The moment it becomes stiff, what I'm doing, again, I'm pulling one fragment out of the bag without no nucleus rotation, no hydrodissection. Once one fragment is out of the bag, then it is much more relatively safer zone. So I want to push the nucleus back. I'm going to use OVD before coming out of the eye with the phaco. Then the nucleus is gently rotated, and again you're going to hold it and then chop. So the message here would be that, first take out one piece out of the bag before attempting any nucleus rotation. That is extremely important. And second, always keep an eye on the flap end which is fluttering. So it has to be everted and facing up. So be a little bit patient, and then you can go ahead and implant the lens. Again, you can see that although the equator extension of the rexus is there, but still it has not gone beyond the equator. So the haptic again is ensured that it is away from the torn edges. So it is placed at 90 degrees from it. And the same maneuvers of removing the OVD, everything can be done. So this was it. And moving on to the last case in this series. So we have the trainee surgeon is doing now during hydrodissection. You can see that the nucleus pops up, and we have a radial extension of this tear. So again, here in this case, I'm modifying my technique here. I'm trying something different. Again, I'm just using an AC maintainer here to maintain the chamber so that I don't have to replenish it. Again, I'm trying another technique here. See, the principle is you don't want to rotate the nucleus when the rexus has gone radial. And one option is you do a direct chop and remove one fragment out. The other way is to do something as a cross sculpt. This I saw Dr. Saurabh Patwardhan and Dr. Suhas Haldipurkar do for the posterior polar cataracts. That's another situation where you would not want to rotate the nucleus, right? So here what I'm doing is I'm doing a straight sculpt. For the horizontal part, you just hold the sculpt and do a horizontal sculpting, okay, just without rotating anything. So the same principles what we use for a posterior polar cataract, the same principle I'm trying to use it here. And you can see that I'm just trying to use the 4-quadrant divide and conquer technique here. So we don't want the nucleus to be rotated with the tear going already to the peripheral part. And I'm just trying to enlarge deepen the groove, and then you're going to have a lateral separation maneuver. So be as gentle as possible when you're doing these lateral separation maneuvers. There's absolutely no hurry. You have to be very careful and very delicate.
And once the fragment is free, then it is not difficult at all. So again, you see that one fragment is free, you just flip it up, hold it, the base, and pull it out of the bag, and then emulsify it. So you got two fragments are out. Now when the bag is empty, you can obviously rotate the nucleus, bring it into the opposite part, and then emulsify. And here just pulling it out without rotating, you can just hold it. You got better access here, and then pull it out. So this is another situation where I have begun to use this. I have not done many cases with this, but this is what I'm beginning to like it. So when you come out like this, you don't have to go and replenish the OVD again as it was being done in all the cases. So again, you do cortex aspiration. So I'm just going to fast forward it a little bit. So again, when I come at, you don't have to fill in. Here, the planned hydrophilic lens is being placed into the bag. So I think let me conclude by telling that what are our basic concerns. Whenever there is a radial extension of the CCC, we are worried about the wraparound tear which can go up to the posterior capsule and then cause a nucleus drop. This is the major concern. So I think I just tried to classify the 7 principles to follow here. The first thing would be always try to enlarge the capsular opening. So try to get some sort of an opening which is much bigger than what would you want, because a bigger rhexis definitely handles the stress better than a smaller rhexis when one of the edges is not this thing. You avoid hydrodissection, you minimize nucleus rotation, and whatever ways of you there. And obviously the most important is always ensure that the chamber is maintained well. So it is quite boring to hear the same topic again and again, that keep the chamber well, but that is the secret, So we have been repeating that many times. So yesterday I was telling the entire secret of the ophthalmic intraocular surgery is this: just keep everything in its place and everything will be fine. And number 4 would be watch for the flap motility sign. Ensure that it is everted and floating around. That's an indirect evidence that all is well. So the moment it is not everted, it is flat and rigid, then it is an ominous sign. If it becomes stiff, inverted and immobile, it's not good. That's the time for you to convert and pull out the nucleus. And when you're trying to manipulate, always ensure that the stress on the torn edge is minimal. You have to be as gentle as possible during your chopping maneuvers, and always the goal is to create space within the bag. Find the first opportunity and then pull the first fragment out. The moment the first fragment is out, your nucleus maneuvers are not going to push much stress on the bag and the torn edge. So that is the most important secret here. Once you have that space, it's important, and obviously the plane of emulsification is much more anterior than what you would have done routinely. Take care to protect the endothelium with the liberal use of OVDs. So I think that is what you would want to follow. Thank you.
Thank you. So we'll move on to the next. If there are any questions, you can just ask. Yes, Mike, please.
So there's one question. In cases of softer cataracts where there's an extended CCC, how can we do hydrodissection? And if there's no hydrodissection, and it will put more stress on the zonules.
So there are both ways. Like Dr. Umesh is here, and he also operates on many cases where the trainees have a radial tear and he has to do. So he most of the times uses the sideways trenching method without doing any hydrodissection, and once you have this trench division, the nucleus starts rotating and you can take it out. While I personally, though I have described the technique of sideways trenching, I don't use it. I do kind of a hydrodissection in these cases. Again, the principle is that you should not be deepening the chamber, you should not be allowing the chamber to shallow. So it's the control on your fluid injection that is important. If you can do that, you will hardly find that the radial tear actually goes down while you are doing hydrodissection. And once you do hydrodissection in soft cataract, the nucleus is free from the the capsule bag. You can just prolapse it out in the anterior chamber and do phacoaspiration. That's the easiest approach for it.
Yeah, see, the trick here in soft cataracts is, if your rhexis is smaller, just enlarge the rhexis and then prolapse the nucleus out. Soft cataract, it's not an issue at all. So the trick is, before you do anything, rhexis has gone radial, you just enlarge the rhexis a little bit and prolapse the nucleus out of the bag and then emulsify. So that's not an issue at all. If you can use fluid very gently if you want to, and then try to divide, rotate, and all those things. But if you are out of the bag, no, the stress on the capsular bag is very minimal. The problem happens is when situations where you cannot do anterior phaco, like in denser cataracts, like when we showed. Softer cataracts, it's much more easier, but you can try to maybe trench and get at least one heminucleus out of the bag. That also is possible. And most important thing is slightly have a bigger capsular opening.
So we'll move on. Yeah, one question.
So how would you change the parameters once you notice the radial tear for your phaco parameters? Would you decrease the bottle height or something?
See, again, never, the answer is always ensure that the chamber physiology is never compromised. Okay, so if you want to go slow, decrease the bottle height also, and also decrease the flow rate and vacuum, so that you should not have any surge. So you don't want higher infusion, but if you continue the same flow rate and vacuum, it's not going to serve the purpose. So decrease everything and then go ahead and do it. It's okay.
What would you do, or you keep the settings same?
So usually, no, I don't change much of a settings there actually. I would continue with the same thing, not much of a difference. So I don't change, but it is worthwhile if you want it to be a little bit slow, both decrease the flow rate, vacuum, and as well as this.
Then one more question, sir. If you have Argentinian flag sign, how would you proceed with lens implantation? What specific rules you follow while implanting when there is a bilateral?
I showed it. No, it's just general. No? The haptics have to be away from the 90 degrees to the radial tear. That's all. Okay. Anything else specific you want? Like, what is your doubt?
How would you dial it in this case? We have to be gentle, it is fine, but there can be stress on the both sides. So which side would you prefer? How would you inject the lens?
Actually, no, just see, ensure that the bag is very well formed, okay? Just the bag is very well formed, and then you can maneuver. It's not so much, I have not had any extension of the tear to the posterior capsule during nucleus lens implantation. I have never had that. So it is not major concern, that's what I feel.
And, would we prefer a 3-piece lens or a single piece lens?
It won't matter, I guess. Anything of his choice.
Okay, so we'll move on to the...
I have one question about the AC maintainer. I've never used it, so just want to ask about the AC maintainer that you use. What is the flow rate that you keep regularly? Like it's like a normal, or you keep something?
Flow rate of what?
AC maintainer.
No, it is there's no flow rate for that. You have the bottle height is resides, and the regulator which you have, that is full on. You are controlling the flow which you want only by the bottle height.
So when you are doing bimanual eye, the AC maintainer is off all the time.
No, it's on.
So
I'm
what is
the
source like?
Another bottle.
Two different bottles are there.
So I never used, so I'm like curious, what is the source of the AC maintainer?
He is investing in that additional bottle of BSS.
And the IV drip set and
quite costly, expensive. So let's move on to the next video. This is a very interesting video, and I learned this particular technique, though I think this has been described before. I'm not sure, but I learned it from Dr. Neha Dholakia madam, and when she submitted this video for my channel. So very interesting technique and very useful. So I'll be going into the nuances of this technique, how it can be used. Audio hai kya? Okay. So we saw in the morning that how we struggle with soft cataracts. But though me and Dr. Deepak, we all showed how successfully we manage difficult hard cataracts very easily. but that is not so in everyone's hand, or that may not be so in every case as well. So this particular case being managed by my colleague, found that she is not able to crack this nucleus. So probably the issue was that the first trench, you can see the depth was inadequate, or probably the nucleus was too sticky and she was little hesitant to stretch it or chop it into multiple pieces. And what it led to was that the separation was not complete till the posterior plate. And the attempts to keep on chopping continued. But you can see from the experience that the surgeon is very gentle with the ocular structures, not doing any violent movements inside the eye, trying to be gentle to try to divide. But probably this is where the experience comes into picture, where earlier in your career, many times you are hesitant to do a particular step or hesitant to make a deep trench. Probably an experienced surgeon would have made a deeper trench and would have cracked this nucleus, might have used a longer chopper, pierced it and completed the case. But here was the case where struggle was going on because the posterior plate, which was a thick one here, was stuck and the pieces were not getting separated. Though she had now chopped the pieces into multiple, the nucleus into multiple pieces, but all were strongly attached to each other, and she was not able to make one free piece which was available for quadrant removal. So what to do in such situation? So that is the question. So here, of course, the consultant asked for help because she knew it was stuck and any desperate attempts further is going to complicate the case. So the senior surgeon takes over and assesses the situation, how it is. And the problem was found that the nucleus is partially divided with the central part is still attached. Okay, so now how to take care of this particular issue? So first, the surgeon tries to further continue chopping, but what I found that once you have, that initial deep trench and chop, then it becomes much easier to chop it further. But if you don't have, you tend to have this, you have to keep on overstretching this nucleus in order to crack till the posterior plate. And you can see that this is, not all cases are similar. So what I'm going to do here is the flower petal pattern. So she has already chopped the anterior part of the nucleus. So here you can see the movement of my chopper. So here I'm using 1.5 long Sinski, and I am not attempting at all to pull out the entire this piece. So I will just show it again. I am holding the anterior part of this chopped piece, partially chopped piece. Then the chopper becomes horizontal and it is as if you are cutting the grass. So you are just cutting the anterior part with the support of this chopper from behind. Okay, so just like how the the field workers do it, if they want to cut the grass, they hold it at the tip and then cut it with a sickle from behind. So that's the moment that will remove these pieces, this anterior part of these attached pieces. And it's very safe because you are away from the PC, you are using a very blunt instrument behind, you are supporting your PhacoTip from behind. So you are just kind of shaving off these anterior pieces very, very patiently. So this is the flower petal technique. You can use, for that matter, any blunt long chopper for doing this technique. And you keep on splitting this nucleus. No need to do over zealous lateral separation as I showed in the previous video. It's going to be detrimental for your zonules and PC. Just keep doing this, Be the field worker for the time being. Just keep cutting this grass. Just hold it anteriorly. Go with your, the long blunt chopper there. Go behind this nucleus. Just watch the movement again, going behind, and try to just push this. And I'm not trying to separate pieces anywhere. I'm emulsifying with my Phaco probe. So I'm using the emulsification power here to cut out these anterior pieces. Okay, so all throughout you can see that I am minimally stretching the capsule as well as zonules. And now as you remove, these anterior pieces, the size of the nucleus becomes small, and then the entire posterior plate itself comes anteriorly. As I think Dr. Deepak was showing how he lifts the central part up and then emulsifies. But in this case, you don't go anywhere closer to the posterior capsule. You just, once the entire nucleus becomes small, you can see that the posterior plate itself comes up, and then you can emulsify everything entirely. So, surgery where for almost 10-15 minutes the surgeon kept struggling for dividing the central part. Using this flower petal technique, just in 3-4 minutes we can emulsify the entire nucleus. All throughout I have kept hylucoat, which is guarding the endothelium. So in flower petal technique, one thing is that the pieces tend to come little anteriorly. So this is a technique of rescue, should not be used as the first technique. First technique I will always use with deep trench and chop, but in case the center is not cracked, which happens in few cases, I think this is a very beautiful rescue technique, and patients will have very good outcome with this. So I don't expect a lot of corneal edema also with this, if I am patient enough and if I am protecting the corneal endothelium with good dispersive OVD. So I think this is one technique which we all should learn. And thank you, Dr. Neha Madam. I think she is also here, so for teaching us this particular technique. Next, I think. Any questions there? Or?
So can we use chopper because it has sharper edge, so it will be easier to cut?
Yeah, so you are asking that we'll use a blunt tip chopper which has a sharper inner edge. Yes, you can use that. But here I think the main important thing is to focus that you are actually emulsifying the anterior part. Okay, that is most of the times what happens is that you are trying to hold and chop. Don't try to hold anything, just keep cutting it. And that simultaneously you try to cut. So even if you shave it off, the anterior part of this, that is fine enough, because then only a small disc of posterior plate remains which you can emulsify.
Can you go back to sculpting and again deepen the center plate?
Yes, we can do that. Only issue is that because here already there are chops made, and again because I am the second surgeon who is going to come and see, so I have lost some amount of perspective where how much the depth is at the center. So yes, that is a good idea to just go and make a deeper trench. But I mentioned in one of my videos, I think what I found is the most important trick to have least amount of posterior capsular rents in your cases is to divide the nucleus when it is whole in the back. That means when the entire nucleus is in the back, you try to do trench divide, you try to do chop. Once you have made pieces or taken out some pieces out of that, whenever you try to use any maneuver, there is a little bit of risk involved, because now fluid exchange, PC has space to come up, and there is a higher risk of PC rupture. So if I am the first surgeon, I may be in a better position to just trench deeper. But when the nucleus has been partially cracked and chopped, I might use this technique, which is I feel safer, because PhacoTip is away from the PC as well as your chopper is away from the PC. Yes.
Thank you.
Sir, in hard cataract, then how do you decide on first go that I will do a divide and conquer vis-a-vis a direct phaco chop? What is the take-home message for the audience here, that when we have a hard cataract, what should we do as a first technique of choice? And in second is, if we already have a small pupil phaco PXF case, in that which technique will you prefer?
Yes, so I will explain this from a trainer's perspective. So when a trainee is there who has a minimal experience of phaco, and we want to teach him to do a very hard cataract, okay, so we can teach him either the 4-quadrant technique, or we can show my technique where I do the deep trench and do the chop, okay. So which one we will allow him to do depends on how we feel the surgeon is skilled in doing chops. Okay, so if you have achieved certain level of ability or skill to do the chops, I will prefer you to learn the deep trench and terminal chop technique. Okay, but if you are not so good with the chopping, obviously in the first go I will say that first you learn the chop and then do the hard cataract, because it's always a savior. But if you are not good in chopping but still you want to tackle very hard cataract, then I would advise you to do divide and conquer technique. In divide and conquer technique, I feel personally that it's very difficult for a beginner surgeon to actually achieve a very good separation without stretching the nucleus too much, because they are generally hesitant to go deep. So the Sinski and your probe doesn't reach the depth most of the times, and they are hesitant, and that creates more pressure on the zonules and the back. That's my personal, what I have experienced while training, these young beginner surgeons for doing hard cataract. So I would say deep trench and terminal chop will be easier to teach rather than doing a divide and conquer. Though for regular cases, divide and conquer is much easier to teach.
No, I would like to know theoretically which is a good technique. We are not...
all are good techniques.
If you are a good surgeon, you are doing both, then we would like to master which one.
Okay, I think Deepak will tell his preferred technique. I will tell mine.
See, there is nothing like a blanket therapy for anything, okay? There's nothing in life which is 100%. It is not going to be like that, okay? You have to find your own comfort zone. You have to, you need to understand your machine, what machine your machine is capable of. And I would not recommend this 4-quadrant technique for the black cataract which I saw if you are not having a torsional ultrasound machine, okay? That's the first thing. So many things are there. Your machine has to be having excellent cutting ability. And I would say that 4-quadrant is much more easier for a novice surgeon to learn and master compared to, especially when doing hard cataracts. That is my understanding. Because people find chopping is a little bit demanding for the novice cataracts. So again, it is not a easy answer for you to have it's not an easy answer for us to give to you. So many things come into play. I have personally, for me, I have shifted from a direct chop to a 4-quadrant technique in recent years. When I see these dense cataracts, these black cataracts, I prefer to do now 4-quadrant compared to do a thing. So it's a individualist thing. So it's not an easy answer for us to give. There's no blanket answer for everyone. You have to find your own way to do it. In my hands, I feel the 4-quadrant technique is easier, much more safer compared to the direct chop technique in this sense. So the answer is obvious now.
I would like to add to this 2 points. One is you can learn in one technique, but you need to have the other technique also as a standby. You might like to go with the chop, but if even in a hard cataract you are not able to get a chop, you either have to do a flower petal or a trench. So you need to learn both the techniques. And second thing, as I told, that you need to have a SOP of yours, depending upon, as sir said, various other factors, your own skill, your machine, and your availability of things.
In PXF, then again, is there a clear-cut technique that which we can use? PXF with the hard cataract.
See, the nucleus division technique is of your choice. You choose your technique which you are most comfortable with, okay? It can be different. For some people, they are comfortable with stop and chop. Some people are comfortable with direct chop. Either way, whatever is good in your hands, the best way you do it. The principle is you are not going to stretch the bag or the zonules and while you're doing chopping or dividing the nucleus. That is the bottom line. Choose the technique of your choice. I cannot say that, this is one, the technique doesn't matter, the surgeon matters. Remember that. The surgeon has to be good enough. It is not that, all only direct chop surgeons are good or all direct divide and conquer surgeons are bad. No. The technique is the same, the surgeon is good or bad. Choose the one which suits you the most and then do it. So don't blame the technique. Yeah. Don't blame the technique at all. The surgeon is at fault. He doesn't know the right way to do that particular technique. So choose your technique properly. All techniques works, I'm telling you.
Theoretically means all technique, they put the same amount of pressure on the zonules. So it
I don't
depends.
believe it. So if the surgeon is not good at trenching, he may put a lot of stress on the bag during trenching. If the surgeon is not good at chopping, while doing chopping maneuvers, he is going to tear the bag. So it's not going to be same. So every technique can cause stress on the bag if not done properly. Doing the technique in a proper way is more important than blaming it on the technique.
And not addressing you, but in general. So think of every case that you do as a case of PXF, as a case of hard cataract, as a case which has zonular weakness. Okay. Only thing, it might not be evident. Okay. So try to have the right technique even in so-called routine cataract cases. Got it? Once you have the safe technique in your routine cataract cases, managing these difficult cataracts become much easier. You don't have to have special powers or skills to manage, very difficult cataracts. Me or Dr. Deepak, both of us do not have any, above average human skills. We have also learned through the same way. The thing which we have learned is that we apply it in each and every case. If you see Dr. Deepak's regular cataract case also, he will be doing with the same gentleness or with the same precaution as he does in a case of PXF or a hard cataract. Okay, that is the trick, to have that repeatability. That's what I mentioned in my talk. The technique is to have the same repetitive, boring movements all throughout all surgeries. Okay, not to make it a kind of a dynamic thing or kind of a romantic thing that every case you are dealing with a lot of adventure and you are coming out victorious. That is not the thing. You have to keep it very repetitive, very boring. That's how you become a better surgeon always.
Yeah, the common question which is from trainees come and ask, directly they say, we want to learn direct chop maneuver. So they have some sort of a, what is fancy, or it is like, a surgeon who is doing divide and conquer and stop and turn surgeon is a lesser surgeon compared to a surgeon who is a direct chop technique. So this concept, you have to just get it right. Like, there's nothing like, less, skillful or more skillful than that. Our goal is to ensure that surgery is safer and you can get equal results with all of them. So just for a completion's sake, this is a new or it's old, which I have learned it recently, is using the Gupta ring here. The preferred one always was the one which we use is the BX ring. Now this comes in and you have to inject it through a cartridge. This is a regular butterfly cartridge which we have for our your hydrophilic lenses. Just load it and push it in. It is an Indian mimic of Malugin rings. Malugin ring is expensive, so we don't have, we can't afford it for us, but it works in a similar way. I just want to share a few tips. No financial interest here, nothing. It is, the advantage with this is slightly bulkier. The thing is, you can achieve better pupil expansion compared to a BX ring. So usually, the 3 scrolls get engaged when you enter into it. Okay, so the 3 scrolls get engaged. The 4th scroll, you're going to just go in and hook it with your Sins cube. So I'm going to use the Sins cube to engage it, and then you can always go in and so removing is slightly tricky here compared to your conventional BX device, simply because this is a biplanar device. So when you're removing it out, okay, let me just go through the removing part. One small tip which I want to share here is, you disengage here as this is done. Use just a Sins cube to disengage from the pupillary margin scrolls. So, and when you're trying to pull it out, there is always a chance that the scrolls, because they're at different plane, they get entangled into the incision or the iris or something. Incision is the more common thing. So what you do is, I'm using an iris spatula here in my left hand and the McPherson forceps in the right hand. You press it down so that you keep the iris and the wound away, and then you pull it out. So this is one small trick which I wanted to share it to you. The advantage of this over the BX is that you get better pupil expansion. You can note the sphincter tears here already. So it itself causes a sphincter tear because it's so sturdy and bulky. So that's how it is. Now moving on to the next case scenario, this is our what I describe as the IOL trap technique, wherein you want to place the lens in the sulcus. Now this is an extremely dense cataract, and patient also had an angle closure glaucoma for which an iridotomy has already been done. So you can see that, as soon as you touch the capsule, you can see those wrinkling of the anterior capsule, radiating folds which are coming out. So that indicates that the zonular stress is enormous. In this case, I raised the flap with the needle because it might be difficult to perforate with the capsule itself. You raise the flap with the needle and then you do a rhexis. The most important thing is you need to have a rhexis of an adequately large size. So the pupillary dilatation is about 5.5 millimeter. That should be the minimum size which is of having, you should have it. So in this case, again, as we were discussing, hydrodissection is very, very critical here. You should not proceed to other steps until you are sure that it is there. And you can see, when I try to decompress the bag is moving around. So its bag is moving around. So this is a situation where usually I would like to stabilize the bag at this stage itself by inserting the CTR. So usually, traditionally, we have been taught that defer the insertion of CTR as much as you can. But in this situation, I prefer to always put the CTR inside first. So the trick here again when you're trying to put in a CTR is create some space within the bag by injecting OVD under the rhexis margin. And then the CTR can be threaded into it. So I prefer to always put it from the side port incision, and then the left hand always pulls it so that it doesn't cause any stretch, and then finally it is just negotiated into the rhexis margin. Now you have an equatorial stretch and a support by the ring. In this case, the bag is now reasonably stable for us to go ahead. Now the question was, in a pseudo-exfoliation case, dense cataract, what nucleus division strategy which you are going to use? So again, it depends on your thing. So in this case, let me see what I'm doing. I'm doing a trench. It is about 80 to 90%. And again, I'm resorting to my 4-quadrant technique. And when you're sculpting, you see that the bag is stable. There is hardly any push or push on the nucleus or the bag. And this message is to drive home the point that the technique of your choice is good enough. Like, it's not necessary that, by trenching you're going to exacerbate the zonular weakness or either way. You can do whatever technique which suits you. The same principles are going to be used to divide the nucleus and pull it out of the bag. So in this case, I would just want to show you the concept of the IOL trap technique. That's what I'm using. So in eyes is generalized zonular weakness. So you have a CTR, how do you try to pull the cortex out? A lot of phobia is there that when the CTR is inside, you will not be able to strip the cortex very easily. That's the reason why you defer it. It is an actually, I think, overdone statement. It is not much of an issue here. You just have to visualize it well, very slow, and make a tangential sweep across, if at all you find it very difficult. It is really not so much of a difficulty in stripping the cortex. Sometimes you can see that the bag would be coming, but it is worthwhile. You can see, I'm vulnerable to go and catch it. Just leave it, you leave the bag there. And in this is what I want to emphasize here is that the haptics are now being placed in the sulcus, and then you have to remove the BX device first because we want the OVD inside before removing it. And then the OVD both in behind and in front is then aspirated and irrigated out. This stage with the irrigation cannula in my left hand, I'm going to push the optic back into the rhexis margin. This ensures that you have the ovalization of the rhexis. That's a clear-cut sign that we have achieved a good optic capture. I'm using a Y hook to retract the iris and see that the optic is gone behind the lens and haptic is in front of the lens. So this ensures that it is well centered, and the idea of using this technique is that you have a better chance of ensuring long-term stability of the lens, because what happens is over a longer period of time we realize that the lens dislocates over a period of time into the bag. So the idea here is we want to have the haptics in the sulcus with the optic behind, and that 360-degree stretch is being provided by the CTR in the bag. So this is what we are hoping that it is going to hold the lens in the place for some duration of time. Now let me go through a similar case where I had a lot of difficulty and just want to share that with you. So this is again a similar case, dense cataract, and visualization is not great. In elderly people, the corneas are not very clear for us to visualize that as well. And this is my plan actually, use BX ring, insert CTR, use IL trap, and I also kept the standby iris claw lens in the worst case scenario if I lose the bag. So that is the plan which I have, and let us see how things turn out. So we want to see well, that is the first thing, we don't want any intraoperative meiosis to happen. So don't have any confusion regarding using a device for iris pupil expansion, this device. The first thing is always, you want to get the pupil expansion out of your head, just put it and then you plan. So in this case, I have used a BX device, and as I'm putting it, you can see that the bag is really wobbly behind. So when I touch the capsule, you can see the entire bag is moving, and I've created a tear. And when the zonules are weak, you can also notice that the rhexis becomes slightly smaller than what actually we intend to make, simply because the counter traction by the zonules is not there. So you wanted to have a 5.5 millimeter or 6 millimeter rhexis, you end up having a slightly smaller rhexis than this. So again, you want to do hydrodissection. I don't want to proceed before ensuring that the bag is real, the nucleus is totally free from the bag. You can see that the bag is moving around. So I thought the first thing always is to go ahead and insert a CTR. In this case, I'm going to use injectable CTR. I'm trying to negotiate it. It has gone into the bag. And I'm hoping that the CTR is now going to do the job for me, and it is like the previous case was. So I thought it will be, this job is done enough. And but the problem with this was, the bag was still not good enough, and now I thought I would want to use a capsular hook here. The problem with my thing is, I've lost the visualization of the rhexis margin. So I want to hook the capsular hooks. I'm not able to see the capsular margin well enough. So what I do is, I go ahead and try to stain the capsule once again. It doesn't stain so well because already come in contact with OVD. The staining is not great, but still you get some clue from where it is. So I'm just trying to identify the capsular bag where it is. So I'm plan to use the capsule hooks, and this is again, these are very bulky. In India, this is what we get. These are very bulky than what we can see. If you just look at the proportion of the thickness and the thing, it is very bulky for this eye. But in India, this is what we have. I think this is made by Madhu Instruments. And I'm able to see the capsular margin because I could go ahead and, this is the capsular margin. This was not visible for me before restaining it. So I restained and ensured that I could see the bag well. And now I have used these 4 capsular hooks to stabilize the bag. So once the bag is stabilized, now the idea of using this hooks came because the CTR alone was not good enough for me to proceed with phacoemulsification. So that is the reason why I had to use this. So you have a pupil expansion device, you have a CTR, and then you also have a capsular hook to stabilize the bag. And observe the arcus which is there, which is quite dense, and the elderly man. These are the patients whom you have a lot of problem in seeing well as well. So in this case, I decided to do the stop and chop and trying to make a long trench. So the central part of the trench has to be the deepest, as has been told repeatedly in this, from the last 2 days which we are trying to tell. And when you're trying to rotate, look at the right hand instrument. The PhacoTip also is aiding me in rotating the nucleus. So this is one way of rotating the nucleus with lesser stress on the bag. So now I ensure that the posterior plate is truly broken, and now is the time to do the chopping maneuvers. You bury the tip, and the chopper goes directly in front of it, and then you go ahead. And you don't expect it to crack in a single way. So you have to place the chopper at a progressively deeper plane so that you get a full thickness crack. So now, once it's there, you're going to pull one of the fragments out of the bag. This is going to help us to create some space. And the moment your capsular hooks go and engage the bag, the phacoemulsification part becomes extremely safe. The only thing is, it's a little bit laborious to go and hook it and all. So, but it is worthwhile in such situations where you're very keen to save the bag. So you can see that the bag looks to be very stable, not an issue at all. And I'm trying to be as slow as I can when I'm trying to remove these fragments. So this surgery probably took me about 40 minutes for this, but it is worthwhile the time which you want to pay. So another important point we need to remember here is that these are the eyes wherein the risk of fluid misdirection is possible. So be mindful of that. So in retroelimination mode, now I'm realizing that there could be a situation where the Descemet's membrane could have detached in the area where I have hooked in the capsular hooks. So I'm trying to do the cortex aspiration removal. So I'm just putting in OVD, and now because I want to do the IOL trap technique, so I have to release the capsular bag. So I'm just disengaging the hooks, and the capsular hooks are out now. And I'm going to use cohesive OED under the iris to create some space. The multipiece lens is gently dialed inside, and so again the BX has to be out now before that. So first I removed the capsular hooks. Now is the time to remove the BX device. So you're removing the OVD. So again, the same principle of I can see the floor there. That was the one thing which I was thinking that it was, let me see whether we can find the DMD here. So this is the IOL trap. Irrigation canal is in my left hand, and the optic is being pushed back so that we achieve an optic capture. So that is the DMD which is seen there now. The DMD flap I'm trying to retract and see. So I just want to ensure that I'm trying to do an iridectomy because I have decided now to put in gas here. So I'm trying to do an iridectomy here. So this DMD happened there, as you could see, probably during my, so I'm doing okay. So the second iridectomy is being done here because I thought I was sitting superiorly and I did the inferior iridectomy. Now I realize I was sitting temporally. So, what happens, the mind when it becomes clogged, so many things happen. Now I'm doing an iridectomy at the 6 o'clock. So the patient has 2 iridectomy. Now this is the step where I'm decided to go and inject a C3F8. So look at this, the 0.4 ml is the gas there, and we are going to pull the syringe to make it, this is 0.4 ml of gas. And then we are going to draw it and make it up to 5. This is going to give us the desired concentration which is required for a non-expansile concentration. So putting in the gas here. So it's when you're planning to have an expansile gas, it's worthwhile to do iridectomies because you may end up having surprises of a pupillary block later on. So this is how the eye looked in the 3rd post-operative day. And obviously you need to monitor by doing OCTs, and thankfully over a period of time it did settle. So these are tough cases. Given a second time, you would have thought better ways to manage this. That is, thank you.
Next will be the last talk before the lunch session, and after this talk there is a small quiz, and then we'll break for the lunch. Yeah. So switch off the lights, please. So in this video, what I am going to show is certain basics of CTR. I have chosen these particular cases because of good visibility. So this is a very high myope patient and with very early nuclear sclerosis and refractive changes. So she wanted to get rid of glasses. So we decided to do the cataract surgery, and you can see the lens margin there when I injected viscoelastic, indicating that zonules might be weak. As you can see, when I started the capsular axis, as we expect in these cases, it's very difficult to make a puncture with the forceps, so I have to use a needle, cystitome needle, to make the first puncture. And then with the forceps, I have to advance this. So usually for these cases, I use the microaxis forceps so that the anterior chamber is throughout maintained. And as we were discussing, the counter traction from the zonules is less, so we have to have short movements, tangential movements. So we should not be pulling this capsular axis stair anytime centripetally. So you have to always go tangentially. If you pull it centripetally, because the zonules are weak, we might have either extension or we may have increase in the zonular damage. So this is what I am doing, going tangentially. Sometimes if it is too weak, I might have to hold using another blunt capsular axis forces, just hold the capsule and complete the capsular axis. Now cataract is soft, just very minimal nuclear sclerosis there. So I am going to just do hydro and probably prolapse it out. So in this patient I did both eyes. So in one eye I decided to put the CTR later, and one eye I decided to put the CTR first. So in this case I didn't put the CTR because I thought the zonules are alright. I can just do the phaco aspiration there. But when we have not put the CTR and we are trying to remove the nucleus, in case of even weaker zonules, it's better to use capsular hooks like what Dr. Deepak showed. But here my judgment was that zonules are all right, so I went ahead without capsular hooks. But when we are doing the cortex aspiration, at that time you have to be very, very careful in these cases. What you have to do is sideways movement of this. Even if you have not put the CTR, try to do these transverse movements. I think there was one video on the Apple Miyake View where it was shown that when you do this stripping of this cortex in the transverse manner, the stress on the zonules is least. So if you are pulling it something centripetally, you are putting more pressure on the zonules. So that is what has been done in this case, very gently. And in order to stabilize the bag, I am going to put the CTR. So here it is important to have right size CTR. So first I chose 10-12 CTR size, but when I put it on the eye, you can see it's very small for the eye. If I put this particular CTR, it's not going to stabilize this bag, which is looks much bigger because it's a myopic eye. So I had a preloaded CTR as it was shown. It's a 11-13 millimeter CTR, and these preloaded CTRs have right and left sides. So this one is the right sided CTR which I had. So I was implanting it for the first time. So let's see how it goes. So it is withdrawn first before you inject, and then you inject. So I think important thing while injecting even this CTR is that you have to go very slow. If you push this CTR against the bag, sometimes you may rupture the capsular bag without knowing, and it might just go into the anterior vitreous. So go very slow with this, and here I think you can go with the cartridge in the bag itself, and then you can release it. But here it was released a little prematurely, so I can easily now nudge it into the bag using the Sinskey hook. But overall, I think this preloaded CTR makes more sense than doing manual insertion. Only the cost is little bit maybe higher. And I did the same IOL trap technique as Dr. Deepak showed, and it's a very good technique for these cases where the IOL remains much stable. Now for the second eye, as you can see, the bag edge is seen more. So I was expecting more zonular weakness in this eye. And so I decided to put the CTR first. So Again, similar things followed. You can see that it's like a copy of the first case where it was little difficult to again make the first tear made with the cystotome. Now here, instead of micro forceps, I am using Haltipurkar forceps and using the same, but you can see whenever you use these forceps as compared to micro forceps, there is more visco leak which happens at the incision, and that's why sometimes I prefer micro rhexis forceps over these forceps. Now here, generally what I do if I want to implant CTR when the nucleus in the bag, that I do first gentle hydrodissection. It is better to avoid complete nucleus prolapse because it makes things little bit difficult, particularly if the dialysis is more. And I inject the dispersive viscoelastic agent just like how we do in viscodissection. And the idea is that it might release little bit of cortex from the capsule, so the cortex aspiration afterwards becomes easier. So now I had, this one was other side, the direction was other side. So I am going to inject it into that area where I have done viscodissection. So I have created that space you can see on the left side into which I will be injecting this CTR. And again go very slow with the insertion, don't be very fast. Now here I felt that manual insertion would have been maybe easier because I could have just got it over the cortex, but this was also okay. So I'm just continuing very gradually inserting this CTR. Okay, so this is the actual way or actual speed at which we are inserting. So make sure that injecting CTR is not a very fast thing that you have to do. You have to go very gentle, because even injecting CTR itself might damage the remaining zonules. So you don't want to induce more damage while injecting CTR where you want to protect the further damage. So once that is done, the nucleus can be aspirated very easily. And then we come to the cortex removal part. Okay, so this is where a little bit of difficulty comes, but as Dr. Deepak said, it's not very, very difficult. Only thing you have to make sure that you keep pulling this cortex, in tangential manner. So basically what happens is that this cortex travels over the CTR and then it gets aspirated. But there are places where this cortex may not be trapped under the CTR, and there it might come off much easier. Okay, so just be very gentle, because here, because it's trapped under the CTR, many times if you pull very fast, you might be pulling the entire CTR IOL back complex, CTR and the back complex, and it may damage the zonules even further. So the patience and very slow movements is the key to release this cortex from all sides. As Dr. Deepak was showing with the bimanual, the same thing I am doing using the coaxial IA. So again, whether to use bimanual or coaxial is your choice, but the technique remains same, that you have to be very, very gentle in releasing this cortex from the bag and remove it. So in conferences, many times we show edited videos where this is not highlighted, like how patiently we have to work on this to avoid any complication. So I think while showing this, I have less patience, so I will just forward it. So at the end, I used little bimanual because there was little cortex which was trapped, and this is the IOL trap technique. So I will just skip it because we have shown it very nicely. Dr. Deepak has already showed, but I will show maybe the 3-piece insertion on the 3D. Just I will show the loading part also. One moment. Yeah, so I am using the C cartridge here. I have placed the IOL in that groove. 1 second, I just lost it. Yeah, so the trick using C cartridge for injecting Alcon 3-piece IOL here is that once you put the visco and then put it in the cartridge, with the flat part, just press little down on the optic and push it further so that the trailing haptic goes little downward. And then when you are pushing the plunger, just keep a watch on that trailing haptic that it should not get kinked or damaged by your plunger. That is the only thing. And then don't push it all the way till the end, because that is the narrow part. Just push it in till the middle, and the last part you should inject at the end, so the leading haptic is not kinked. And the moment the haptic comes out, just rotate it clockwise, so the leading haptic goes to your left side. That's it. And then you flick the trailing haptic to your right side, and then you can dial it easily. So here as well, I did the IOL trap technique. I think it's a very good technique that Dr. Deepak has described. And what I found is that if we put the IOL completely in the bag, you will always have a little bit of that pseudo-phacodonesis in the post-operative period. But when we have this IOL trapped, where the haptics are in the sulcus and the optic is in the bag, we find that the pseudo-phacodonesis is much less. So we can hypothesize that this IOL bag complex is going to stay for much longer period, hopefully for the lifetime of the patient. Okay, that's it. Thank you so much. So after this, if there are any questions. Yes, so Deepak.
It will be the same power, because the optic is in its natural position only, so it's not going to change. The question was, would you change the IOL power? No, you don't, not necessary.
We'll start with the quiz.
So in this case, there is zonular dialysis and we have issue inserting the CTR. So watch the video carefully. Can see the zonular dialysis there, almost 3 to 4 clock hours. So before releasing the other end, surgeon just retracting the iris. The other end is not seen there.
Yeah, so surgeon is basically inserting the CTR. He thought, of course, on 2 dimension you cannot see it well, but that's what he must have thought, that the CTR is probably not going into the bag. So he looked for the other end and it was not there in the bag. So what will you do in such case? You can raise your hands and answer. Neha madam, tikde mic then.
The CTR is probably in the sulcus. One can leave the CTR and put a second CTR and go ahead.
Okay. Any modifications you want to do while inserting the CTR again, or same
I guess
way?
just inflate the bag really well
Better.
and make sure that the first loop itself is under the capsule.
Yes. Okay. Next. So we'll go to the answer. So that's perfectly right, that the CTR is not in the bag as it was intended. So this is how it was managed.
So anyway, this CTR was this thing islet was not released, so it was taken outside. Now the surgeon is trying to put the CTR from the other end of the zonular dialysis. So this is the one more option you can think of, that change the direction of the CTR, change the placement of the first support of the CTR, and you can place it in the bag.
Okay, I think that's the end of our pre-lunch session. So we'll break for the lunch. If there are any questions before we go for the lunch break, we are open. We'll start exactly at 3 o'clock. So gather here 5 minutes before, so we can start right on time. Come kare? Should we reduce the lunch hour? We have a lot of other videos to show. Lunch mein? We will be also taking feedbacks from all the delegates. So those who finished lunch early.
Task well then.
So for how much degree of zonodialysis you would prefer a CTR or would you go for a capsular hooks?
3 clock hours.
Okay.
3 clock hours, otherwise CTS. It has to be supported by CTS.
Okay, but when will you use capsular hooks first? Okay, would you start with capsular hooks?
My preference is in a case of generalized zonular weakness. No, my first preference whether only CTR works well, because you avoid that 4 additional ports. That's the only idea. If it is not working, then you have to use the capsular hooks. Or in situations where there is a gross zonular dialysis, okay, the gross zonular dialysis more than 4 clock hours, and that situation you are planning a CTS, then you have to use a capsular hooks. Should be very clear cut with this.
So we have very good videos in the evening, so those things will be answered definitely.
Thank you, sir.
So the first video post lunch session, I am going to showcase.
This video is part of PhacoTips 3D teaching course,
where the patient came with a decentered multifocal IOL which was in the bag, and thinking about what can be the probable cause. So this patient gave history that a patient is one-eyed, so other eye has poor vision because of corneal opacity, and this was the patient's seeing eye. 3 years back, patient underwent cataract extraction with multifocal IOL implantation, and as per patient had fairly good vision in this eye for last 3 years, but last few months patient was noticing that the vision is deteriorating slowly. So obviously the IOL is decentered. YAG capsulotomy has been already done, and so the only solution what we can do in this case is to replace this decentered IOL. And I was thinking what could have been the the cause for this kind of decentration, which is IOL already placed in the bag. Because post YAG laser we don't expect these decentrations. If the haptics are well secured in the bag, we generally see that post YAG laser also the IOL remains well centered. One possibility could have been that there was probably a dialysis or peripheral, maybe PC rent during surgery, and the IOL stayed there for a long time, but as probably the support reduced, it kind of started decentering. So first thing I am going to inject a 1.4% hyaluronate there to maintain the anterior chamber. Now the IL is there in the bag for very long time. So in order to remove it, we need to release it from the bag. And also I want to tamponade the vitreous there, because YAG laser has already been done. So now I am going to make another incision, so that will help me in maneuvering this IOL out. Now you have to be very gentle while doing this. The primary aim or goal here while removing the IOL from the bag is to maintain the integrity of the zonular apparatus, so that if I want to place the IOL in the sulcus, it should have a stable sulcus. So I am using these two Sinskis to gradually just try to pull this IOL out of the bag, and it appears like a hydrophobic IOL. And generally there are more adhesions with hydrophobic IOL, but even in hydrophilic IOL we sometimes find that the haptics are more adherent. So here I am going to pull this or separate this IOL from the bag very gently, and still I am a little wondering like why this IOL has decentered. So now I have shifted to a forceps, which will help me holding this IOL and try to separate it from the bag. Again, as I said, the main thing which we have to watch for. Can you switch off the light? Light switch off. Main thing what you have to watch for is whether whatever maneuvers I am doing, whether it is causing any traction on the capsular bag. That is something we have to watch for. So now you must have realized that when I pull this optic out, the haptic of this IOL is already broken. So the primary surgeon had implanted this IOL with the broken haptic in the bag. Can you switch off the light, please? So releasing the second haptic is very important, because see, you can see there is a lot of adhesion with the second haptic. So the trick here is to be patient. You have to release it very, very slowly. More gentle you are, there is a lesser risk that you will damage the bag here. Again, I am injecting 1.4% hyaluronate here into the bag, so that I can just tease out this haptic, which you can see is around that area. The bag is fibrous, so I want to gently release it. So using visco dissection method for releasing this haptic is a good idea. Also it maintains the anterior chamber, avoids any shallowing, any vitreous prolapse. And after pushing some OVD into the bag, again I am trying to tease this haptic out of the bag. So this side of the haptic comes off now. So you have to pull it out in the same way, in the same direction of the haptic, rather than pulling it centripetally. So rotate it basically, and here the entire IOL now has come into the anterior chamber. So I think the take-home message is that if you have these kind of damaged IOL with the one haptic missing, if you place in the bag, probably in the next few months of post-operative period, patient might still be okay. But in the long run, it's not going to stay, and obviously patient is going to blame you for putting that kind of IOL in the eye. So you have to be very watchful. It's better not to keep any damaged IOL in the eye. So here I have decided, I have taken a superior incision because that is the steep axis, though the astigmatism is very minimal. So I have done a kind of a corneoscleral incision there. And I'm going to now cut this IOL in the anterior chamber. I have already injected a heavy dispersive agent to protect the endothelium there. I use this technique normally. A longer Sinski is used to give a counter traction. I use this Packer-Chang scissors through the incision, and the advantage of this scissor is that it is a cross-section scissor. So in the incision, usually the opening of incision is very minimal, and you can cut it open, cut the IOL very easily. And believe me, it's not difficult at all. The only thing you have to maintain the same thing, that you don't press on the incision anytime and just cut. So I generally cut beyond 50% of the optic. So around 70% of the optic is cut. And after that, we can just pull it out, rotate it around the incision. And most important thing here is to always protect the endothelium using a good heavy dispersive agent. Don't use methyl cellulose in these cases. Use a combination of chondroitin and hyaluronate. Because the mechanical trauma to the endothelium is much more severe than what we cause by phaco energy as well. So you have to be very, very watchful here. So my left hand Sinski is used so that the optic stays down and doesn't hit the endothelium there. And I'm using microforceps through the main incision. I'll just grab one of the pieces that I have made and pull it out through this incision. And what happens is that this one half comes out through that incision, because I have divided into two parts which are joined together at the hinge. And once one part comes out, you just have to rotate this IOL. So I am rotating the IOL around this incision, and it just comes off very easily. So there are many, many techniques of IOL, and you can see that one haptic is already damaged. So I think that is the take-home message, that never leave these kind of IOL inside the eye, and patient is going to come back and blame you for this kind of issue. Now I'm going to just check if there is any vitreous strand or anything, and clear it off before I place the replacement IOL there. So some bleeding has occurred from the corneoscleral because I have cut the conjunctiva there. So little bit blood has trickled down, and there is no vitreous as such in the anterior chamber, but I decided that I will remove the vitreous, whatever is there behind the posterior capsule. And you can see here, so quickly the vitreous comes out. That's because this patient already has a complete PVD, and these are the cases where, as I was mentioning in the morning, that vitreous just keeps coming when you start cutting it, and that's because it is already detached from the posterior side, and that's why more you cut, more it will keep on coming. But that's okay. These patients do not have any risk of retinal problem, because now, because the PVD has already occurred, generally you don't tend to create any more retinal breaks. Idea is to do just thorough vitrectomy before you move on to the IOL implantation. So I will just move on, because we have seen a lot of vitreous vitrectomies there. And that's the end of the vitrectomy. And now one more important message is that now you can see that I have removed the IOL from the bag, but I am still not sure whether the sulcus is good or not, because this patient has been operated elsewhere. So it's always important to visualize. If you have any doubt, like whether there is a peripheral tear, peripheral dialysis, I think the iris hooks are very useful in these cases, where you can just retract the iris, watch everything, and when you are putting the IOL in the sulcus as well, it can be under the watch that the haptics are going right into the sulcus, and they are not diving down into the vitreous anytime, because that is another common problem that we may have, that after managing everything, if you are putting a 3-piece IOL and it just dives down, you have another issue in hand. So I'm placing the iris hooks now to retract. On one side you can see that anterior capsular rim is quite nicely seen, and same thing on the other side also we'll see. and you can see the iris. Once you retract the iris, we can see the anterior capsular rim here. Though the rim appears quite large, that means the anterior capsular axis probably was quite large. So once I'm sure that the sulcus is there and it can support the IOL in the sulcus, I will just push through this, because we have already seen it in the last case how to implant, and I will just show the trick here. So wherever we have cases where the PC is open and we want to place any IOL in the sulcus, always use your left hand instrument properly. Use that Sinski to guide the IOL properly. We don't want it to dive down into the vitreous. So always make sure that it keeps pushing that leading haptic upwards into the anterior chamber, or if you want to directly put it in the sulcus, fine. But I generally advise beginners to place it in the anterior chamber first, and then you can dial it. So first the trailing haptic I am going to dial first into the sulcus, and whenever I am dialing the 3-piece, I always make these movements. That means I don't dial generally in one go. I usually dial one haptic couple of clock hours, and then again I sometimes dial the other haptic couple of clock hours. This is for better safety of the zonules. We don't want to damage it. So once the IOL is nicely placed in the sulcus, then remove the iris hooks and then do the visco wash. So a few things to learn here. I think first most important thing, if you have damaged haptic of the IOL while doing surgery, don't leave it there. I think it's better to replace it. Even if you don't have it in your the stock, you can wait, you can just postpone the surgery, and putting the IOL later is much easier than keeping that damaged IOL inside the eye. So that's it. Thank you so much. So this was the first video after lunch session. And if there are any questions, definitely you can go ahead, and after this we have a toric IOL session. Yeah.
So there's one question. Dr. Ritika is asking about, please tell us about the IOL cutting scissors.
Yeah, the IOL cutting scissors used is designed by Packer Chang, so it's similar type of IOL cutting scissor. It's made by Indian company CardioCare. You can also have it in MST with disposable tips also. So it has a very nice design because it's a cross-cutting scissor, and advantage is that because it's a cross-cutting scissor in the form similar to vitreoretinal forceps, so there is no movement at the incision when you are cutting this IOL with this forceps. So it's very easy to use as compared to other IOL designs, IOL cutter designs. Yes. We'll start with the toric IOL session. 2D. So first talk will be by Dr. Deepak on toric IOL basics.
So I want to have a raise of hands here. How many of you are doing toric IOLs? Sorry. Yeah, light please. So we have about 50%. Okay, because you have all attended PhacoTips 4.0, by the time you reach home on Monday morning, 100% of you would be doing toric IOLs. I believe that, okay? So that would be our motivation. So, okay, I think we can off the lights now. So why is it relevant actually, So many studies have shown that, there is a significant amount of pre-existing astigmatism. That is, at least 40.5% of them have at least one diopter of astigmatism pre-operatively. And now with the availability of the toric lenses and the know-how of this, I think we can benefit, this many more patients now. And of these all, 70% of them are having against the rule astigmatism. See, the relevance of against the rule astigmatism we want you to understand, because the against the rule astigmatism is a progressive condition. A person who is having one diopter ATR when he is 60 years old would become maybe about 1.5 or 2 by the time he becomes 80 years old. So we need to understand, because as we age, we drift from with the rule to against the rule astigmatism. That is a common concept we need to understand. So of course the quality of vision is significantly sharper when we don't have a residual cylinder, or we can minimize the amount of cylinder preoperatively. So in my practice in our center, this is the thumb rule which we follow. Against the rule astigmatism, which is 0.5 or more, the patient is eligible or is advised a toric lens, whereas a person who is having with the rule astigmatism 1.25 or more, then we'll advise a toric lens. The reason is obvious, as I told, ATR is progressive, and with the rule astigmatism is going to shift to ATR over a period of time. So let me just re-emphasize, what do you mean by ATR? By definition, we know that the vertical meridian is flatter than the horizontal meridian. In reading, it means that you have a cylinder. When you do a K reading, you have a cylinder of minus 190 degrees or minus 175 degrees, minus 105 degrees, or plus cylinder at the axis of 165 to 15 degrees. That is what we call as a ATR. So when you do auto K, you usually get in minus cylinder formats. When you do it in your IOL master or something, you get in plus cylinder formats. So be sure that anyway from 165, 160 to maybe 20 plus cylinder is an ATR, and that is the most common form of pre-existing astigmatism which you have. And with the rule astigmatism, younger the patient, it is more common to have an with the rule astigmatism. So IOL, one of the reasons was barrier cost was there, but nowadays we feel that the number of Indian lenses are available, the barrier for the cost has come down now. See, there are three important steps when you in toric IOL practice. You have to measure, you need to calculate, then you need to mark, and then you need to align. Okay? So measure, calculate, then you need to mark it preoperatively, and then you need to align it in the surgery itself. So these are the steps which are involved in a toric IOL practice. And you need to very clearly understand that errors can happen at every step. You can go wrong while measuring, you can go wrong while marking, and also you can commit an error while aligning in the eye itself. So what are the most common ways of measuring the astigmatism? Okay, we have, these are the common things: keratometry, topography, and tomography. And the most common question which is asked is, can we practice toric lenses with just your auto K which we have, autorefractor keratometer, because we may not have access to an optical biometer, topography, tomography. See, in the ideal world and the ideal situation, if you have got access to all these instruments to measure, it is better, because you get an overall view of the corneal counter. But if you don't have access to these, even with just your autokeratometry and your immersion biometry also, you can practice toric lenses. That is the first message, take-home message I want to give it to you. This is with my experience, because some of our peripheral centers, we don't have access to topography or an IOL master. We just do it with your immersion scan and auto K. Still, we can get reasonably good results with even that. So the first myth you need to get out of your head is that we can practice toric IOLs only we have access to all this equipment. No, at all. If you can do your measurement with your conventional biometry, the same thing you can do. So autokeratometry which you have is good enough for you to implant toric lenses. So the only question is, how do we rule out irregular astigmatism when you don't have access to topographies? See, your auto K readings, the simple method would be take multiple readings in that patient. Okay, you should get consistent readings in that patient. And if it is consistent, 3-4 readings consistently, both in terms of diopter as well as the axis. The reading comes in, one is a diopter and second would be axis. If there is not significant variation in the multiple readings which are taken, that is good enough. The patient is having corneal scar or bad astigmatism, then every time you take, it might come differently. So in those situations, if the readings are inconsistent, then you can rule out the patient for toric lenses. So there's a simple way to just select your toric IOL patients. Simple way. So basically, you're coming to the technicalities of it. Okay, now you have measured. So let me just re-emphasize that when we are measuring, ensure that the patient, when you're taking the patient, you don't put any local drops or any drops when you're trying to measure the corneal curvature. You know, we want the cornea to be pristine and with a very functioning tear layer, so that we get the more predictable readings. So whenever the cornea, you put a drop, what happens is the tear film is, is hampered and we don't get a clear thing. So it is better, because if you are doing the thing, you can already see the Myers. The Myers will be very clear and well defined. But if the Myers are not well defined, then the surface is not good enough. Maybe you ask the patient to wait or come other day, or put some lubricating drops and then try to take a reading. And second would be, try to ensure that the head position is absolutely straight on. It is quite difficult, especially when you're doing an auto keratometry, because you're not visualizing. Same with the IOL master as well. But try to at least ensure that the head is straight and not tilted enough. That is one way of doing it. Now moving on to the marking as such, you know that the marking, there are two markings which we have to do. First, the reference marking, and second would be the axis marking. See, the patient, the IOL has to be aligned at 135 degrees. To align IOL at 135 degrees, first we need to understand what is the reference, that is the 0, 180, for which you are going to then measure the 135. So measuring the 0, 180 degrees becomes the most critical aspect here, the reference marking, because on the basis of the reference marking, you are deciding to plan your axis or mark your axis. So most errors happen because of errors in the reference marking. So this is something which we need to understand here. So of course we have manual marking versus digital markerless devices, and I'll be speaking on the manual marking method because I don't have access to the digital versions, and how best we can do to minimize these errors. That's what we're going to study here. Let me show you the video here, and if you have any doubts now, you can just write down, and maybe you can discuss with us at the during the end. And I'm just trying to search my video. So I'll be showing it, how we mark at the slit lamp. Okay. Now, the first basic principle is, you want the patient, the head has to be straight. There is this error which can happen while measuring is there will be slight head tilt. That is one error which can happen. And we make a slit beam which is very thin, and it has to transact the Hirschberg reflex which we are seeing there. So that is where we are going to do. And the beam is now placed at 0, 180 degrees at the slit lamp, and you can see it is transacting the Hirschberg reflex. So you want to be absolutely sure that it is there. So usually what we do is, we try, and you can use a speculum, you may not use a speculum. Usually this is done after you are anesthetizing. So I'm using a 30 gauge needle here, 30 gauge needle which has been stained now with the stain, and then you're going to create a small puncture there in the superficial stroma. The idea of creating this small puncture is that, even if the list is late and the patient comes out a little bit late, they have the mark is still available there. So you are keeping it there, and you have a fine mark there, and it doesn't spread. The only secret here is you don't have, if the cornea is a little bit dry, you don't have the spreading of the ink. So this is what it is. And now how do you use the iToric app? This is the screen grab which you are. The patient is now, actually I record this at the slit lamp itself. Okay, so the reason is the eye is stable and you have good illumination, and your eyes, you can stabilize your hand while taking the photograph by placing it on the tabletop of the slit lamp. And because I've used a speculum, the exposure is quite good. And so this is when we take a grab. So this is Dr. Saurabh's iToric app. And for iPhone users, there are other variants which you can try. But as you can see now, there are multiple rings. Let me just zoom it. It's not, rings are not visible. Okay. There are rings, circumferential rings which are available there. And we have to correlate it with the limbus, the outer limbus, which I prefer to do this. You place it, and then the app is now going to calculate how much is the camera tilt is there and how much it is off the off axis from the reference mark. So you can see here, what it's showing is the camera is rotated 4 degrees, whereas the mark rotation is 0. I think in the top left hand you can see where my arrow is. This is what it's showing now. So the whatever marking you have done, see the basically why we are doing this, using this app after marking that incision is, we want to know whether whatever we are presuming that it is 0 180 degrees, is it exactly 0 180 degrees or is it off? So in this case, it is showing that the axis reference marking is off by 4 degrees. Okay. So then you have to now you have to enter the axis of placement which was originally planned, and then it will show you how much you are off axis. Now we are off axis by 4 millimeter. So what I'll be typing it here. So I'm just trying to use the caliper to align it. So it is now showing that I entered 174. It is effective mark rotation is 3 degrees away. So we have the final axis of placement will be 171 degrees. So this is how we are going to use this app, and of course you can always use it in the OR also, but this is one way to ensure that it is much more predictable. So again, I'm using the 30 gauge needle to create a small stromal puncture there. So this is how it is going to be done, and you try to be as central as possible, then take a photograph. And then with the image, you have to superimpose these rings here to the best of your ability, and then use the caliper which is given, and just to align your whatever axis, and then now you know that how much of your axis reference mark is actually off the original mark. So you say it is effective mark rotation is 20 degrees. Now you use 178 degrees, and now it shows the new axis of placement is 180 degrees. So this is I have found the best way to be as predictable as possible with your manual markings. So try to do it at the slit lamp and then do it. And of course, you can always do it at your the OT also. Many times I do when the patient, you have a long list, and if there is nobody to mark it in the OPD, when I'll be doing it in the OR itself. That also I'll be showing. So this is one way to do it, and it has helped me a lot. The other way to know whether your axis is really central or is purely horizontal or not is, or the patient is tilting ahead, you have to swing between both the eyes. When you swing both the eyes, it has to transact the center of the pupil. Then only you will realize, whether it is really the horizontal meridian is proper or not. So again, the same thing. So, are you showing the iTori cap in your also? A little bit, okay. So again, you are going to enter. Let me. So it's a very handy tool and very reliable, and it improves the the predictability a lot. That's what I have found out. And let me show the intraoperative part also. I am struggling to find where I have kept it. I think you can show the next. I'll meanwhile search for it, okay? Search for it.
So I think Dr. Deepak has already covered
Hello
some
friends,
part of
this is
iTori.
Dr. Saurabh.
I will just 2D. Okay, so now iToric app is available on the iOS, that is Apple platform also, so it can be used here. So with the same features, so that can be also used. Now basically Dr. Deepak has used it in a very diligent manner and has taken a lot of efforts. I made this app because I am lazy basically because I don't want to mark it on the slit lamp, and these are different methods. So I also used to use the slit lamp marking method before I started, but I used to have a lot of issues. One thing was that I had to go out of the OT and mark it, and patients of course were not always that cooperative. So once I started, so this is old me 10 years back, okay, when I started using this app first time. So what I'm doing here is I just mark freehand, by reference marking, we mean that we need 2 points from where we want to measure the toric axis. So you can just mark freehand approximately 180 degree apart, and this is the first version of the iToric app. Now it's a little bit more improved with maybe more interface is better, and you can zoom in just as I showed, and I will just show you. So what Dr. Deepak was telling about that both eyes should be at the same level, that is what we can see on this app actually. You can see that. So on the app, when you don't zoom it, you can actually see whether both the eyes are aligned. That means both the eyes are in the same horizontal axis or not. And then you can zoom in on the one eye. So that takes care of the head posture part. And once you have that, just click on the patient, the image, and you can use the flash of the camera also and capture it. And rest of the things I think Deepak has shown. So basically, even if you don't have exactly 180 degree marks, you are going to calculate the axis where you want to place based on these reference axis marking. Rest of the things Deepak has already shown. So this is not a toric calculator app. This is for basically the axis marking. So on table you have to use again Mendes ring for the final reference axis marking, which I think Dr. Deepak will show in the next video. Now there are many other applications. I will just skip through because this has been already very well explained by Dr. Deepak. So, and you can also save that data. Dr. Zain is here. Thanks to him, because I was so lazy I didn't even publish any study on this, but he was the first one, and thanks to Zain that this app is now recognized and one of the top apps for toric marking. So you don't need to use anything else basically. And when I didn't have Callisto at that time, I just used to ask my fellows to mark 180 degree, or even my assistant, and then they will just show me the image that this is the mark and this is the new axis marking. We can use the same app for if you are fond of using slit lamp marking, you can also calibrate your slit lamp itself. So that using this iToric app, I have used it in interesting way by using the retroillumination marking. I will just show you that we can use it in a child also. Yeah, see, this was a child which required a toric IL, almost 4 or 5 diopter toric IL, and he was not, of course, very helping for me. So this is the image I have taken on an auto refractometer on infrared mode, and where you can see that zonular kind of cataract this child has. And instead of marking the cornea, I mark these opacities using the iToric app. So now these opacities, lenticular opacities, become my reference axis, And for example, here I will just to elaborate here, the axis of placement was 108, and once I marked these lenticular opacities, I calculated, so new axis of placement was 25 with respect to these lenticular opacities. That is what we mean by reference axis marking. So on table I used the Mendes ring, I aligned it according to the lenticular opacity marks which I have noted on my app, and according to that I now measured 25 degrees from that reference. So these marks I am making at those opacities where I have marked it, and then from there I am going to mark 25 degrees. Okay, so hope this clarifies the concept of reference axis marking. Reference axis marking doesn't always mean 0 180 degree, it can be anything, it can be 90 degree also, or it can be any axis from which you want to mark the final axis. And this patient, I think I did phaco with posterior capsular axis and probably antivitrectomy, place the IL in the bag. This is the end of the surgery. You can see it is according to the aligned marks, and even post-operatively you can see it is exactly placed at the same axis. So this is different innovative ways you can use this app. So you need not have slit lamp marking or any other ways to mark. You can just take a autoref infrared image and use this app. Okay, so this is one way to use this app. You can use the same for even conjunctival vessel marking. So instead of marking it on the cornea, you can use conjunctival vessel ends to mark them on the iTori cap, and then on table take those as a reference marks, and you can mark the final axis. Okay. So I will just finish one more video. You are ready? Okay. So you can shift back to Dr. Deepak.
So we are again marking the reference marking. This is at the slit lamp. So the idea of using this needle is that the mark is going to stay for a slightly longer duration of time. So if we just use a pen, so the surgery is delayed. If the patient is delayed in the list or something, then it just goes off. That's the idea. So now this is I'm sitting temporally, and these are the two reference marks, and the axis new placement has to be done. Now this is, I'm just trying to remark the original marking so that it becomes a little bit more easier to visible. And this is the Mendes ring, and this is what I am using it now to mark the new axis. The new axis is now marked, which is be 95 degrees. So, or it is 70, 80 degrees, I think. That's what it is marked now. So now, in this case, I'm doing the hydroimplantation. You can see that the irrigation cannula is held, and then the important thing, as has been re-emphasized here, you want to be very sure that any OVD which is on the back surface of the lens has to be removed out. It is not mandatory to do hydroimplantation. You can also do this thing. Here I'm just trying to irrigate the back surface of the lens just to remove any of the OVD which could be sticking on, which you are used to load the lens. But you need to spend adequate time to ensure that all the OVD posterior to the lens is taken care of. Now, before doing the alignment, you need to ensure that the wounds are very well hydrated, because we don't want the chamber to shallow, and then again you have to redo the alignment. So you hydrated as much as possible all the incisions, and now you are going to do the final alignment here. So you want to be sure that the alignment is right, and that's it. And then you have to hydrate the wound before coming out. So I'm just hydrating the incision so that the chamber doesn't shallow and you don't lose. And sometimes, when the chamber shallows, it pops up and it can go away. And this is a way of, just ensuring that it is in the the axis is not the lens is not rotated. So dilate the pupil and examine and know for yourself whether how good the lens is, whether it is rotating or not. So I think this is again we're going back to the slit lamp marking. So this is what I'm telling you. You have to swing between the two eyes to know whether the alignment is right or wrong. So when you swing, it should be at the same level. It should be cutting across the Hirschberg reflex on either side. Then you are taking out the head tilt part of it. So you do it and then you're going to mark it. So you can use a speculum, you may not use a speculum. It's an individual choice. And this is the axis which we are going to mark on the table using the Mendes ring. You can just create a scratch also. Again, here in this case, we are doing an hydroimplantation. Again, don't be under the impression that that is the only way to do it. It's perfectly fine to use viscoelastic and then remove it. That's not an issue at all. So you don't have to be so much perturbed about this. So this was a technique which I was using before, using this app. But still, if it is better to always do it for your all cases, and you're just marking it. Just let me fast forward it here. So it is not at all difficult to use to mark this. And this is one way of marking. You are using the both the ends. You're marking it at the same time, like this. So this is what I used to use very much pre-op, and this is a good habit actually. Just confirm that the patient's head tilt. That is one of the most important source of errors which can happen. And in the theater, sometimes I think this is, you want to see the pit which I was describing. If you mark it with a needle, you can always have the pit, and the smudged ink will not make the go wrong. So you still have the pit to note, and then you can do it. So it's a repetition of the cases. Let me just go ahead. So perfect centration, I think, if you are doing it in the theater, so traditionally we were using these instruments which were defining us whether we are in horizontal meridian or not. And you can see this is a bubble marker, and the bubble has to be in the center of the three sections which you are having. That indicates that you are in the perfect horizontal meridian. Again, when I'm operating in the operation theater, I still would prefer to use a speculum and then you ensure that the head is straight, not tilted. Give him a good fixation. Give him a good fixation, do it, and then you can see that the bubble is in the center part. If you would want to just see this again. So you can see that the bubble is exactly in the center part here. And then here you have an additional 90 degrees mark as well. Again, you can confirm with the app itself. When you're taking photograph with this app in the operation theater, it doesn't come out so good for me that the exposure or the hands will be shaking for the person who is taking. So the reason I prefer to take this use this app at the slit lamp itself. So you're doing the same thing again. So you enter the axis and it has come, and then you go ahead and do it. So difficult situations. Now this is a situation where you have it's a young patient and you have a plaque there, and of course it's perfectly fine to place the lens and do YAG after a couple of months later. It's not mandatory, but if you're keen, you can just try this also. And if you have a good rexus with the open, you can still go ahead and place the toric lens. That's not an issue at all. So this is the plaque and this is the rexus margin which is there. And in these situations, of course, the vitreous has to be kept out of it. So anterior should not be disturbed. And let me tell you that it is not mandatory for you to do this thing. Because in situations where you have promised a toric lens or something and you end up have a central plaque, have some amount of explanation to be given to the patient, but it's perfectly fine to YAG it later as well. So again, as we were discussing in the morning, now we have an open posterior capsule. I have used an OVD to inject the lens inside, and I don't know how the OVD is going to remove. Now we'll just have to wait and see now. So I think I have edited out that part, but the OVD was removed without disturbing the lens, and this is how the lens final alignment is there at the slit lamp. So in certain situations where the posterior capsule is still there, and in a situation we have promised a toric lens, if it is central and it is not extended, you can still place it in the bag. And this is an unusual situation, complication which I had, wherein there is an anterocapsular tear, the rexus has torn, And luckily for me in this situation, the alignment axis was different from the axis at which the rexis had torn. So in this situation, it's perfectly at 90 degrees away from the axis which is the rexis has torn. So even in such situations, if you're lucky enough and the rexis tear is at against the area where you can still go ahead and place the lens. And this is the post-operative picture. And this is the bag which is covering, and the rexis area which is torn is in this quadrant. This quadrant is the rexis torn. And thankfully the alignment axis was different. So one need to remember here that the dots which are there always, they delineate the axis at which you place, and usually that is the steeper meridian where you're going to keep it. Okay? So that's what it is. And now if you have any doubts, please ask us so that we want you to be thorough with the toric lenses. Any practical difficulties which you have?
Lights on. So if there are no doubts, I will just show 2D. 2D.
Yeah, please. That will not happen in all cases. When the in myopic patients,
yes.
In myopic patients, it might happen. So in those patients, the most important thing is your rexis size has to be slightly smaller than what usually. Okay. And second, I would prefer to put in a CTR whenever we have a bigger bag. When you're putting a CTR, when you're putting the lens, it's debatable. Some people prefer a CTR. Some people feel it doesn't make any extra advantage to it. But I believe that putting a CTR does help us to ensure that the contact between the posterior capsule and the optic is much better, and you minimize the lens rotation in those situations.
Okay.
Thank you, sir.
So I will show a video. One of the most common issues that we all face during toric IOL implantation, that like Dr. Deepak showed in his videos, that all the pupil was nice and dilated, but sometimes it doesn't happen. So on table sometimes
my
the
cases
pupil becomes
with
small.
Small pupil and
So these are some strategies you can use while dealing with toric IOL and small pupil.
Methods I used for these cases, and I use coaxial irrigation aspiration for all my cases, so surgeons using bimanual may have more options than these. So this is the method 1 which I use. Pupil is mid dilated, I would say, but the moment you form the anterior chamber, the pupil enlarges quite a bit. This is a bit like LIDRS, where on entering with the irrigation, the pupil enlarges, AC deepens, and then you can see those marks much more easily. Now you can see once I form the chamber, I can see both the marks simultaneously, and then I can nudge the IOL to the final axis. And nowadays I am using this Calesto markerless system, but of course you can do manual toric marking and can get good results. Now second method is to roll the eye right and left to see the marks. So use of the parallax here. So again the pupil is kind of mid dilated, it's around 4 millimeter. So these marks on these IOLs are approximately 4.5 millimeters apart end to end. So you can, if you can see at least one mark, and then you can roll the eye from one side to another, and under the pupil you can see those marks. So use of the parallax, by rolling the eye from side to side, you can get a general idea where the marks are. You can see I am rolling the eye to the left side to see those marks, and then align it with the axis marking. Again, to emphasize, you can do the same with the manual marking as well. So rolling the eye right and left in these cases where the pupil is kind of mid dilated, around 4 millimeter. In most cases, when the pupil is slightly smaller at the end of the surgery, this method works quite well, and you can nudge the IOL to the final axis by checking the axis by rolling the eye right and left. But in some cases the pupil is really small at the end, and even if you use, say, adrenaline or other dilating agents, it doesn't yet dilate, and in those cases it's really tough. And in this case, what I do is I retract the iris on one side, check the marks where it is exactly, and then check on the other side by retracting the iris on other side, I find this method really tedious, takes long time, and also the visco removal is not adequate in such cases, and I find with this technique the chances of rotation of the IL are high. So I don't recommend this technique now. Now another method that I used to use before was making additional marks on the IOL. So here I have used the pupil expander ring, but before I implant the IOL, what I am doing, I gently touch the IOL in the line of those existing marks at around 3.5 to 4 millimeter distance apart. These are literally just tiny, very tiny scratch on the surface of the IOL, and it is visible even after you remove the pupil expansion ring. And you want to remove the pupil expansion ring so that you can remove all the OVD from the anterior chamber, behind, from the bag as well. Without the OVD in the anterior chamber, removal of these pupil expanders or iris hooks sometimes is difficult, and you may land up with more trauma to the eye. So you can see here the pupil is still fairly large enough even after removal of the B hex. But once you look for the final alignment, you can see you may not be able to see both the marks on the IOL simultaneously, but those added marks which I have done on the IOL, you can watch them very closely, and it's visible only on microscope with high magnification, so it will not be even visible in the post-operative period unless you look carefully. Patient doesn't have any aberrations because of these very, very tiny marks which are there, and the advantage is that post-operatively also you can make sure that IOL is well aligned. Now this is the fifth method which I use. So during surgery, any time if you feel that the pupil has gone down significantly and you have to put a toric IOL. Now here I have already removed the cataract, but before toric IOL implantation, because the pupil was too small, I am going to use pupil expander. You can use iris hooks or any pupil expansion device. So there is no such rule that you have to use it only at the start of the surgery. You can put it any time in between the surgery to make sure that the final result is not compromised. So once B hex is in, I am going to implant the IOL. Now using iris retractors or pupil expansion ring after the nucleus removal or after CCC, make sure that the anterior capsule is not engaged in the pupil expansion device or retractor. Now once the IOL is in axis, I will be removing all the OVD from the anterior chamber and most importantly from the bag. If you leave OVD in the bag, this IOL has a tendency to rotate in the post-operative period, which we don't want. So remove the OVD completely, and this is one thing which one of my colleague told me that you can try, that removal of the pupil expansion ring under the irrigation, but frankly my experience is not good. You can see that chances of iris prolapse are very high. The idea is right that you don't put OVD again, and that may lead to rotation of the IOL. So what I have done, I have modified this technique, and what I do in this case is in the presence of the pupil expansion device or iris retractors, I remove entirely the OVD from the bag and from the anterior chamber. I make sure that the IOL is well aligned according to the axis, and then I use hyaluronate, which is a Covesi OVD, just in the anterior chamber while I remove the B hex ring or any pupil expansion device or iris hooks. So that makes the things much more less traumatic and very controlled. So just look at this case. This is a small pupil. I have used a B hex ring, cataract and cortex has been removed. The IOL goes into the bag there, and you must have seen that when I am using B hex ring, I make sure that in subincial area there is no flange of that B hex, so this avoids haptic dragging the B hex into the bag. And now I am going to remove this OVD completely. Before that, I am just nudging the IOL closer to the axis of alignment where I want to put it. Again, I am using a Callisto markerless system, but manual marking with Mendez ring final axis marking is completely fine, very accurate. And the other thing what I use is the iToric Patwadan Android app for freehand marking and then get the final axis. So here of course I am using Callisto. So once just watch how cleanly I remove the OVD from the bag and from the posterior surface of the IOL. This ensures that this hydrophobic IOL sticks well to the posterior capsule. And now what I have used is a 1 or 1.4% hyaluronate only in the anterior chamber, and now I am going to remove this B-hex ring from the chamber. Very controlled, no chances of trauma to the iris or to the endothelium, and removal of this cohesive OVD is really quick. So this avoids any further rotation of the IOL. This has really worked for me and got very good results with this technique. So you can try it. It will definitely improve your toric IOL results. Of course, you can do many other things like hydroimplantation, but with small pupil it's always tricky. Do try and do write comments how you do things differently and how it is better. Thank you so much.
So thank you. I think that ends the toric IOL session. Of course, if you have any doubts.
Sir, so any post-op specific instructions for the toric IOL patients?
We don't ask the patient to lie down or something like that, because eyes are always moving, so we can't really stop the eyes from moving. So no specific instruction as such.
So there's one question.
Yes.
Is cohesive better than HPMC while doing toric IOL?
Yes. While implanting the toric IOL, cohesive viscoelastic will be better, because complete removal of OVD is easier with cohesive OVD as compared to HPMC.
Sir, when you consider rotation of the IOL, and what is the ideal period when you do it?
Okay, re-rotation you mean. So post-operatively, the toric IOL has rotated from its original axis where you had implanted. So in such cases, I don't usually rotate in the first week. So I wait for at least 1 week. So generally, on first week follow-up, I see whether the patient really requires rotation. If it requires, I call him after a week. So second to third week is the best period to re-rotate these IOLs, because by that time the capsular bag starts becoming more sticky. If you rotate when the bag is fresh, again there are chances of re-rotating, particularly like Dr. Deepak was saying, many times the cause of rotation is big bag. So once bag little bit of kind of contracts, so that happens after 2 to 3 weeks, it's best time to re-rotate such IOLs. So you can go for any case. Most importantly, you should avoid cases with irregular astigmatism, because these give inconsistent results. So better to avoid doing toric IOLs in those.
So means how many degrees, and then you will consider the re-rotation in which
re-rotation
case?
So re-rotation depends on basically patient's expectations. In our scenario, I would say up to 10-degree rotation, where the error is going to be less than 30% of the total toricity, I would avoid. But depends also on the amount of toricity you are going to correct. For example, 6 months back I operated a patient having 8 diopter cylinder, and I used a customized toric, and in that the rotation was hardly, I think, 8 to 10 degrees. But 30% of 8 diopters becomes almost 2.5 diopters. So in that patient I rotated after I think after 4 weeks, and that did well. In the same patient, the other eye didn't rotate, so we had full correction.
For serial rotators, if we have to rotate around 2 times or so do we consider putting a CTR while we do?
Yes.
Suppose if we have to rotate third time, a patient which was rotated once, we move it to the axis, and second time again it has again rotated, say by a gap of around 3 or 4 weeks after the first time.
How have you documented the rotation? How have you documented the rotation?
By dilating and seeing it on the slit lamp.
Okay, so that itself is quite tricky, okay? And then you documented rotation, you are able to analyze what is the reason for rotation. So unless and until you feel that the CTR which you have given has not given expanded enough or something, then there is a point in putting another CTR. If the bag is of normal size.
Yeah, it was not a myopic patient.
A normal size, then there is something else which is missing. it shouldn't rotate usually. I haven't had much of a significant rotation even after second time also. Have you experienced something like this?
So this happens commonly. Which type of IOL you used?
That patient was acreol toric.
Acreol, okay.
It
So
shouldn't happen.
I haven't seen with that
that
IOL,
platform.
but
To do it twice, but while doing it for the second time, I was considering whether I should be putting in a CTR with it or not. Eventually, I didn't.
You can try, but first of all, I must congratulate you because this patient came to you second time also for re-rotation, because most of the patients go away after first. But I think one of the common causes which I have seen in not my case, but I have maybe heard in a conference that plate haptic IOLs, particularly if they are smaller, the bag is bigger, and plate haptics, they are fixed size, unlike the other type of haptics. In those cases, it will keep on rotating, like we see with IPCL. If IPCL is undersized, it will keep on rotating. If you rotate it, again re-rotates back to its position. In this case, I think best to explant and put another type of IOL. I think that could be one of the options. Okay, so I think one more question there. Mike.
So there is one question for Deepak sir.
Yeah.
So the name of the marker with the central ring and 2 arms intraoperative marker.
This video is part of PhacoTips.
Hello.
Name of the
marker.
It is called axis marker. It is just called an axis marker. I am not sure about is any specific name. Are you aware?
No, the inventor must be very old, before our birth, I think.
So it's just an axis
we
marker.
will find out the name of the inventor.
I am not sure about the name, but it's called an axis marker. That's all.
But the ring is called Mendes ring. That
ring is Mendes ring. The marker is axis marker.
Anybody knows the answer, they can Google it or search.
Sir,
But
there is
now
one
I think
question.
with iToric, I think nowadays, yes.
Sir, in iToric app, there is in the app how to use that app. In step 5, enter axis of placement, that is 173.
Yes.
How that we can get?
That is from the toric calculator, whichever Barrett toric calculator if you are using, which is the most common one. So from that you will get the axis of the placement of the IOL. So that's what I said. This app is only for reference marking, not for toric calculations.
See, you get a chart from the company maker, whatever, if you have not even opened the Barrett's, okay? You ordered a lens and the company person will send a lens along with a chart there. It will be saying the alignment axis will be written there. That axis has to be entered here. Okay?
Another thing which I wanted to share is that, what is the most common error in toric IOL, calculation or toric IOLs where you get massive surprises? Commonest error is, a transcription error where you, instead of steep axis, you enter the flat axis power. Okay, so you get IOL which is exactly 90 degrees as compared to where it should be actually. And if the patient has 2 diopter astigmatism pre-op, patient will end up with 4 diopter astigmatism pre-op. And that is the most common. Now to avoid that, what I, generally, because most of us use, say, like you said, the autokeratometer for, measuring the toricity of the cornea. Now most of the autokeratometers by default show the flat axis on that. So make sure that whatever autorefractometer or autokeratometer you have, which axis it is showing. So if it is flat, you have to remind yourself. Another thing which I tell, my consultants also, if you have access to IL master or any optical biometer, make the setting so that you see a positive astigmatism. So whatever positive astigmatism of the cornea is shown, that is axis is shown, that is approximately the axis where the IOL is going to land up. So that avoids any confusions.
See, let me elaborate and give an example. Your auto-K reading is showing minus 1.5 cylinder 90 degrees. You are expected to align at 180 degrees. Okay, that is showing the flat axis is showing the flat axis. So the steeper axis is 180 degrees, and you are supposed to keep your marks at 180 degrees. So remember that the marks which are supposed to be at the alignment axis have to be kept at the steeper axis. And steeper axis is usually what you should have your keratometry reading set also. So if it is possible to set your AK reading, if you're not, change it to the transpose it. It can always be transposed and set if it is possible. In IOL master, it is definitely an option is there.
Okay, so we'll move on to the next 3D video. So with audio, please.
Course. In this video, we'll be dealing with a case of pseudo exfoliation with hard cataract. It's more of a Morganian cataract.
So in this case, I will just fast forward to the area which I want to show. So
capsular tension rings. This tear tangentially and never radially. So the zonular weakness is quite severe, and the nucleus appears little shrunken. So I decided to put a capsular tension ring. So one eyelet goes in, and I want to place this IOL in the bag. So the Sinski in the left hand will make sure that the capsular tension ring is pushed down, so it doesn't pop up into the sulcus. But in cases where it's very severe zonular weakness, sometimes the capsular tension ring can pop up or pop out of the bag and go into the sulcus. In such cases, it's important to understand what is the exact severity of zonular weakness. In this case, I think it's quite severe. As you can see, while putting capsular tension ring also, the bag was moving. Now, because it's a very hard cataract, I decided to do a chop. Using longitudinal power, you can see 70% power and 40% on time. So for chopping, I am using vertical as well as horizontal chop technique. So this is a vertical chop technique. Important to make the pieces separate right till the posterior plate. So it's a leathery kind of cataract which I am dealing with. Now here is the kind of a horizontal chop where the Sinski goes beyond the equator, and now the quadrant removal. But as you can see that as I started doing quadrant removal, as the bag started getting empty, we can see that the bag is not stable, and from the inferior side, in fact, the bag is coming up. So probably there is either peripheral capsular rupture or dialysis. So as the fallibility was still there, I thought that I will emulsify pieces. But as I continued to do that, I could see that the bag was coming up. Probably the capsular axis was already torn, and bag had dialysis there. So at this point I stopped, decided to do BSS OVD exchange and then judge the situation. Already the zonular weakness was quite severe, so this was something I was expecting. Now I am going to give subconjunctival xylocaine here. Wait for a minute and then open up the tenon, subtenon space and give posterior subtenon xylocaine using blunt cannula. Around 1 to 1.5 cc is injected. So the patient becomes comfortable, and here I have decided that I am going to take these pieces out through the scleral tunnel, because this bag is very unstable and I don't see any space to give support to this bag, because the anterior capsule rim is not properly visible. Putting capsular hooks are difficult. Scleral tunnel has to be made with care, making sure that you make at least 6 mm external incision, and then using the crescent blade you create the tunnel. Cut as you come out make sure that internal opening is big enough so that you can visco express these pieces easily. With 2.8 keratome, entry is made and enlarged by cutting while going in. Now we can take out these pieces by a sandwich technique using Weierwichtes and Sinski, or you can use the visco expression like I am using. And as you can see, as I am trying to take out these pieces, the bag is also trying to come out. So the zonules are very weak. And what happened to the CTR? So in such cases, most likely what happens is that the CTR pops out of the bag and goes into the sulcus. Now it's very difficult to retrieve this CTR from the sulcus, so we have to leave it as it is. Now as I tried to visco express the last piece, you can see the bag also started to come out, indicating that zonules have given way and this bag cannot be now used, so I have to find out another way to fix the IOL. So once the nucleus is out, I removed the B-hex pupil expansion device and I am going to insert a iris claw. For that 180 degree I am going to put slightly posterior limbal or scleral incision. This helps in enclavation of the iris claw IOL. Iris claw IOL is inserted and then oriented. Iris claw holding forceps is taken. As we go in, you can always notice there is shallowing of anterior chamber, so we have to be careful that once you go in, slightly tug the anterior lip upwards, and now the iris claw is pushed back behind the iris and enclaved. For the right side again the same procedure is repeated. Now I want to remove the central bag and also the anterior capsular rim, because if we leave this bag behind the iris claw IOL, in future it might just get fibrosed and come into the central visual pathway and may hamper vision. In this particular case there is already YAG PI which was done pre-operatively because of the shallow anterior chamber, so I didn't do a surgical PI, and that's the end of the procedure. So in this video you can see that in case of severe zonal weakness you should have plan B ready for the surgical rehabilitation of the patient.
So now
Thank
you saw in this case like how the iris claw was done. Appear very simple, right? So but when a beginner surgeon tries to do that, so I want to show you that and I will tell you the tricks how you can learn it quite easily. Switch off the light please.
This video is part of PhacoTips 3D teaching course.
So you could see that I could remove that nucleus and put the iris claw easily, but this is the first case that my trainee is going to do iris claw. So first thing that the beginner surgeon encounters is, look at that, the AC starts shallowing big time, and the moment the surgeon goes in with the forceps, iris starts coming out. So the first attempt fails. Again more visco was injected trying to grab the IOL. Now iris claw IOL is also pushed down because of the visco injection. Tries to grab the center of the IOL, but no, ultimately manages to hold on to the edge of this iris claw IOL. Again the posterior lip of the scleral incision is being pressed, that's why the AC is now collapsing again and again, and not able to hold the IOL properly because it's not holding the center of the IOL. So second attempt also gone. So this is how a beginner feels rather than what I showed. So first enclavation was done by me, and now I am asking the trainee to do the second enclavation. Again started facing the same issues, that the AC was shallowing, not able to catch hold of the center of the iris claw IOL, and that's why not able to go behind the iris as well. So ultimately the trainee managed to somehow handle and hold the center of the iris claw IOL there. As you can see, the iris, the AC is already collapsed completely, but the iris claw is behind the iris now, and the trainee now struggles to find where the iris claw is, and just by accident enclaves it properly. That was by accident. It was not what the trainee intended, so it happened. But now let's see how we can simplify this method. So this is another surgeon or another trainee, I would say, who is going to put the iris claw IOL. So we have made few modification in this technique for training our surgeons. So what we do, the main problem these the beginner surgeons face is that because of lack of control over the hand, the posterior lip tends to get pressed down. So in order to reduce this leakage of viscoelastic, we use Hylucoat, which is much viscous, heavy dispersive OVD. And here we are using it not to coat the endothelium, but this is basically to make kind of a resistance for any other viscoelastic to come out. So it is like guarding the incision there. And with the help of Mr. Ajay Mahajan, late Mr. Ajay Mahajan, I had asked him, because you saw the earlier iris claw forceps which had teeth type junction. Now another issue trainees used to face was that it used to damage the iris while coming out. So I asked him to make a little rounded, so he gave me this one, and it's quite useful design of iris claw forceps, where now you will see that once this surgeon goes in, so first always the left hand 27 gauge cannula should go in, so you should not struggle to find that incision. Once it goes in, you can see there is still visco leakage, but because of Hylucoat it is reduced. And now here I will just show you in first live action how it was done. Very easy, right? Now how he judges where the claw is based on the relation of this end of this iris claw forceps with that claw. So here you can see the end of the iris claw forceps exactly in the same line. So while enclaving it, he knows that it's at the same position, and that's where he is going to press that 27 gauge cannula. And that's how it is not now accidental, but by design he has enclaved the iris claw IOL on one side. Again he will put Hylucoat to guard the door. Now once you get experience, you need not use this OVD, and you can use methyl cellulose, because by that time you get used to holding the scleral tunnel up and avoiding visco leak, and also you are quick enough so that you can go in and grab the center of the iris claw IOL very easily. So again goes in, grabs the center. Again subconsciously we have to watch where the claw is, and then you can enclave it very easily. Again it looked very easy, right? Again subconsciously just check the tip of the iris claw forceps in the same line as the iris claws there. So once it goes behind, you know where it is going to land up, and at the same place you are going to press your cannula down, right? So it becomes much easier now for you to do the iris claw IOL. And always do a peripheral PI whenever you use iris claw IOL, because you don't want any pupillary block to happen because of iris claw IOL. Okay, thank you. So if there are any questions regarding this technique, because I think iris claw IOL is one of very good tricks that anterior segment surgeons should have to bail out of these situations.
So the IOL holding forceps that you use,
Yes.
holding forceps,
Yeah.
where is it commercially available?
So that's what I mentioned. Mr. Ajay Mahajan, he was the owner of CardioCare. Stall is right behind. Unfortunately, he passed away this year. He helped me in designing this iris claw IOL, so it's available with CardioCare. Yes. Any other questions regarding iris claw? Okay, so we'll move on to the quiz part. 3D on, yes. 3D on.
So there is one question. At which point should we use pilocarpine while implanting iris claw IOL.
Yes, so I think I missed it. So if the pupil has not constricted already, we should use pilocarpine before implanting IOL. So there are different companies. I think we use the excellence lens. Optech is there, and which one you use, Dr. Deepak? Excel, same I think.
Excel Optics and Freedom.
Freedom.
But the problem is you really don't get them very frequently. Some of them they just get out of stock. They don't respond. Yeah, that's Excel Optics and Freedom is what we are using.
So this question is about it's not about who will recognize it. I just want to know who will recognize it first. Lights on, dim lights on. It's the very simple video clip. There is something wrong going on there. You can just identify what it is. And whoever will tell it first will get the chocolate. Yes. So you can watch it again there. That haptic is broken. So that sir will get the chocolate.
And can you explain why this happened? You have seen yesterday's video of IL implantation. So, mic then. Mic.
So probably while loading the haptic, it got stuck in the.
Yes. Yeah, push-pull technique, and whenever you close the cartridge, watch it under the microscope. The haptic should be inside the cartridge. Many times it's stuck between those, butterfly flanges. That's when you get this broken trailing haptics. And now I will just show a very interesting technique of IL explantation. I have already shown the Packer-Chang scissors. So
this video
is a
part
very
of
very
PhacoTips
nice
3D
innovation by Dr. Neha Dolakia madam, and this case I just did maybe 3-4 days back, where the IOL was subluxated into anterior vitreous, you can see. So the plan was to do complete vitrectomy and then explant the IOL. So but since it was in the anterior vitreous, I decided that I will just pull it out first and pull it out in the AC. And I just wanted to know, there is a, sorry, हे नहीं है सेटिंग्स नहीं मिळते स्विच ऑफ करूया एक मिनिट प्रेझेंटर मोड इथून कसं हां so presenter mode of hide okay yes okay so this was the next video this one presenter mode off now I just wanted to know how many of looking at this back, this patient was operated 10 years back. What could be the cause for this kind of dislocation? Anybody knows? Okay, so you can see the anterior capsule there. There is hardly any fibrosis. It looks as if the I have done the surgery yesterday, right? So this is dead back syndrome kind of thing, where there is no proliferation or no fibrosis of any of the capsular element, And nowadays these kind of patients are coming back after 10-15 years, where I'll just subluxate, where the anterior capsular rim is still there, but the PC has given way and there is a subluxation. So what I wanted to show in this case was a very good innovation by Dr. Rolekia madam. So first thing, I want to pull this, the IOL up into the anterior chamber there. So there was little vitreous in between. I edited it. I removed that vitreous from the anterior chamber, and now I rotated this IOL. And this, cutter, it's like a PhacoTip, and it attached to the, the Phaco probe itself. So it has a ultrasound energy. It's, shaped like a Caesar, but it's the tips are not moving. That means it's only vibrating with the ultrasound energy. We can use the same irrigation through the irrigation sleeve, or we can just switch off the irrigation. We can stop, aspiration is already stopped. And I am using heavy dispersive agent in the anterior chamber. And okay, now, आवाज नहीं है क्या? Yeah, you can hear the sound. It's I am using basically the longitudinal phaco energy here, and the active center is giving noises because it's not recognizing whether it's in the AC or not. But you can see how nicely it's cutting the IOL very easily, and the counter traction I am providing because I am used to it by another Sinski. But you can also hold the IOL with a forceps and then cut it. Okay, you can also cut into 2-3 parts as Dr. Neha madam had shown in her videos. But here I am using the same technique which I use normally, where I cut it more than 50% and then just pull out very carefully these pieces out under the cover of heavy dispersive OVD. So congratulations, I think big round of applause, because this is another big innovation from Dr. Dolakia madam, and I think Indian ophthalmology will be proud of this innovation. I am sure it is going to be used all over the world very, very soon. And very innovative technique. Dr. Madam is there. Ma'am, you would like to explain about a few settings which you commonly use with this? I'll just pause the video. Lights on, please. Madam,
And thank you, Dr. Saurabh, for introducing this. The Phaco power, so there are 3 different groove settings, there are 6 different lengths, and there are 2 different thicknesses of PhacoTips out of the common 10 machines that we have. So each machine has a specific tip. Sometimes the tip, if the grooves are similar, can be interchanged, but I would not advise that. So once I know the machine, a particular tip will be given. We need to find the lowest Phaco power with which it can cut. So you must try in vitro first, outside the eye, with any cheap foldable IOL, because we want the lowest power that will protect the endothelium really well. And recently one doctor from Bombay did it, got 6/6 N6 vision, next day post-op crystal clear cornea. Lecturer from JJ Hospital also did the same thing in a one-eyed patient. Both these patients were one-eyed, so there was no striate keratitis. Second thing, if the lens is cut into 3 parts, like Kit Kat slivers, each part is only 2 millimeters and it can be removed through a 2.2 millimeter incision also. And there is no stretching of the bone by doing twisting, turning, and it is protective, and I prefer it to bulky scissors, but people are used to the scissors, that's fine too. But this is a nice way to get it. Vacuum should be 0, flow rate, aspiration should be 0, irrigation should be on, and keep putting viscoelastic to protect the endothelium. But Dr. Saurabh has done it very nicely with the counter traction. If that's not possible, because he's good at this, side port, from the side port I have designed nice forceps which open horizontally, so they are ergonomically good to hold, and the jaws open vertically to grasp the IOL, and good counter traction is given. It's actually quite simple. There are videos to explain the steps. Thank you.
Thank you, ma'am. So what I did was okay, madam.
Yes, very, very
1
nice.
to 10, it's okay?
10 on 10.
Okay. So we'll move on to the next video, which is very interesting video, and I want you to think about whatever things are happening in the video, and we'll build upon it in the next, the talk by Dr. Deepak. So here I start.
This video is part of PhacoTips 3D teaching course. This is an interesting video, a posterior polar cataract, and there was a posterior capsular rupture. Along with that, there was fluid deviation. So let's have a look at it. So started off with a good size capsule rex is there, and decided to do mechanical dissection. So instead of hydro dissection, decided to do mechanical dissection. This gives advantage that the nucleus will be separated a bit from the capsule, and you can do the emulsification a bit easily. I am going to use the sideways sculpting method described by me. So central trench is made and then sideways trenching is done to have a plus sign. So this technique avoids any nucleus rotation while you are emulsifying the pieces. Once these trenches are done, the pieces are divided and the pieces are pulled in the center and emulsified. PCR probably happened at this time because I could sense that there was some change in the fluidics after this, and avoiding rotation of the nucleus, I tried to pull the pieces in and emulsify them. Avoiding nucleus rotation helps in preventing the posterior capsule rupture if the central part is adherent to the PC. So one by one the quadrants are emulsified, and here I could sense that there was some giveaway of the posterior capsule, but the followability was good, so probably the anterior hyaloid was intact and I could emulsify the pieces quite easily here without any prolapse of the vitreous so far. And now I could notice the posterior capsular rent there, rupture, and still the followability was good and I couldn't see any vitreous strands there. Doing BSS OVD exchange there to maintain the anterior chamber, and again, as there was no vitreous visible in the anterior chamber, I decided to do cortex aspiration there, and as I go near the area of PC rupture, you can see that the vitreous starts bulging. And now as I continue to do cortex aspiration, you can notice that the posterior capsule has started bulging now. It is coming anteriorly, and this is the time when I suspected that there was fluid misdirection as well. So the fluid was probably going through the area of posterior capsular rupture, behind the posterior capsule and pushing the posterior capsule forward. That's what was happening at this point, and you could see that the PC has wrinkles, it's getting pushed anteriorly, and the moment I went near the area of PC rupture, you can see the PC goes back because probably the fluid which was trapped behind has come out through the area of posterior capsular rupture. Now here I think I should have left the cortex alone, but I tried to pull it out and I could see a vitreous strand there, and still I had the temptation to pull out that remaining cortex there, which I shouldn't have. Again I could feel that maybe I was pulling on the vitreous there, so decided to do again BSS OVD exchange and take out the IA cannula there. Now there was no vitreous in the AC, so I think it was a good idea to just place the IL and close the surgery. But I thought of again, had the temptation to do dry aspiration of this cortex, and again you can see that the vitreous started to get pulled. So I injected a little bit of diluted triamcinolone there. It went into the vitreous, you can see that, and now I am going to do pars plana vitrectomy, making an incision at 3.5 millimeter from the limbus. You can make it at 3 to 3.5 millimeter using 23 gauge MVR and 23 gauge cutter. Initially the opening of the cutter is kept sideways, and under direct visualization it is kept away from the posterior capsule. And the idea here was that I will cut the vitreous from behind, so there will not be any prolapse of vitreous when I place the IL and do remaining visco wash. So the pars plana vitrectomy was completed, and again I attempted to remove the cortex which was there, and I could remove it, but again you can see there was still some vitreous strands which were there. Probably the antivitreous was still intact, and that's why there was no significant prolapse of vitreous there. But there were few strands which were trying to come in the anterior chamber. So once the cortex was removed, which was probably unnecessary in the hindsight, I decided to place the IL in the sulcus, enlarge the incision using a 3-piece IL here. Make sure that you open up this IL in the anterior chamber and don't try to attempt it directly inserting into the sulcus. Sometimes it may drop into the vitreous. So once the IL is inside, it's carefully dialed under good visualization into the sulcus behind the iris. Now here the capsular axis size is very large. So I attempted doing optic capture, but where the CCC is larger than 5.2 and it's eccentric, I think it's better not to, because it may cause tilt of the IL, because only on one side it gets captured, like in this case. Now I decided to do visco wash, and when I started doing that, again there was fluid misdirection. The fluid started going behind. Can the shallowing of AC because of the leaking large incision? That's what I thought maybe initially. But as I removed the probe and decided to hydrate the incision, you will find that even during hydration of the incision, the AC was becoming shallower and shallower, and that's when I realized that the injected fluid was getting trapped behind the posterior capsule. You can watch it again here. As I injected the fluid to form the anterior chamber, it went behind and in fact caused more bulge in the PC. The PC was bulging more and the IL was pushed anteriorly. So again I tried to form the anterior chamber, but I can see that the PC was bulging and there was fluid which was trapped behind the posterior capsule. So pars plana vitrectomy comes to rescue in such situation. I had already made the pars plana port, so that was helpful. And you can see here that as I start removing the vitreous and the fluid from the pars plana root, you will find that the AC starts becoming deeper and deeper and it starts forming. So in case of fluid misdirection, I think this is one way to tackle it. And you can see now the AC is nicely formed. So now I should not be pushing more fluid in the anterior chamber. I will push just air and then suture the incisions. Now the IL is already in sulcus, but there is a optic capture which I don't want, because there is optic capture only on one side and you can see that the IL is little bit tilted. I don't want that because it may lead to astigmatism. So I released that optic capture from inferior side as well, made sure the incisions are watertight and sutured them. This was a nice case to understand the concept of fluid misdirection and how to tackle it. Thank you.
Okay, thank you. So this was basically, I would say, a misadventurous case where I could have just closed it at the time when I realized there was a PC rent and almost everything except that little bit of cortex was out. But I think it, I realized how the fluid deviation was happening in this case. Of course, this is not how it happens in usual cases, which Dr. Deepak will deal, but this is for understanding the concept how the fluid gets trapped behind and causes shallowing of the anterior chamber. So we'll start with Dr. Deepak's talk on intraoperative hard eye syndrome. Any questions in between?
So intraoperative hard eye is a very important topic for all of you because it's not such a very common thing to be spoken about in the meetings or conferences which you see, and most of us would have experience in some way or the other. So let us understand what are the various mechanisms and causes, what causes this. So let me share with you a few case scenarios here. This is one case, 75-year-old lady who has phacomorphic glaucoma. She is almost with medical management, and before the surgery the IOP is 8. You're given IOP, the mannitol has been given, and you can see the cornea is very clear. Block has been given and massaged, and I'm ensuring that its eye is soft. We don't want to enter in an eye which is hard because there is a risk of suprachoroidal hemorrhage happening there. So we need to be mindful of that. So all the additional care has been taken. These are the challenges which we are anticipating in this case. And look at it now, as soon as I put in OVD, this is actually sodium hyaluronate. So actually, as you see, as soon as I put in OVD, it starts to gush out. Look at the intensity with which it is gushing out through the side port. This is actually sodium hyaluronate here. Instead of creating space, just coming out. And the eye refuses to become soft. It is extremely hard. Whatever I want to push in, it's just coming out. Okay?
This video is part of PhacoTips 3D teaching course.
So at this stage, what are you going to do? You're not even touched the anterior capsule. The eyeball is extremely hard. So I wait for 3 to 4 minutes to know whether it just softens up a little bit or so. And there are two possible reasons. One is the fluid misdirection syndrome or suprachoroidal hemorrhage here. Now, because I am dealing with a phacomorphic glaucoma and we expect a zonular laxity because the lens has been pushed forward because of that, I am thinking of fluid misdirection in this syndrome. Now, how do we manage? So in this case, I just decided to do a pars plana tap here. So what I'm doing, I'm measuring about 4 mm from the limbus, and I'm just using an MVR blade to just create an incision in the pars plana region. You can just keep watching it here. As soon as I put, you can see there's a colored fluid which comes out. Actually, this is the aqueous stained, the dye stained aqueous which is just coming out here. I'm not going anything, just made an incision here. So you can see that it has just come out. So in just a couple of seconds, the eye just becomes soft. So now again, once the eye has become soft, it is now predictable. You are going to do everything in a similar fashion, and I'm create a rhexis, and the phaco is done, and the lens is placed into the bag, and the eye is absolutely fine. There's absolutely no problem at all, and you hydrate the incisions, and you suture the sclerotomy which you created by using 8-vicryl suture, and then close it, and the patient does absolutely fine. So the mechanism by which this intraoperative hard eye developed in this case was, this was a case which was having zonular laxity. When you put in dye, when I put in the fluid to wash it out, and then I pushed in the OVD. So what happened, the part of the fluid has gone behind the zonules into the burger space, and that is what was causing the hardness in this eye. So we didn't do any vitrectomy, nothing. You just made a pars plana incision, and that just, because of the pressure itself, the fluid just burped out on its own. So in this case, the diagnosis is not so difficult because there is a pre-existing scenario of a weak zonules, and you expect this to happen. This is another case. He's an 80-year-old man who has this pseudoexfoliation, non-dilating pupil, and antechamber depth of 2.74 millimeter. And In this case, we have planned a toric lens, and the rexis is being done now after the BX lens implantation. So far, everything is fine. It is all right. The lens is being just nudged to know whether it is mobile or not. And the last fragment is aspirated. At this time, and as I begin my I&A, I can now sense that there's a positive pressure. The PC is being pushed anteriorly. It is touching my aspiration cannula. And you can see there's no space in the anterior chamber. It's difficult for me to introduce the cannula itself. After waiting a couple of times, I could manage to it. And you can see this. Let me pause here. These tiny lens particles are seen inside, okay, behind the posterior capsule. These are dust particles in the lens. This is suggestive of a free access to the burger space from your anterior chamber. So that is one indirect evidence. And now eye has become hard. So at this point, the iris is started to prolapse out. And what are the things which you typically we look is, presence of a red glow, which indicates that, okay, it doesn't look to be a supracorneal hemorrhage. It looks to be fine. I try to go in and put in OVD, decompress, put in OVD, but nothing seems to be working now. So I still have a lot of cortex to remove. And you create a little bit of space and then go in with irrigation. Again, the eye becomes hard. So it's almost impossible for us to proceed further. Patient is complaining of pain. So surgery is temporarily suspended. We just monitor the blood pressure, and in the OT itself, I'm just starting the IV mannitol. So I'm just waiting there, sitting there, and the IV mannitol is given. And after 15-20 minutes, again go ahead and try to fill in the chamber. It is better now. I'm able to form the chamber. It looks to be much better. So again, using a bimanual I&A, you're going to do the cortex aspiration, the planned CTR is put, and the intraocular lens is being placed. Now, when the iris is coming out like this, in such a situation, it's not wise to keep on pushing the iris back. When it's coming out, let it be there. And I'm seeing the last bit of cortex to be removed. And once the OVD is all removed, finally you push the iris back in place and retract the iris. Now this is my left hand has got an irrigating handpiece. I'm using it to retract and see that whether the alignment is properly done or not. And in spite of such a traumatic experience in the surgery, the outcomes were all right. Now again, a very seemingly routine case. In this case, there's nothing very ominous for us. And the nucleus emulsified. And this stage, the positive pressure started to build in this case. Again, you can see the posterior capsule is becoming convex. It is trying to push in more anteriorly. And there's no space literally in the back for me to proceed with the surgery here. So again, I go in and refill with OVD and look at the way in which the OVD is being pushed out rather than inside. These are some indications that all is not well. So with great difficulty, with repeated injection, I could somehow manage to clear all the cortex. But now is the time for implanting the lens. Again, the same situation. I am using sodium hyaluronate and still I am unable to create any space there. The posterior capsule is bulging out, literally bulging up. And I'm just using now a little bit of dispersive OVD on the iris to make it sure. But I've somehow managed to enter with the cartridge inside. At this stage, the cartridge is literally touching the posterior capsule. It is something like that what is happening. So I felt injecting a lens in this scenario could be more traumatic to the posterior capsule. So I just withdraw, in this case, come out. What I do is just hydrate the wound, close it now. So I want to do something which, I just want to postpone the surgery. I want to assess what is the situation. So we postponed the surgery and IV mannitol was given in the wards. And in the meantime, I got a B scan done and an indirect ophthalmoscopy done just to rule out any presence of any suprachoroidals in this case. So 2 hours later, before the last case, again the patient was shifted back to OT. And this time the eye was behaving absolutely normal. I could form the bag and then maneuver the lens into the bag and then aspirate it out. So these were the 3 unusual scenarios of fluid misdirection causing intraoperative difficulty in this case. Okay, so let me go to the last case in the scenario, and which is something for us to learn. And this is something, let me just start. I think this has a voiceover. Let me see.
A healthy 65-year-old lady undergoing a routine phacophotonic IOL implantation under topical anesthesia. Apart from the cataract, she does not have any ocular pathology. Her IOP is 16 preoperatively on the day of surgery, as were her other vitals. The surgery seems straightforward. Rhexis is done, nucleus emulsification done. Surgery is going on in a very predictable way until now. I'm doing cortex aspiration, things are looking alright. But as I'm trying to perform hydropolishing to remove some fine fibers, I notice that the eye is becoming hard. The chamber is shallowing. The posterior capsule is literally bulging anteriorly. I hydrate all the wounds and wait for about half a minute. The patient is complaining of slight pain as I'm trying to push in cohesive OVD into the eye to deepen the chamber. Well, this is a dramatic visual. The OVD is refusing to get in. Such is the pressure from within the eye that more OVD is gushing out than I can put in. There is absolutely no space in the capsular bag. The positive pressure is relentless. Please note the red glow continues to be absolutely fine. At this point, I am hitting the pause button for a couple of minutes. Fluid misdirection versus suprachoroidal hemorrhage. The great debate is going on in my head. The fundal glow is excellent. The patient is healthy, no glaucoma. It must be fluid misdirection, I thought. After 2 minutes, the situation did not improve. If it was fluid misdirection, there should have been some reduction in the pressure. This got me suspicious. I aborted the surgery. Indirect ophthalmoscopy was attempted, but the view was not great because of the corneal haze. The posterior pole B scan was done by my technician, and this is the scan. It looks fine, so I thought fluid misdirection is the diagnosis and is confirmed. That's what I thought. IV mannitol was started to reduce the pressure. The plan was to complete the procedure after 3 hours on the same day. In the meantime, the routine blood pressure checkup in the ward shows a spike, 170 by 110. Well, I thought anxiety may be the cause. Medications were given to control the blood pressure and she was better. 3 hours later, back to the OR. The eye had marginally improved, had not softened significantly. Managed to push in the IOL somehow, but the pressure began to rise again. It was relentless. I am struggling to remove the OVD. I am unable to position the lens in the desired axis. At this stage, I am unable to understand what the issue is. The red glow continues to be good, and since the B scan is normal, I thought a pars plana tap would help if there was fluid misdirection by draining out the fluid in the Berger space. So I make an incision 3 mm posterior to the limbus, but nothing comes out. It was a dry tap, and this was scary. I realized I'm missing something. It was a moment of sheer panic. Quickly, I closed the sclerotomy, closed the conch, hydrated all the wounds, and the AC continued to remain flat. The eye was patched and the patient was shifted out. 2 hours later, I mustered up some courage and took the patient back to the ultrasound room. Gingerly, I monitored the B scan being performed. The posterior pole scan was still fine, however, as we began scanning in the peripheral areas. This is what we found. There was clear evidence of suprachoroidal hemorrhage. It was restricted only to certain areas. And this was my first encounter with suprachoroidal hemorrhage in the last 20 years of my practice. These are the first day post-op pictures. There was corneal edema. The antechamber was still shallow, but the pressures had come down. The patient was treated with anti-glaucoma medications, topical steroids, systemic steroids, and atropine. Her blood pressures were normal from the second day onwards without any medication. And by the end of 1 month, the scans were normal, the suprachoroidal hemorrhage resolved, and the patient had a best credit visual acuity of 6.6. Now, about the misaligned lens, well, who cares? Masterly inactivity, conservative management, along with loads of prayers. This was all that was done, and the patient miraculously improved over a period of 1 month. The moral of the story: differentiating fluid misdirection from a limited or aborted suprachoroidal hemorrhage is very difficult. The presence or absence of a red glow may not be the best sign to rely on. In suspicious cases, it would be best to abort the surgery and do a thorough B scan evaluation to rule out an limited or evolving or aborted or an impending suprachoroidal hemorrhage. Although it's more glamorous and heroic to do a pars plana tap to drain out the fluid in the Berger space in a case with intraoperative hard eye, this case taught me something else.
Well, it taught me that being conservative is more sensible in such a situation. Thank you. So, it is, I never thought I would experience limited supraocular hemorrhage in my career. I thought it is for somebody else. It's never for me. How can I do? I always do phaco and other things, It's apna time aayega. So the moral of the story is apna time aayega. It is your luck if you get it in your 100th case or your 10,000th case or whatever it is. So I've had, after this case, another one case I've had. Of similar situation, but now you become wise. See, we are showing very adventurous thing like going and poking in the paspana and for all this draining the fluid and all those things. And sometimes this taught me, this case literally taught me that you have to be aware of certain things which you may not have experienced before. So it's very glamorous and might not be very difficult to go ahead and poke in the needle there and do it. In fact, you could end up in a disaster and lose the eye. So I have one of my friend, a corneal surgeon, whom I had referred a case for endothelial keratoplasty. They ended up having a similar situation, and they thought it was dealing with a fluid misdirection. They went and did trying to do a palaspana vitrectomy, and the suprachoroidal hemorrhage became an expulsive, and they lost the eye. So these are some things to learn for, and that's it. Thank you. No, now you should have a systematic protocol is there now. So how do you differentiate between these two? Usually you just wait for a couple of minutes. If it is fluid misdirection, it is going to become soft in maybe 10-15 minutes again immediately. Okay. Otherwise, if it behaves abnormally, best advice is to just abort the surgery, go ahead and give IV mannitol, do a B scan, thorough B scan, just not the posterior pole. You have to scan the other areas as well. Because phacoemulsification is a closed chamber technique. The peripheral, it is an evolving suprachoroidal hemorrhage might not be detected. That's the reason why the fundal red glow still continues to be good. So peripheral mound is developing there, and you are not able to see that because the closed chamber technique is preventing it from enlarging, the suprachoroidal hemorrhage from enlarging. That's the reason why it might be just stopping there. So these are the scenarios which we get in a closed chamber technique. If you're doing extracapsular, it would immediately become extensive suprachoroidal hemorrhage and it would have come. So in such situations, it might be very difficult. So best would be to abort and evaluate, and then you buy some time to live for another day. That's it.
We'll start the next session. This is a pupilloplasty procedure from the beginner's perspective. So we can do iris reconstruction in cases where there is traumatic mydriasis and where the cases there is iatrogenic damage or surgical complicated cases. We can perform pupilloplasty procedures for better visual function and quality. See, here we are having a surgeon who has a reasonable experience in cataract surgery and who performs cataracts on daily basis, and he or she is has seen an expert doing a cataracts pupilloplasty procedure and has watched many videos, and now she wants to try the pupilloplasty procedure herself. So we'll go through the mistakes and the proper way of pupilloplasty to be done. So here in traumatic mydriasis case, the cataract is already dealt with. It was a subluxated cataract, and we have already used the pilocarpine drops to bring down the pupil, and also the mechanical pulling was done. The first suture of pupilloplasty, that is a single 4-throw suture, was taken by an expert surgeon. So this is a beginner surgeon who is trying the pupilloplasty for the first time. So here, instead of a bent needle, the surgeon is using a straight needle. The proximal part of the needle is straight and the distal part is bent, so which is not the correct method. The proximal part should be more bent. The first pass through the iris was relatively easier part. So the second part, which the surgeon wants to go through the iris, now there was a difficulty as the needle was quite straight. If it would have been bent, so it would have been relatively easier. So the second bite through the iris was very small, and later on when you suture it, it might cause iris cut through, and release of the suture can happen. So here you can see the surgeon is struggling to come out of the anterior chamber, which is because of the less bend of the needle. And during the pupilloplasty procedure, this is a CIF4 needle which is used, and the proline suture, it is 10-0 proline suture, which should be used. Sorry, it's 9-0 proline suture. Now the angle of the needle is changed for better access, and the surgeon is quite successful in the second attempt. She comes out of the anterior chamber very easily. So the take-home message is, the first point should be there should be a proper bending of the needle here. So using a Sinski or a forceps, you can hold the distal part of the suture and bring it out of the incision where you have entered from the proline suture. So you are making a loop out of it, and the end of the suture should go through the loop 4 times. So that is called a single 4-throw sutures. There are many other methods like Sipser knot method, or Osher has modified those pupilloplasty procedures and making a suture out of it, and this is the easiest one. So you have to go through the loop 4 times without leaving the end of the suture. That is important. Why? Because once you go through the loop, if you leave the end, you don't remember how many passes have you made already. And if it's and here the surgeon is just leaves the end of the suture because she thinks that the visco is coming in between, and she'll wash it off and then pass it again. So here leaving the end was a mistake. So now the visco is washed off, and the surgeon doesn't remember how many passes have been done. So can you guess how many passes are done here? So if it's less, obviously the suture knot will not be tight enough. So the second mistake which was done was the end of the suture shouldn't be left while doing 4-pass sutures, 4-throw. So this it's the end of the pupilloplasty. Here you can see the suture being tied up, but there is slight cut through of the iris tissue, as the pass through the iris is not adequate enough. So there is a keyhole through the iris. So now here comes the expert surgeon, which had done the first surgical knot. So he is properly bending the needle so that it passes through the iris easily. So this is the proper method through which the needle should be bent. So he has made a side port through which a suture or the needle is passed, and you can see a side to side motion of the needle while entering through the side port. So this is the proper method to go through the side port so that the needle doesn't harm the incision, it doesn't bite through. So the chunk through which the needle is going is thicker, the iris chunk is thicker, and the bent part of the needle makes it quite easier to go through the iris. Here you can see both sides, the bite of the iris is quite thick, and you can come out of the eye through any part of the cornea. So pre-planning the suture location is quite important. So here the distal part of the knot is taken out to make a loop of the suture. So loop, here we have a 4-throw sutures now. So 4-throw pass should be done, and again for a beginner surgeon it's very important to not leave the end of the suture, and from one hand it should be handed over to the other which is holding the McPherson's forceps, and the distal and the proximal part of the suture is tied to make a knot. So you can use the main port to cut the suture ends, and that's the end of the procedure. So this is the second mistake which the beginner surgeon is making. As he is not pre-planned the incision or the suture which has to be taken, so the surgeon is going through the main port. Here the surgeon has bent the needle slightly. The surgeon here should make a mental map as to where the suture has to be placed. So the surgeon is grabbing the iris end at a different plane, and where it has to, he or she is intended to pass the suture, it's not there. So pre-planning the suture as to where the placement of the suture should be done has to be planned previous to the surgery. And this is the correction where the side port is used for placing the suture and for better accessibility. So the take-home message is proper planning of the placement of the suture should be done pre-operatively, and all smaller incisions would be quite easier to go through, and proper bite size through the iris to prevent the iris cut through. Is the same procedure, like we are forming a loop out of the distal end of the suture. and the first knot is slightly trimmed. It shouldn't be too long. So the take-home message is, first of all, there is proper prior planning of the placement of the sutures to be done. And second is bending of the needle is also important for easy passage. And the needle should pass through the incision with side-to-side motion. And the proper bite size through the iris so that there is no cut through of the iris. And the distal part of the suture is used to make a loop out of it. And the fourth row, during the fourth row pass, we should not leave the end of the suture. Thank you.
Any questions? So just for the curious minds, the first surgeon is myself. I had seen lots of videos, but I realized that there is a difference between seeing the videos and actually doing it. And it appears very clumsy when you try it for the first few times. But then you realize that once, if you have to try new technique, you have to become comfortable with appearing clumsy for a few times. You can shorten that period of becoming clumsy by your deliberate practice, by analyzing and again asking your mentors. But if you keep on doing the same thing, you will become better. But if you have to learn the new thing, become comfortable with looking clumsy to others. Yeah, basically you have to imagine where the when you have to mentally imagine where the knot will be coming, and then we will tie, and then it will close that loop. In the first, in the second one mistake, I was taking too long, trying to take too long path from the superior part to the inferior part. That would not have been also practical also.
So to answer, in case of traumatic mydriasis, sometimes you have overall enlargement of the pupil, or that you have to guess before in the preoperative period, or sometimes there is a sphincter damage only in one part. So if the sphincter damage, suppose, is only in the inferior part, you can take just one suture in the inferior part and you will find that the pupil is nicely centered with that. But if there is an overall enlargement of the pupil and sphincters are lost all over, better to take 2 bites, either horizontal or vertical, and make the suture, the pupil small, so it remains centered. So we'll move. So we'll move on to the subluxated cataract. So the first case that I am going to show is a case with 4 clock hours of subluxation.
This video is part of PhacoTips 3D teaching course. In this video, we'll be dealing with a subluxated cataract of 4 clock hours, 40-year-old male with history of blunt injury by ball, and there was traumatic mydriasis as well. I tried to make the capsulorhexis centered on the proposed central location of the bag, and you can clearly see the subluxation on the temporal side. So using the microcapsulorhexis forceps under dispersive OVD, I completed the capsulorhexis. It is important to keep little distance between the edge of the lens and the capsulorhexis so that we can put the capsular hooks. Now limited hydrodissection is done only in the area of subluxation where I want to put the capsular hooks. These are MST capsular hooks which support the equator of the bag. So I used 2 capsular hooks here. I avoided complete hydrodissection here because sometimes the nucleus may pop out of the bag and may make the things little difficult to stabilize the bag. Once the capsular hooks are in place, I completed the hydrodissection. It was a soft cataract which was expected in a young patient. So after the hydrodissection, the lens aspiration was done. Very minimal phaco energy was required because of the soft nucleus there, and at the end did PSS OVD exchange to maintain the anterior chamber. Cortex removal was thoroughly done. Because I have not used CTR yet, it was easy. There was no trapped cortex under the CTR. So that is why I generally wait for the CTR insertion. I use the capsular hooks to stabilize the bag first, remove the cataract, remove the cortex, and then I'll be inserting the CTR. Now before I insert CTR, I have slightly adjusted the capsular hooks because I don't want the CTR to go through these loops of the hooks so it doesn't get entangled. I can remove the capsular hooks completely as well here. So you can see how I am placing the CTR, taking Sinskey to guide the CTR into the bag, avoiding it popping out, and then at the end I will be using the micro forceps to grasp it, and then I use this longer Sinskey to guide it into the bag. Now the bag is well supported. I can remove the capsular hooks. I'll remove the little bits of the cortex which was left in the area of capsular hook there. You can see the bag is now stable. IL is now placed in the bag. It's a single piece hydrophobic IL in the bag. I removed the OVD from the bag and then placed OVD only in the anterior chamber, and now I will be doing the pupilloplasty using single pass 4-throw. Now in this case the traumatic mydriasis was because of the damaged iris only in the temporal part. I could see that in the nasal part the sphincter was working fine. So I decided to do a single pass 4-throw only on the temporal side. Using the 25 gauge forceps and the bend needle, 90 proline is used. Pass through the iris, taking care not to damage the iris. And once it is passed through and through, I will be pulling the suture out, and through this loop I will be taking 4 throws. These 4 throws secure the knot and I don't need another pass. So 2 micro graspers are used to take these 4 throws. You need to focus so that you don't reverse the throws anytime. When you are tightening the suture knot, make sure that you don't use excess power here, otherwise sometimes the suture may cut through the iris. So here you can see that the knot is nicely secured. I cut it with micro scissors and visco wash is thoroughly given. Patient had a good outcome post-operatively.
So this was the technique used for the subluxation, which is less than 6 clockers, and now I will show a technique where it's more than 6 clockers.
This video is part of PhacoTips 3D teaching course. In this video, we'll be seeing management of a subluxated cataract. So in this case, you can see inferior almost 5 to 6 clockers of zonular dialysis, and only at one place you can see few zonules are attached. So first thing is I am going to put heavy dispersive OVD in the area of subluxation. It avoids prolapse of vitreous, and then the regular dispersive OVD before we start capsulorhexis. Now in this case, it would have been better idea to stain the capsule because you can see the visibility is slightly less. But I could complete the capsulorhexis using cystitome and then shifting to microcapsulorhexis forceps. The central part of the capsule was fibrous, so I decided to move the capsulorhexis tear around this area so I could get a continuous curvilinear capsulorhexis. In the area of subluxation, it is important to stay away from the area of subluxation and then do very minimal hydrodissection to avoid nucleus prolapse. It is important to have CCC rim in the area of subluxation so we can put the capsular hooks. So I made posterior limbal incision for putting capsular hooks. So this is MST capsular hook which is being used. Capsular hooks provide support to the subluxated area of the bag and work like artificial zonules when we are doing phacoemulsification. So you can see the hook being passed and then it goes around the anterior capsular axis rim and you can see the tip of the capsular hook supporting the equator of the bag. So 2 capsular hooks were used here. Once the capsular hooks are in place, you will find that the phacoemulsification surgery becomes quite easy because they provide very good support to the bag in the subluxated area and you can do your regular technique of phacoemulsification. Here it was a soft cataract, so I decided to do trench divide and then phacoaspiration. In subluxated cataracts, it is better to keep low bottle height or low IOP. This avoids further prolapse of the vitreous and also avoids excess deepening of the anterior chamber which might increase the area of subluxation. It is important to use dispersive OVD throughout the procedure because nucleus removal sometimes is little anterior than the usual cases. While taking out phacoprobe, it is important that we do BSS OVD exchange so that the anterior chamber doesn't collapse. If we have not used CTR at the beginning, it's usually easier to take out the cortex. If we have used CTR, sometimes the cortex is trapped and then you have to remove it by using tangential movement of the eye probe. So once the cortex is out, I am going to put capsular tension ring. Now before this I can remove the capsular hooks as well, but I have kept it here just to keep the bag to one side, and you can see how the first eyelid goes into the bag and then slowly we move the McPherson and we push the CTR into the bag. It's very important to be very slow while doing that because if you try to do it very quickly, sometimes you may drag the bag. Now using capsular axis forceps, I am going to put the second eyelet here. It has to go around this capsular hook and it goes into the bag. I would have liked to rotate this CTR further so that the eyelets stay away from the area of subluxation so that it gets better support. So I rotated the CTR little bit. Now I am going to do a small flap from 2.5 millimeter to 1.5 and I am going to use here double flange technique. This is a 6-0 proline suture and CT segment which is there, and the eyelet is threaded with 6-0 proline and the bulb is created using the low temperature cautery. Once the bulb is formed, I will just check that it is holding the CT segment. You can see that now it is holding the CT segment. So now the other end of the 6-0 proline can pass through the 30 gauge needle. So I am just checking that it is passing through the bore of the 30 gauge needle. Now this 30 gauge needle will pass through the scleral flap. It is important to create space between iris and the bag to avoid inadvertent tear of the capsular bag while we are inserting the 30 gauge needle. So the passes through the flap underneath and pierces the sclera at around 1.5 millimeter. Now it is important to stay closer to the iris to avoid injury to the bag. We can also use iris repositor in the other hand to protect the bag. And now this 6-0 proline is threaded through the bore of the 30 gauge needle. Once it goes into the bore, you can retract this 30 gauge needle and proline will come out through the scleral incision. Now the CT segment, where one eyelet we have already passed the 60 proline, is introduced in the anterior chamber, and both the peripheral eyelets are maneuvered so that the CT segment goes into the bag while the central eyelet is anterior to the bag. Once the position is there, we can retract this 60 proline, and you will find that the bag gets centered when we retract this 60 proline. Now the 60 proline is trimmed. You just keep 1 to 1.5 millimeter 60 proline outside the sclera, and then you create small bulb using again cautery, and then it goes into the scleral flap which we have created. Thus we can use this double flange technique using 60 proline to fix the bag to the sclera through the CT segment. It's a very easy technique to learn. Of course, few things we have to be careful about is piercing the bag while passing the needle, and not to keep the suture too long, otherwise you will not have adequate tightening of the suture once you have made the bulb. Thank you.
So if there are, can you switch on the lights?
So what question? So one question. So is it okay to implant the lens first and then implant CT segment?
Yes, yes, yes. I think, in fact, last few cases I have started doing that, and reason is that it also protects when you are putting the CT segment. In one of my cases, the proline which was there, the tip which was flanged basically, when I pulled it in, it brushed against the PC and caused a PC tear. So I think to avoid that, it's better to place the IL in the bag and then put a CT segment. That might protect the PC in such cases. But I think one of the important things to learn here is to use the capsular capsular hooks for any case where you feel that zonular weakness is there. Okay, because once you put capsular hooks, even if you have completely loose zonules, if once you put capsular hooks, you will find that doing phaco becomes very easy, because they just replace the zonules and they are even stronger than the zonules. So you can do your usual technique without fearing that you will have difficulty in emulsification. So next, we are going to show a couple of cases. Only, the two cases, the steps are similar, and this is, to understand, or I would say this is going to examine or test your analytical skills, what is happening when the steps are done there. Double click.
These are two Morgagnonian cataract and chop technique. Just analyze these two videos. So that was the first case. Now this is second case.
I want all of you to watch the technique very carefully and analyze if you find any difference. We'll show again. So this is the first case. This is the second case. You want to see again? Light थोड़े से on करा. Light on करा. नहीं double click करते 3D जाते थे. Okay. Again watch. Yeah, there is no analysis yet.
Right, what is wrong? Are you asleep or what?
So the direction of the Sinski in the both cases is different.
Right.
The first is directed downwards, and the second one is which is the correct towards is coming from the periphery towards the.
So in the first case, the hold is at the center, so it is actually in the first case the nucleus is almost dancing. The hold, because you are holding from the center. In the second case, you have gone little more in the, you have passed the center and you are trying to chop the anterior 1/3. So I think in the second case, the hold is better.
Okay. Very good. So at least I think that answer is correct. That second technique is better. Now watch again. Start from the first this thing. Now don't watch the nucleus being broken. Just watch the capsule. Okay, so what was the difference? Correct. And first case you can see how the bag was dragged. Okay. So this can be the, you can switch on the lights. So, the difference between a successful or uncomplicated case and a complicated case can be so subtle. Okay. The difference between technique of a better surgeon and the average surgeon is always very, very subtle. And these videos is to show you that when you are analyzing any other surgeon's video, for example, you want to mimic, say, Dr. Deepak surgeries, you have to look at, all these nuances, all these small things which are happening inside the eye, and that will make you better. So if you want to copy someone, copy perfectly. Okay, and our Indian manufacturers are very good at that. So we copy everything perfectly, and that's why Indian products also have very good results in our patients and also cost effective. So I think for surgeons also same thing. If you copy someone, copy it perfectly. One more is video. Okay. So thank you. So now we'll have a little tea break to energize ourselves, and we'll start again in another 20 minutes, maybe. So we'll be beginning with the video. This is a very interesting video. I learned this particular technique from Dr. Bharti Megur's video, and where she showed the technique of removing subcapsular fibrosis. So let's begin with the video. So this was a pediatric cataract, and
this video is part of PhacoTips 3D teaching course.
If you see this cataract, you can see that it's kind of partially absorbed cataract, and if you see the anterior capsule, it appears fibrosed. So the anterior capsule has some fibrosis. So we are going to tackle this case. So initially when we examined the case, because this is a pediatric cataract, pre-op examination was not always complete. So when we check this patient on table, this is what we are seeing, and maybe we thought that we might have to use just the vitrectomy probe or maybe a scissor to cut open this anterior capsule and then probably place the IOL in the sulcus. So that was the preliminary plan. So the initial part was done, good staining of the anterior capsule was done, injected the heavy dispersive OVD Hylucoat, and then the initial part was done by my colleague where surgeon is trying to make an opening in the anterior capsule. So it was created in the central part. So the thought process was that we'll make a opening and then probably using a forceps, if we can make a anterior capsular excis, we'll be able to remove rest of the lens matter and place the IOL in the bag. But as expected, because there was subcapsular fibrosis, doing a larger capsular excis was not possible, as it was held by this subcapsular fibrotic bands. And as there was no way of enlarging it unless maybe probably we have to cut these bands or cut the anterior capsule itself along with these fibrosis. So that was probably another solution to this problem. What here I thought that maybe we can try this technique, which was very nicely described by Dr. Bharti Megur madam in one of her videos, where she showed how to remove this subcapsular fibrosis. So I thought, let me try this. If I can remove this fibrosis underneath the capsule before just trying to cut it open. So what I am doing now is using a forceps from the side port and using the Sinski in the other hand. I am just trying to give a counter traction. So I'm just grabbing that subcapsular fibrosis area there, and just very gentle traction is what is important, because if you pull it very fast you might cause zonular stretch and zonular breakage there. So I'm using the Sinski to just pull the anterior capsule away from this area of fibrosis, and by giving this gentle traction you find that it starts separating from the capsule. So basically anatomically this subcapsular fibrosis is probably the proliferated lens epithelial cells, and so they are not basically fused with the anterior capsule, and you can actually remove it easier than what you think. Again, here the importance is for patience, because you have to be very patient while you pull this subcapsular fibrotic bands in order to avoid damaging zonules as well as damaging the capsular excis margin. So watch how I am giving counter traction using the Sinski. So the anterior capsule is being held back, and sometimes you can also support the equator of the lens using iris repositor, but you can see that it starts coming off quite easily. The important thing is just do it slowly so you don't pull out the bag. So the fibrosed area is completely out, and now I can do routine bimanual irrigation aspiration. I will just shift forward, because this is not difficult part. So at the end you find that I can clean the entire bag. So where I was thinking of cutting this anterior capsule open and creating a larger excis, I could do a nice rexis and keep the entire bag as it is and remove all the fibrosis. So now here I decided that, because you can see that capsular excis is quite small here, so initial capsular excis what was made, it's still the same. So I decided to enlarge it a bit, and this is turned into monochrome. So there is with Ingenuity we can change the colors so that the capsular excis margin becomes more easily seen, and so a tangential nick is made using micro scissors, and then I'll be grabbing it with the micro excis forceps. And because it's an empty bag, we have to be very careful not to pull it radially, so always go tangentially very slowly. And at one point of time, there was still little bit of fibrosis which was left. So I had to negotiate. So this part, little bit of fibrosis was there. So I had to negotiate that part. So I had to change. And this is another thing. Whenever you are using this microforceps, when it goes subintially, it is better to change the hands rather than trying to pull from the same end. Many times in pediatric cataract, particularly, you tend to have extension of capsular axis if you try to negotiate this subincial area of the rhexis from the same end. So it's better to change hand and then complete the capsular axis. So the capsular axis was complete, and I could place the IL in the bag very easily. So this was already, we had planned 3-piece IL, so the same IL we are going to put, but in the bag. So the advantage of putting in the bag for pediatric case is probably that we can do a sulco fix, like if patient has some refractive surprise, we can place another IOL in the sulcus in future. So that is the advantage. So you can see that initially, which appeared to be kind of a completely fibrous capsule, now it's looking like absolutely normal capsule without any fibrosis, and probably this might be useful for the patient in the long run with better, like IOL is in the bag and I will be much more quiet as compared to IOL in the sulcus. So that was first. Thank you. So I think same thing we can use even in adult cases. Now I'm going to show another
This
case.
video is part of
It has two
PhacoTips 3D
parts.
teaching course.
First part is IPCL explantation. Now in future, we are going to see many of these cases, particularly the phakic IL, ICL, IPCL, where patients might come after 10, 20, 30 years with cataract. Now this particular unfortunate patient had trauma after putting IPCL. So after 1 year he got trauma, and the trauma, there was intumescent cataract formation. And so I had to remove this IPCL. So removing IPCL is very, very easy. Actually enlarge or make a large incision, just 2.8 is enough. So I want to stain this capsule below the IPCL because afterwards I have to do the rhexis and remove the cataract as well. So I decided, and yeah, I forgot to mention that after trauma, this patient had retinal detachment as well. So after trauma, I repaired the retinal detachment. It was almost like a giant retinal tear. And I operated, the posterior pole is attached, but vision is very poor, finger counting 2 meters. And afterwards, patient developed this intumescent cataract. Now, oil is still inside the eye. I decided not to remove oil as far as possible at this point because I don't know the retinal status, if it might detach. So I just wanted to remove the IPCL and remove the cataract. That was the plan. Now, first part is removal of the IPCL. So again, I am going to use a dispersive OVD here to protect the endothelium. And you just have to lift this IPCL up in the anterior chamber. It's very, very easy. You can use any blunt instrument like Sinskey. You can use those dialing holes also to pull up this IPCL into the anterior chamber. And once it is in the anterior chamber, you can use micro grasper forceps to pull it out. So first part is easily done. And you don't need to cut or anything. These IPCLs or ICLs are very, very thin, and you can just remove from the 2.8 incision. Just while removal, make sure that endothelium is not damaged. So put a Sinskey hook or any iris repositor over this IPCL. So while coming out, it doesn't rub on the endothelium. Now I use this Sinskey hook to pull the haptic to one side, so I can grab and take a good hold of this IPCL with the micro grasper forceps, and then I can easily pull it out from the 2.8 millimeter incision. Watch how I am protecting the endothelium using the Sinskey over this IPCL, so it doesn't have any physical touch. Now this is the most difficult intumescent cataract. So one thing is patient is young. Patient I think is 25-year-old. Patient has a lot of elastic tissues. Patient has undergone retinal surgery plus silicone oil has been implanted, is there inside the eye. So it is going to add to the buoyance. So it is going to push everything anteriorly the moment we enter into anterior chamber. So what do you expect in this case? Anyone? Guesses? Chocolate? Wait for it. So just watch again. So it doesn't give you any time for, and I am using heavy dispersive agent, patient is under block, I have massaged the eye, everything has been done. But these young patients with intumescent cataract, many times you may not get any time to react. So probably within, I had calculated probably 0.2 or 0.3 second, it just zips open. But the good thing about these cases is that the cataract is really soft, so you don't have to worry. And usually these tears do not extend to the posterior capsule because the pressure is on the anterior side, and not if you don't press the nucleus down much, it usually doesn't extend to the posterior side. So despite oil being there, I'm not much worried because I know that I can aspirate it very easily. So as Dr. Deepak showed in the afternoon, I just have to make a slightly larger opening, at least on one side, so that aspiration is easier. And so I made a nick, and I'm going to convert it into kind of semi-circular CCC or opening. And because young patient, very soft, it just gets aspirated in a quick, vacuum. And I don't have to do much, just need to be careful that I use proper fluidics, dynamics, use slightly lower parameters. Probably I have kept little bit less vacuum here, but rest of the thing is same. OVD and BSS exchange is done in order to avoid sudden shallowing of the anterior chamber after this. So these are the only things we have to take care of while doing these kind of cases. And in our experience, like because we get many trainees, young surgeons, we have extended rexis. We have done so many cases with extended tears of the capsule. We find that the chances of this tear going back is very, very, very minimal in expert hands. If you maintain the anterior chamber well and have very careful maneuvers throughout the surgery, then the extension is a very, very rare thing to happen. So I have placed the IL in the bag there with haptics which are perpendicular to this, and that's it. So I just wanted to show how the IPCL can be explanted very easily, and how we can manage Argentinian flag, that too quite easy. So thank you so much, and next talk will be by Dr. Deepak. Any questions we can discuss?
While removing the viscoelastic from under the IOL, Dr. Deepak prefers to put the irrigation cannula. I have seen Dr. Saurabh put the aspiration. Is there any difference when we want to clear out the visco from under the IOL once the lens is in the bag?
No, irrigation only. He also puts irrigation.
Both irrigation?
Yeah, irrigation.
Okay,
only,
that's
yes.
always better. It creates a wave-like thing.
No, Saurabh uses an coaxial, right? So it has a irrigation and aspiration.
That is
so
correct.
He has to go only.
Right.
So irrigation is safer, just passive washing out of the
correct.
The OVD. That's all.
And Dr. Saurabh, in all the cases I'm seeing, your bevel is many times facing downwards.
Yes.
Is that, I mean, it looks very dangerous when you're doing it.
That's what I said. The protection of PC is done by the phaco-dynamics or fluidics more than the position of the PhacoTip, because I use it in all my cases, and my PC rent rate is very, very, very low, in fact. So it doesn't. So that is not the reason for PC rupture. That
so the vacuum has to be kept low.
No, you can use the same vacuum.
Okay.
So I showed in the morning cases, and good that you highlighted this point. We have to pick out the cases where the risk of PC rupture is more.
Correct.
And there is a paper from Russia which says that if there is an anterior hyaloidal separation before you start the surgery, Or when you start the surgery, entire hyaloid gets separated. In those cases, this PC becomes little redundant, and we saw those fluctuations.
Yes.
These are the cases where you have to remember and then either lower the parameters, or maybe these are mostly last pieces, so I can pick it up little anteriorly and emulsify.
And what is the advantage of keeping it bevel down?
Bevel down or sideways is
Sideways
for
is good.
better vacuum, because
Better vacuum.
we want to attract the pieces common. When you keep it anteriorly, what according to that. But in case it is not there, we have a silicone oil mode on immersion A scan as well, so we can use that to calculate.
Okay, this is an elderly male patient who has a hypermature Morgagnian cataract, and I have planned a phacoemulsification in this patient. And so I'm expecting a very mobile nucleus. I'm not sure about the zonular strength in this patient. So what I'm doing is, if I lose the bag, maybe I would plan to do an iris claw fixation. So in this case, my plan was to do a scleral tunnel phacoemulsification, and if required, abort phaco and then convert it into SISS. That was my plan, because I did not know the health of the zonules and other things. And also, the scleral tunnel will be helpful if you have to implant a iris claw lens. That was the plan here. So I puncture the capsule, and the fluid comes out. So visualization is a problem here. So what you do is just go in and gently irrigation, just to clear off the field so that you can see well, and replenish the OVD once again. And then now I'm using forceps. So in eyes with Morgagnian cataracts, it is better to use forceps rather than needle, because you have a better control, and you can perform the rhexis without causing much of a stress. Lesser physical force is actually required when you use a forceps. And these are the situations where the forceps scores over that of using a needle in such situations. And so the nucleus is very much mobile here, and my plan is to do an horizontal chop technique in this situation. First, I'll try to create a central groove, just to see that whether I can divide it like this. And so the left hand instrument is stabilizing the globe, and now I'm trying to do. What is the problem which has happened for me is the wound hydration. The intracorneal tunnel was slightly bigger, and that is causing this massive wound hydration. And first of all, it's a complex case, and now the problem is I'm having difficulty in visualizing. So my chopping maneuvers, I'm not able to see well, and this is where I'm struggling here. So I have got one piece off now, and the visualization is not great. So usually in these mobile nucleus, my go-to chop always is the horizontal chop technique. So in this situation, I'm still continuing with my shop chopper, but now I get an idea that I should go ahead and switch to the horizontal chopper. This is a chopper which I'm not so used to, and this is a slightly longer. It's a modified Chang chopper like thing. The curvature is slightly bent than what I would have used regularly. And just please open your eyes and just look at it, what happens now. Okay, now I'm trying to negotiate it, and something has happened there. Okay, so you just have to go back and see this. I'm trying to negotiate the instrument which you're not so familiar with, and you're going to use it. And here I'm sitting in probably the superior place. The entire Descemet's membrane from maybe 3 o'clock to 6 o'clock, it is now stripped there. And you're having nuclear fragments inside still. Few of them are divided, and majority, one of the heminucleus is still as it is now. Now, how would you proceed with this situation now? So I would want anybody can stand up and answer. How do you want to proceed with this case? So you have a situation where the visualization is not great. The nucleus is quite hard, and you have a fairly large DMD which is there now. Now, how do you proceed with this case now? This is the area of DMD which is there, and so this is the challenge now. So any answers? Okay. So first thing what you do is you have to push the OVD to push back the DMD, whatever it is there. Now the question, $1,000,000 question, would you want to convert to SICS or Phaco? So why not Phaco in this patient now? Okay, the reason why Phaco could be much more deleterious here is there are two things. Phaco, the fluid is always constantly flowing inside. Okay, so what happens is it is always going to redetach the Descemet's membrane. It's almost free floating. And the side port instrument, again, we have to introduce. While in reintroducing the chopper, you are at every chance of extending the DMD. And apart from that, you have to deal with the nuclear fragments. That's the reason why you already have a scleral tunnel there, which is there, and you just have to extend the scleral incision on either side, and then so you enlarge the incision on either side, and then going to manually remove the fragments here. So again, put in OVD, and is all these maneuvers you are ensuring that the Descemet's detachment on my left side doesn't come into picture. So when you put the viscoelastic, put it from the right hand side, never use the side port, that side port again. So I'm trying to separate that the two fragments so that it has to be floated. See, because all these fragments are still attached, they're not totally free. The free one has come out. So try to separate them under the cover of OVD. So when things are going tough, you have to ensure that nothing more worse happens here. So you don't want a PC tear or a rexis extension and all these things. And try to do visco expression as much as possible. Press on the posterior lip and then push this nuclear fragment out. So the main problem here was the improper visualization because of the wound hydration. And in these elderly patients, always you have a risk of Descemet's coming off at some place. This is a very unusual complication for me, that I had Descemet detachment with many other places, but not with the side port instrument. This is the first of its kind which happened. So now you can see this is the fluttering DMD flap which is there. So you can see that it just goes back and settles here. Now here you can use an air tamponade as well, just air. But in inferior detachments, I always prefer to have a longer tamponade, because I have had experiences where the detachments again redetaches after some time. So in this case, again, I'm using C3F8 gas, 14%. You take 0.4 ml of it and then make it 5 ml. So I'm injecting the gas, and the incision is closed, and I thought the case was very well managed, and I was extremely happy, relieved, and I never expected anything to go wrong. But the nightmare continues. Next day, the patient comes. He came a little bit late actually than what the normal schedule was. So we were worried why he's not come late. The reasons was he had persistent vomiting in the early hours of morning. So he was so busy vomiting, he delayed his visit to the hospital. He never realized that the problem is in the eye. That is the reason why he's vomiting. Actually, what has happened here is, you can see it has caused a pupillary block. The gas is expanded in spite of using the right concentration, and some of the gas expanded has gone behind the pupil. It causes a pupillary block glaucoma. And the pressure is 64 now, 60. So it's very easy. When you go back and do an antersegment OCT, you can document very well that the iris is sticking on to one part of it. So this is a very, not an uncommon complication when you use gas for DMD treatment, and you should be mindful of it. So always better to admit the patient if you can, or ask them to report very early, because although you have used the right concentration, sometimes the gas bubble does expand. When you saw when I closed the case, the gas wasn't so much big, but later on it did expand, and this is what happens. So the treatment is very simple. You just go there and just decompress your paracentesis incision, which you do, and then the pupillary block is relieved. But when you can see the DMD is already attached, or there is no problem with the DMD as such, but the patient is in severe agony because of this. So you decompress the anterior chamber, and you can do it in the slit lamp as well. You don't have to take him to the operation theater. You can just do it in the slit lamp itself. Try to release not the entire gas, just a little bit. And so we are concerned whether the once the decompression has happened, whether the DMD will again recur back again, because we have reduced the size of the gas. But thankfully it remained attached, and eventually over a period of time it settled well. So these are the pictures. So what are the mistakes? I would have a second chance, when you are when having a complex situation before, and in this situation now retrospectively, I would have said the manual SICS would have been a safer choice in this patient to begin with. So retrospect vision is always 6-6. So this is how it is. And it's an unexpected complication of hydration. And always when you're having one scenario going bad for you, when you're not seeing well, try and stick to the technique and the instrumentation which you're most comfortable with. Trying to do use a chopper which was I'm not comfortable because you're not used to the angulation at which you enter and all those things. And unfortunately, I had this this complication. So a lot of things to learn from these things. The message here would be always try to keep the eyes which have got complications closer to your heart and never forget them, because these are the one which actually teach us a lot. Okay. And lastly, when you used gas, maybe doing an aridectomy in that time would have been better. If you would have avoided this pupillary block also. Thank you so much. For inferior detachments, I think it's we prefer to have it at least for 10 to 15 days. But for superior detachments, it's okay for 1 or 2 days also is enough. 1 day is also enough for superior detachments. Yeah, SF6 also is fine, no problem. That stays for maybe 1 week or so. For large inferior detachments, I still prefer a C3F8.
In this situation, iridectomy would have been only possible at say 6 o'clock.
No, it has to be done at 6 o'clock only, sir.
Achha.
Because for all gas reasons, you have to do an inferior iridectomy only. It has to be done at 6 o'clock.
Does it cause any diplopia or anything?
No, nothing. Peripheral iridectomy.
Excuse me, sir. In DM, the area of the DM, where to use air, and in which situation we have to use the gas.
Yeah, I told you, no?
Classification of that.
Yeah, see,
area-wise.
inferior detachments are extremely difficult to reattach. Okay? The reason is, whenever you put a gas, it always rolls up, it comes up. So, superior detachments are very easy to reattach, simply because the gas is always there for us to supporting it. Whereas the inferior detachment, what happens? Because as soon as the patient gets up, the bubble moves up. So that's the reason inferior detachments are much more challenging for them to reattach. So whenever we have inferior detachments, larger ones, the gas is preferable because it stays there for a longer duration of time, and that's the reason for us to use the gas in this. For all superior detachments, just air is fine.
Sir,
there are two type of gas, SF6 and that one.
C3F8.
Right.
Yeah, C3F8 stays for longer duration of time. SF6 stays for a slightly longer. SF6 is also okay. You can use that also. It is shorter duration of time, and the visual rehabilitation will be much more faster with SF6 because it doesn't stay for longer.
Now, what is the dilution ratio?
I think 14% is for C3F8 and 12% is for SF6. This is a non-expansile concentration.
So this mixture of C3F8 till 5 ml of plunge, the plunge is drawn back. It is air, sir? Combination of C3F8 with air or?
Yeah, air. See, you have taken 0.4 ml of gas, and then to make it 14%, the rest of it is the air until we are drawing up to 5 ml.
Sir, how much to push is just depending on the AC to form complete.
Yeah. See, what happens, you have to push and wait also sometimes. What happens, sometimes the gas might come out, wait for a few minutes. One more school of thought is pressurize fully and be there, make it very hard and be there for maybe 10 minutes, 7 minutes, and then decompress a little bit, leave the air bubble about 75% fill of this thing. So that is one I can do.
So one technique which I have learned from cornea surgeons while injecting this gas is, rather than injecting it from the side port, you can use a 30 gauge needle. Once you have done the inferior PI, you are not worried about the pupillary block glaucoma. So use a 30 gauge needle and don't go through the side port, just pass through the limbus, okay, make a new entry basically through the 30 gauge and inject the gas completely, and while you are coming out, just put a swab stick over that area, so it doesn't leak out. So you get a complete, feel of the gas in the anterior chamber. So this is sometimes done by surgeons after doing DMAC or DSEC, which stays, because the contact period of the gas for particularly the inferior part of the desmet, as Dr. Deepak was showing, is most critical. So if you have complete fill of the anterior chamber, even if when you are using C3F8, next day it will get absorbed little bit. Okay, so inferior part will be exposed. So if you have more complete fill, the chances are that for 24 hours at least, it's a complete, attachment of that desmet. So that helps in such cases.
New incision exactly opposite to the...
No incision, it's just an
limbal,
injection. Yeah,
limbal.
you just limbal, you inject.
Opposite to the...
inferiorly, like opposite.
So away from the area of detachment.
Yes.
But that's what she wanted to know.
Yes.
I think.
And while injecting, make sure that where you are injecting should be little on the down, because gas travels upward. So if it is up, you will not be able to fill it completely. So it should, at that time, the eyeball position should be little down when you inject and complete fill it, something like that.
Good evening, one and all. I am Dr. Sneha, consultant at Nandadi Pai Hospital, Kolhapur branch. There's too much of phaco since morning, so let's come back one step and see what all can happen in biometry. There was this one patient who presented to us with history. He was a 55-year-old male. He was farmer by occupation, known case of diabetes and hypertension. Came with complaint of diminution of vision in left eye since 1 month. On examination, his vision in right eye was 612 and N24. Left eye, it was counting finger half meter, N60. With correction, best corrected visual acuity in the right eye was 6.9 N6, and left eye there was no improvement. So as usual, we did a auto ref reading. Right eye was this thing, and in left eye the patient was not able to fixate. IOP was normal in both his eyes. Slit lamp examination revealed right eye was early cataract, and in left eye he had a mature intumescent cataract. Fundus, there was no view. Investigation, as in any case of mature cataract, a B scan was done in his left eye, which showed retina to be attached, and he was advised at cataract surgery. So we did IOL 700 in him, and it was expected that my optometrist would come back to me, and as usual he came back to me saying axial length he couldn't get in this. So I was like, okay, fine, no problem. We have a scan and we'll get the IOL master axial length in it. So what we did a scan, and on that day somehow our immersion was not working. So with contact, a scan in his left eye came to be 20.61, and in the next day immersion started working, and that time it was 21.02. AC depth, as you can see, left eye it was a shallow AC, and right eye was normal. While the axial length in his right eye was 23.46 mm. So difference of almost 3.5 mm in axial, axial length difference was there. We entered the same readings on our IOL master manually, and what power we got was other readings clear. In the right eye, it was around 21 diopter, and in the left eye, which was to be operated, it was around 30 diopters in almost both contact and immersion method. So, what to do next? Okay. Okay.
I had a similar case, and I had done the B scan, and I found that the length was not matching with what I was getting on A scan. And in that situation, I took the power from the other eye and ignored this.
Okay. Even I was of the opinion that the patient is a shabby looking farmer, and then maybe he is amblyopic in this eye, and we could go ahead with whatever the IOL power we have got. Till then, to my surprise, my counselor came telling me that, Madam, patient has opted for a trifocal. Now I was like, now what to do? I was like, he must not be having much expectations, but this shabby looking farmer was a rich farmer, having all sugarcane farms at Kolhapur. So please don't be biased by the attire that they are wearing. And he was affording farmer. Now what? He wants a trifocal. No, ma'am.
And for the grade of the cataract, was the vision disproportionately less?
No. It was mature intumescent cataract.
We could do it in 2 stages, maybe cataract first and biometry later, and IOL implantation.
Okay. Deepak sir, what you would do?
Or you can do on-table refraction, or even you can do on-table after removing the cataract, you can do biometry on your IOL master. Make the patient in sitting position, do an IOL master,
On
take
table.
the reading.
On the OT table.
During surgery, you remove the cataract,
Yes, sir.
then fill the chamber, take the patient, bring the IOL master in the theatre, do it there, and take the patient again on the theatre and put the lens.
No, what was the B scan
No,
like?
but then how patient opted for a trifocal? I had to order the lens beforehand.
No, then-
Whatever library lenses are there, it wasn't in that
then you have to
range.
keep the inventory. Means what else you can do otherwise? You can't do anything.
How many lenses are we going to keep in that way? And 30 diopters.
Or do it
the
in 2
odd
stages.
Powers. Okay, we'll keep
If
the
he
regular
wants trifocal,
powers.
then you do it in 2 stages. Remove cataract, then with a clear understanding to the patient that we will be doing first cataract surgery because of this dilemma. Okay. You have no other option.
B scan was okay?
A B scan was normal.
B scan was normal?
Yes, sir. Okay, so all of us have seen KBC. When in doubt, we have 3 options there. 50-50, call a friend, and then there was one more option called expert opinion. And then I told sir that this is the case. Sir suggested, as you all said, we decided to do a 2-stage procedure. First stage, cataract extraction and to leave him aphakic. And in second stage, we decided to put a trifocal. The same I convinced the patient, then again the patient goes back to the counselor. Until then, my optometrist also got to know that this is what we are planning to do. Both of them again came back to me and they started telling me, ma'am, in this age, how can you keep the patient aphakic? They'll think that we don't know to do surgery. Now what to do? And the patient also was not convinced with this 2-stage surgery.
Yeah, I think you need to counsel the counselor.
Yeah, that's what we did. We told the counselor this has to be done in 2 stages. And she was now like, what package should I tell? Should I tell the trifocal package or aphakia? We don't have any such package. Now what to do?
Yeah, good evening everybody. We also come across such situation. In such premium cases, doctor need to be a counselor.
Yeah, I did the counseling, ma'am, and I had convinced the patient, but my counselor and the optometrist were like, you cannot do this. They were telling me, how can you leave it aphakic?
Then you put the lens whichever you want and be ready to explant it and put it again.
Okay. Okay, my optometrist was like, they are so good glasses nowadays, we'll give him contact lenses, we'll then see whatever refraction is to be. LASIK, yeah, that was also an option. So,
Then you make piggyback lens. Put 23 lens, then if there is a residual anyway, it is giving 30. Put whatever right eye you got it. If there is a surprise, go for piggyback lens or so, that's better.
Okay.
That is an option.
So we told the patient and the attenders, they were like thinking like we don't know what is going on and something is wrong with us only here. So, but still they didn't go to any other doctor because I had told him, Saurabh sir has told this and we'll be doing this only. Then somehow they got convinced, and in first stage, we just did a cataract extraction and we left him a phakic. And he came back after 10 days, and then we repeated a IOL master again. Can you see the axial length now in the left eye? Same patient? It's almost the same as right eye. It is almost the same. And then the lens was ordered accordingly, and patient was implanted with a secondary trifocal lens, and he is very happy reading 6.6 and N6. So how, we'll just open this for discussion. How reliable is the IOL master? What are its limitations? And is A-scan really reliable?
A couple of points which I want to add here. So in such a situation when there is so much of an asymmetry between the right eye and the left eye, and you are having an hypermetropic eye, densely hypermetropic eye, there's always a chance of, amblyopia. So when you're counseling, for a trifocal lens in such a dense amblyopia, it's again a very important issue to consider first. But secondly, immersion aids can usually give a very reliable reading. In this case, I don't know why it did not give an accurate reading, but usually for all practical purposes, if your practice is slightly in the rural setting, you should have a good ultrasound machine with an immersion scan, because many times IOL master alone will not work in these dense cataracts. Especially if you have the 500 ones though, then definitely almost 50% of your cases you have to rely on your immersion A scans. So that is a big limitation of your the optical biometers. Either way, still I think you cannot perform, your hospital has to be equipped with a good immersion A scan.
So with only immersion being there, can we go with the premium IOLs?
That's a good question. The problem with for I use whenever in such a situations, the advantage of you having an IOL master is you can, if you don't have any other way to measure, the angle kappa can be measured with your IOL master. So I don't have an issue with the keratometry readings or the axial length with immersion biometry, but I have to measure the IOL angle kappa. And if I don't have any other instrument, IOL master is the go-to instrument. That is the reason why I would want to use an optical biometer for trifocal lenses, rather than for calculating the AL alone. Axial length is most often than not, my immersion biometries are okay with that.
Okay, so recently I heard of this Ladi method of calculating this thing, IOL power, where sir says that whatever you get on immersion axial length, you add 20 microns to it, and that is equivalent to your IOL master readings. Has anyone tried out that, or anyone knows anything about that? How relevant is it? And it is a copyright thing.
It's nothing new actually. If you go to Dr. Warren Hill's website, I think must be 20, 30-year-old, you always have a difference in the axial length read on optical biometer and immersion A scan, and you have to always add a 0.2 to your reading. So I think it's nothing new. So that's what we generally use. But what we have found out that even if we use the same axial, because 0.2 translates to roughly say 0.4 diopter in terms of IL power, and maybe 0.3 or 0.2 in terms of refractive error. Our refractive formulas where we are checking the accuracy, we are checking plus minus 0.5, which we consider as the gold standard. So when it happens below that, hardly it matters whether you add 0.1 or 0.2 in the axial length. So I don't believe in that formula, frankly.
Okay.
What I feel, see, what the masters say, that rather than going for all of this, what is needed is optimization of the A constant. So you have to study your own results and you will get bang on results.
That
Problem
is,
is we don't study our own results. That is the
so
problem.
that optimization of A constant was needed when the optical biometers were not commonly used. Nowadays, with the optical biometers, the A constants are already, optimized for that machine. So optimization is usually not for a surgeon, but for the equipment. So if you are using different immersion A scans and different keratometry machines, then you have to optimize the A constant. But say you are using ILMaster 700 and I am also using ILMaster 700, we should get the same results using the same A constant which have been already optimized.
On the same lines, how would we get to know how much is a surgeon-induced astigmatism? Well, we calculate any of the online calculators. This is one of the things that is there. So how does every individual get to know their surgeon-induced astigmatism?
You can calculate SIA using the same, on the same website by Dr. Hill. There is a Haggis calculator. It's an Excel sheet which you can fill up and you will get a SIA. Now again, the role of SIA nowadays has gone down. One thing is that our incisions are more consistent, 2.8 or less. We are not using 3.2 or larger incisions. Most of us are using temporal incisions, which again by the centroid value gives very less surgical induced astigmatism. So if you see the overall effect of SIA on the toric IL calculation part, it's very, very minimal. It is 0.1 to 0.2 diopter. Again, the question comes where the actual final outcome we are measuring in plus 0.5 minus diopters. Does this 0.1, 0.2 actually matters in terms of, surgical induced astigmatism, whether it actually changes the final outcome? But yes, if you want to be more and more accurate, because see, SI is also a mean of induced astigmatism. So if you say 0.2 diopter is my mean surgically induced astigmatism, in few cases it might be even 0.4 or 0.5, and in few cases it might be even 0. So there are a lot of corneal tissue factors which affect SIA. And that's the reason why any corneal incisions which we are using to correct astigmatism or refractive error has been traditionally found to be unpredictable. The same is true with LRI, same is true with RK, which we tried to correct many refractive errors, because the healing pattern in different patients differ. And that's the reason why toric ILs are better to use rather than relying on any of the incisional methods to correct the astigmatism.
The temporal incisions which we are using, they really don't cause any astigmatism. So if you just go back and check all your data, so every patient when he comes for 1 month checkup post-op, you just study the K readings, just a cursor, you don't have to do a very serious study. You come to know how much of a surgical induced astigmatism you're having. Just follow the pre-op K1, K2 reading and post-op K1, K2 reading. But on the contrary, if the surgeons are doing superior incisions, few of the surgeons might be still doing superior surgeons, that it does induce an astigmatism which is worthy of consideration. So if you're doing a superior incisions, then please go back and study your SIs. That will be higher than what we get in a temporal. As Saurabh was telling, it will not be more than 0.1 or 0.2, and it is hardly of any clinical significance nowadays. So when you enter it into your the toric IL calculation formulas, it may not make much of a difference. But however, if you're using a superior incision, then please do study it seriously.
I'd like to make a point regarding one of the options that you mentioned is call a friend. And in any case of biometry, where you have some suspicion, something odd, something difficult, something which is not fitting right, it's very easy and it's a very good practice that you send the patient to a colleague to do the biometry independently. So, for example, if you have ILMaster 500 and your colleague has 700, get it done on another machine, completely different place, different clinic, different person doing it. And sometimes that's useful. There are challenging situations where, in fact, a very interesting case of a patient of mine who's had extremely high keratoconus, and she's been my patient for almost 25 years, progressively developing cataract. She was using scleral contact lenses, and as the cataract was increasing, she kept on saying, I need to undergo surgery. I kept on delaying it because I said with very high cones, there was just no formula, there was no measurement. So I did the measurement on immersion biometry, I did it on Varion, I did it on IOL Master 500, IOL Master 700, and Terions. I sent it to 2-3 colleagues in Mumbai, each one giving all sorts of different results. In fact, talked to Dr. Saurabh also about the case, because sometimes in challenging situations, you don't need to use only your mind. Use different machines, use multiple minds. And the solution for that, fortunately, came through Dr. Neha, because even she kind of failed because she did the measurement and she was getting erratic values. And then when the patient was walking out of the clinic, she thought, okay, anyway, this patient is not going to be rid of the scleral contact lens. So she did the measurement with the scleral contact lens. And then whatever value we got with that, I put a monofocal lens. And now with the pre-existing scleral contact lens, she's doing very well. So sometimes you need multiple minds, multiple machines. And don't feel shy of sending to colleagues, because in a challenging situation, I think even the patient understands. And you can show the printouts that, see, this is the difficulty we are having, particularly for premium lenses.
Thank you. We have the last quiz for today, and after that there are 2 talks.
Sir, in immersion, I've seen that there is sometimes disparity in IL-pass between 2 eyes. It happens when sometimes even the optometrists are doing, air gets trapped just in front of the probe and it gives very erratic readings. So you better repeat, empty the shell, repeat it again, or you can always try next day also.
That's a good point.
So now next we'll move on to the next question. So this is anterior segment video, just watch it. This is subluxated lens, just dancing in the anterior chamber. So the question is, what you will do in this case? You will approach it, or you will send it to retina surgeon, or on what basis you will decide that who should approach it?
You can ask the patient to lie down and then observe how the lens is behaving. Is it falling back or is it staying in the place? If
Yes,
the lens
sir.
is falling back, then you can send it to the
Yes, just lie down the patient and check it is at what level. If it is just staying in the same plane above the zonular level, anterior segment surgeon can approach it. Otherwise, you have to send it back to retina surgeon. They will deal with it. So sir will get the chocolate. I think this is second chocolate he is getting.
Okay, so now we are finishing with the clinical program for the today. So we have a couple of talks now. I am sure that they will be also useful to you all. They are just connecting the laptop. I would request Dr. Deepak sir to please come and sit in the front seat. You can put the lights on. All the lights can be. याच्यातच आहे ना खूपच खेळत खूप
अभिषेक फोटो लाइट ऑन करा. Can you switch on all the lights? Switch on all the lights. So I hope that last 2 days have been useful to you all. Yes, sir. So those who find the first day was useful, they can raise your hands. Second day useful, raise the other hand.
For next day.
Yesterday was the yoga day, so at least today we did some yogasana. And of course, yeah, tomorrow, so third hand also. So now I'll be speaking about a very interesting topic, and I thought of speaking about it because many times our thoughts, ultimately decide what we want to become or what we become at the end. Can you switch on the lights, please? So just like tube light, these lights also come, very late. And we also think of, right things very late through our own errors, omissions, and then we learn so many things. But thanks to YouTube and other social media channels nowadays, we come to know others' mistakes first. So we can always avoid those mistakes. Unfortunately, we still do mistakes and then only learn better. So I'll be speaking about certain laws in life and actually how does it affect on our surgical journey, surgical learning. But I will also speak about what stops you from developing probably a successful practice, and probably this also stops you from developing a premium IL practice. Okay, so maybe we'll find some kind of correlation. Now, suppose this is a not very unique position. Suppose you are a surgeon who is going to visit a new facility. Okay. And they are going to welcome you, you are going to perform some surgery. You are a very successful surgeon, by hath ka khel, you can just do surgeries just like that. So you are visiting a new surgical center and you have a PC rupture, which has never happened in your life, till that time. And you are an expert surgeon visiting this new facility and you have a PCR. And so you ask for a vitrectomy cutter. Correct? Assistant says he doesn't have it. Right? Has it happened to any of you? Or has it happened to you in your setup sometimes that this is not ready, this and so I can see some heads nodding, And then you are frustrated, of course, and many times we have heard of this law. Yeah, very favorite law of ours, Murphy's law, right? So can anybody tell what is Murphy's law? Please, Mike, please. This is an interactive session because I will not be teaching anything. I think we have a lot of, seniors who can teach me a lot of better things. Yeah. So anything that can go wrong will go wrong, right? It can go wrong. So do you know what was the origin of this law, how it came, we think it's based on some study or something like that, or maybe a great philosopher thinking about universe and telling us. So it's a very interesting story. So Edward Murphy was in fact one of the inventors. He was in charge of a test checking the G-force on human beings or animals. Like when NASA wanted to put up a human being in space, they wanted to check all these things. So they were studying these things and he was part of a team which is supposed to check that G-force. So he invented a sensor so that when they were making these sleds and rockets and then they will put a chimpanzee there, and putting a chimpanzee is a very costly thing in those experiments. So he invented a sensor where you actually can sense how much G-force is there, and then they will correlate with the physiological changes. Okay. So during the first test of this kind, which had a lot of press and all, his assistant attached those sensors. Now the head of the entire program asked him specifically that please check yourself these sensors, which he proudly refused. No, this is a very simple thing. My assistant will do it. I don't have to bother. Sensors failed. And because the assistant had wired it wrongly. Okay. So entire big experiment just failed because of a simple error. And in the press conference, Murphy blamed it on the assistant, saying the saying that if a man can possibly make a mistake, he will make the mistake. Okay, so that is the origin of Murphy's law. So what do you gain from it? What is the origin of Murphy's law? Is actually lack of preparation and probably irritability. That somebody asked him, you go and check, and he was irritable. No, it's all right. Okay, so basically he was not prepared for the failure or possible causes of failure. So what Murphy's law actually teaches us is to be prepared. So if you are better prepared, this kind of law, it's not actually a law, it is in our mind just that if anything can go wrong, it is going to go wrong irrespective of what we do. It doesn't happen that. If we are more prepared, so we have plan A, B and C, it's likely that we are going to succeed. Okay, we are going to have a better outcomes. So that is the first thing which we learn from Murphy's law. Now another situation, a surgeon calls me with very fair experience of surgery, used lot of IOLs, monofocals, very experienced, and tells me that I want to learn to implant trifocal IOLs. Okay, now this is a very tricky thing because this means very different things from different surgeons. Okay, so what is the problem with this statement? Can anybody guess? Yes, sir. Can you mic, please?
Actually, the surgical steps involved are not different from what he is doing day in and day out. So maybe he is thinking when to implant a trifocal and what to expect from a trifocal rather than how to implant.
Correct. Yes. So this is what is known as Kidlin's law. Okay. So what this law says is that if you write the problem down clearly, okay, then matter is half solved. Most of the time what happens is that when you have some struggle, we have some problems, we tend to put it down little incorrectly. Okay, like this surgeon, he put it down his problem that I want to come and train for trifocal IOLs. Probably it means different things for different surgeons. Okay, so can you guess what can be different things? Okay, a surgeon says the same thing. There are 10 surgeons saying that I want to learn a premium IOL surgery. Okay. Now, Nidhi, can you just write it down, like what all things can it mean, and problem statements can be completely different. Like sir said, he doesn't have knowledge probably about when to use it or when not to use it. That is one thing. Any other thing you can think of?
How to counsel a patient.
Probably he doesn't have knowledge about counseling the patient. Okay. Selection of the patient. Yes.
He has a stress what the result will be.
Correct. Performance anxiety. He might be doing all right when the patient's expectations are low, but when it comes to, so the problem statement changes. I want to come to you so that I don't get stress while implanting premium IOL. Right? So problem statement has changed now. Okay. Any other thing? Okay, that is patient selection, type of IOL selection, fine. Anything else?
Shaky about the biometry.
Shaky about the biometry, knowledge of biometry, yes. Yes, knowledge about how to tackle or how I can tackle if patient is unhappy. Anything else? This is about basically counseling and all related. It may be surgical. I go to that surgeon's place, he is doing one surgery for 50 minutes. Okay, now what can be the problem statement? Maybe he is not confident of his surgery. His basic steps he is not confident of. He is taking long time to do the surgery. But he feels that, I should be doing premium IOLs. But his problem statement is wrong. He wants to do his regular cases more efficiently. So he becomes confident in doing surgeries and then he will be able. So same problem, you have 3-4 different problem statements. So unless you have your problem statements written down, you cannot point out, you cannot go to particular surgeon or particular mentor or particular teacher and tell him that these are my problems, solve this, and then you will get the answer. So you should always break down the problems that you have, Then each component can be analyzed properly. Then you make a strategic planning and implementation. Correct, okay. Correct.
He wants to learn basic surgery well.
Yes.
Problem is he's not willing to accept that and tell it to you. He's camouflaging the statement and telling, I want to learn trifocal premium surgeries.
Yes.
So this is one of the ways. What we come across this junior surgeons is honest self-assessment is very critical. So it may hurt their own self-esteem, but you should honestly analyze how good or how bad I am. That's the first step to start learning.
Correct, yes. So based on this, yes. Correct, yes. So similarly, you can also suggest any problems that you think of, or your colleagues might be telling you that, I have got this kind of problem or something like that. And you will find out that if you ask them to write down the problems, many times writing down the problem, as the law suggests, takes care of the solution, because the moment you write down the problem, the solutions come automatically, because you start thinking of solutions when you write it down. So that was one of the laws that I think that has helped me a lot while taking care of many issues. So another thing which, all of us face this right from the MBBS days, junior residency, senior residency, and, we always have complaints, and same things even nowadays residents, senior residents, fellows, consultants keep on complaining. First is that I did not get enough surgeries during residency or while doing the job, right? Then when somebody goes ahead, I did not get the surgeries regularly, so there were breaks in between. Then I was not taught complication management. Though I did the surgeries, I was never taught complication management. So now, what to do? So generally, basically what we all want ultimately is success in some form, right? So what is the law of success? The law of success is where preparation and opportunity meet, right? So success is where preparation and opportunity meet. But what happens is that we expect that both go simultaneously. That means preparation as well as opportunity should go simultaneously. All other way, I should get opportunity first, then I will start preparing. That is the usual thought process that we have. But most of the times in real life, it is opposite. We have to start preparing first. So when the opportunity comes, and it may be less. So probably, as the time changes, the opportunities change. Probably 20 years back, the opportunities or ways of opportunities were different. Today it is different. Maybe 20 years down the line, it will be all different scenario, right? But what cannot change is preparation. Can you prepare yourself for the time when you are going to get opportunity, which may be this year, next year, or maybe 5 years down the line, but you should start preparing. And I know many people who do that, and when they come to us for training, we immediately know whether they have prepared themselves for coming for surgical training, and it makes a huge difference. For example, even residents or trainees who come to us, in their first case itself, we know, are they observing, are they reading about the case or about the theory, about the practical aspects, are they analyzing each and everything that they do? If they see just one patient in a day in OPD, are they analyzing, are they keeping notes about that patient? Are they reviewing their own cases regularly? Even if they do say one case in a month, have they reviewed it very nicely in that month or not? And are they communicating well with their teachers, mentors in a proper manner? Are they, properly communicating about their problems, what issues they are having? Not just that I have to know complication management, I have to do many cases, I have to do cases regularly, not that. What my problems were while I was doing this particular thing, not just surgical training, it may be OPD, it may be procedures, different things. So all these things will make you prepared for that opportunity. And opportunity will come maybe this year, next year, or 5 years down the line. But if you are prepared well, the law of success says that preparation should meet opportunity. So whatever is in our hand, we should do it completely. And that's what I always followed right from my MBBS days. Always prepare to your best of your ability, so that whenever the opportunity, knocks your door, you come on top. So always get out of this vicious cycle whenever you are in trouble during your days. Emotions, grudges, blame games, blaming out someone else, or victimhood that I am I am doing so much and still I am not getting. Remember, the opportunities may not be still there. When it comes, you are already prepared if you put on the hard work. So always rely more on information, intelligence, and always optimism. I have seen that optimistic residents, those who are intelligent, who are always well informed, who are hardworking, they do well whenever they get opportunity, whenever it comes. Okay, so now I will come back to little bit basics, which is very close to our hearts, is hurdles in starting premium practice. Okay, so I think we have discussed few things about it. Anybody else wants to enumerate what are your problems of starting? So how many of you are doing premium IELTS very, very regularly? Like, raise your hands. Yeah, few. But I think most of us are not doing it very regularly. So you can come up and answer these questions. As I said, you have to first find the problem statement. Okay. So can I have few answers? What are the hurdles in starting premium practice? From your personal point of view, you can just answer. Yes. Can you give mic? Apprehension. Yes.
Premium practice will involve their expectations will be increased, and for beginners it's like would I be able to satisfy him, or to start up with, this is the main thing we face.
Yes.
As a beginner.
Sir. Confidence of surgery, apprehension. Yes. What are the hurdles? You have to tell hurdles out loudly so that you get a solution. I told.
Cost of the surgery, convincing the patient for the premium.
For the cost of the surgery. Okay. Okay, that's what you think, that you need a bigger infrastructure so that patient gets convinced. Okay, you need a lot of other things like marketing team, advertisements, and other things to start. Yes. Okay, so a certain red tapeism in your practice. Yes.
Cataract surgery is not a subspecialty in ophthalmology.
Yes.
No, that is a problem. Everyone thinks that cataract is a general ophthalmologist playground and others are specialty. So everyone wants to do a specialty and then do a short course and learn cataract surgery, and then the hurdles arise for premium IOL practice. If you are confident of being a good cataract surgeon, you shouldn't have any hurdles because you are trained to achieve perfection. If you treat it as a subspecialty rather than a general thing, then you shouldn't have a problem.
Great. Okay. Anything else? Yes, sir.
Because even if you are a good cataract surgeon, those who are good at doing ECC, they had lots of trouble when they had to convert to phaco. Those who are doing good phaco, you have to again learn how to do torics, then you have to learn how to do multifocal, then you have to learn how to do multifocal torics. Lenses are changing, technology is changing.
Yes.
So I always tell the younger generation that what you learned during your residency days, possibly 90-95% of your surgical work will have no connection to what you learned at that time. So you have to learn forever.
Yes. Very good. So I will tell my experience, of becoming a premium IOL cataract surgeon or premium IOL practitioner. When I joined, I was formally trained as a retina surgeon. So when I joined practice, I was, of the, kind of thought or of the opinion that I am primarily a retina surgeon, okay, and I also do cataracts, right? So with that thought process, I started doing cataract surgeries, and for first 1 year, 2 years, I was doing like that, Then I realized that I am good at it, okay, but still I am not like, other surgeons which I see or I meet in the conferences where they talk about premium IOLs and other things. Now what is the problem? Okay, I have the necessary skills or anything, or I can achieve it if required. The problem was this, do I look at myself as a premium IOL practitioner? Okay, in the book Atomic Habits, Okay, many times we feel that when we put out the results, okay, then we are identified as someone, correct? That is what is the thought process. That means, suppose one is a very great orator or a great, I would say, leader, because now he has gathered people around him and he has, made a party or something like that. But that is not true. Okay, so I will tell you what is most important thing, in fact, is how do you identify yourself. For example, many legendary leaders, okay, they first identified themselves as great leaders. Okay, they always portrayed as great leaders, or maybe great engineers, scientists, or something like that, and then slowly they became that. Okay, it is not other way around, that they first became leaders and then they identified themselves as leaders. So similarly, you have to first identify. So you have to tell yourself, I am a premium IL practitioner. I can, very well do all premium IL patients. I can satisfy them. I can do everything for them. When you identify yourself as a premium IL practitioner, then your body language changes. Then you are not thinking about infrastructure. You are not thinking about whether I will be able to satisfy that patient or not, or whether I'll be, thinking about whether I should tell high charges or not for your services. This thing will go in the background once you decide that, no, I am a premium IL practitioner and I'll be speaking with, or I will be communicating with each of my patient in the same manner. Okay. Same thing happens when I became a refractive surgeon in probably 2016. Before that, I was not doing any refractive surgery. I was just doing IPCL, no LASIK, no femto, nothing. Okay, so first, once we got the refractive suit, the first 3, 4, or 6 months, I was not identifying myself as a refractive surgeon. And that's the reason for my failure. Like, I was the same thing, I was thinking, how will I convince patient to pay, 1 lakh rupees or 1.5 lakh rupees for smile surgery in my town? That was my thought process, okay? But then when I realized, no, I should start thinking as a refractive surgeon. So I went to a couple of places, attended their OPDs, okay, how they were approaching patients. It is lot different than how a retina surgeon approaches his own patients, okay? A cataract surgeon approaches the patient differently. A premium IL cataract surgeon approaches the patient differently. A refractive surgeon approaches the same patient differently. Okay, so because they identify themselves as refractive surgeon. So the moment I started identifying myself as a refractive surgeon, my body language changed, my thought process changed, my communication skills changed, and I was more proactive. Okay, so when like for example, you are seeing apprehensive about counseling patient. I am not apprehensive about counseling patient about bad effects of these premium ILs. Yes, of course we inform the patients, but we are talking about the positive points, because we have now done so many patients, where we have seen so many implants, we have seen so many patients who have been done and who have been happy with the implant. So that is something we should be keeping in the mind. Another thing what is very important is what is told in the sales part, is that when a salesman goes and tells that, see, I am not going to take care of these small orders, I am going to always go for a big order. Unless a big order comes, I am not going to deliver these small orders. But what is important in sales is that, are you efficient, are you confident in delivering small orders? Okay, the same thing applies to our practice. Are we confident, are we efficient in delivering excellent result even with lower paying patients or non-premium patients? If we are good at that, we are going to start getting the bigger orders, which are the premium ILs. So we have to focus on that. So these are a few things which we must, first attain, and then we will start identifying ourselves. Okay, so regular cases finish say 15 to 30 minutes. Okay, no anxiety while advising patient any surgery for that matter. If you are thinking anxiety, what will happen to this patient in your mind, it shows in your body language, and believe me, there are vibes which are caught by the patients very easily. You will find a positive surgeon, the same patient gets counseled or gets ready for the surgery very easily. Well, another patient another doctor who is anxious about the result, patient will pick up vibes. and that patient is not going to get operated from you. So you have to make sure that during, advising surgery, if you are having anxiety, there is some issue. You have to focus, and as we are talking about last 2 days, how to reduce the complication rate. We have to find out and practice each and every little maneuver that reduces the complication rate. Okay, if you reduce it to so less, you are more confident about your results. Your anxiety goes down and you are confident. So the process is going to continue. And you will find that when you are doing good with the small orders, more and more patients are getting other eye operated with you very quickly. That means you are confident in now going for the premium IOL practice. You don't have to worry about anything. Like one of the delegates said, am I proactive in managing unhappy patient? Do you think you get unhappy patient only with premium IOLs? How many of non-premium IOL patients are unhappy? Same percentage. Same percentage. Okay, there is no difference. You will find same number of patients are unhappy with non-premium IOLs, same as premium IOLs. How we are treating them, how we are trying to convince them, how we are empathetic with them. Do I communicate with them properly? Okay, that is habit. Once we get into that good habit, do we give enough thought and time for that patient? We explain to them that these are the issues we need to solve. Maybe we may not be able to solve, but still I will take care of you. Or do I just keep disposing of this patient or send to others, and so am I good at managing those unhappy patients even in non-premium IOL patient? That is very important. And of course, the later part is, am I good surgically managing unsatisfactory outcome, right? So we have to upgrade, we have to keep on upgrading our knowledge all the time. We should be able to rotate toric IOLs if patient is unhappy with the toric rotation. We should be able to exchange the IOL. We showed many cases where we explanted the IOLs, we exchanged the IOLs. We should be able to provide or give information to the patient about refractive lasers available to take care of, say, residual refractive errors. We have now Silker fixed lenses also, which you can use for residual. So we have to provide a solution. So most of the times patients are unhappy when we don't provide them a solution. Whether they go for it or not is a different thing, but we should be confident in providing them a solution when there is an unsatisfactory outcome. Now remember this every time. Perfection is enemy of the good. Okay, what does it mean? Yes, please. Mike, please. Yeah.
But they are waiting for the perfect time, perfect patient who is not expecting too much. That could be also be the hurdle for them, I think.
Yes.
There is no perfect time for anything. They have to just start doing it.
Yes. Anybody else? Yes, sir.
You feel that you should deliver a perfect result every time for every patient, for every eye. So if you're going to have that high expectation, you will never progress, because you're not going to be perfect for every patient, every time, every eye.
Yes. So all my patients are 6x6, N6 is a big lie. Okay? It's a big lie. No matter who tells about this, it's a big lie. It's not possible. Yeah, all my patients are happy is possible. Okay? That is because your communication, your problem solving ability for that patient, you can make patients happy and satisfied. You can achieve probably up to 100%. But 6x6, N6 is a lie. Not all our patients are 6x6, N6. And always, I think this is the most important thing to achieve success. You have to get comfortable with failure. Okay? And as Dr. Nidhi mentioned in her talk, that failures are considered as our gurus, provided that we learn from them. Okay? Otherwise, we will keep on failing without learning anything, then it's not going to learn you. But be comfortable with whatever failures you have in life. And always understand the science and keep improving. Like he was saying, we have to learn, relearn, always keep attending conferences. Rather than attending conferences, you can go to certain surgeons and watch them closely. I generally try every 1 or 2 years I go and attend some influential surgeon or practitioner, because there are a lot of things to learn from many different surgeons. So keep learning from them and keep adapting to them. So only way, I think this was told to me by Dr. Nidhi from one of the books, the only way to get over the fear of doing something is to go out and do it. Correct? If I have fear of heights, will it get solved sitting in this hall? Unless I climb a mountain and maybe feel that height, it's not going to say. Similarly, if you have some anxiety, apprehension of doing premium IL practice, how can you get over it? By doing it. So do more and more premium IL. Have a lot of unsatisfied patients. That's the way to learn, to become an ace premium IL practitioner. So wish you all very, very unsatisfied high number of premium IL patients, because those will be only 0.5%. So that many multiple times you have many satisfied patients as well. I think the final key to success, I think what I found and throughout what I actually feel, and that's what I have observed all throughout my life so far, observing others, observing students, my seniors, my colleague and everything, I think gratitude is the core of success, okay? Because success is a perceived notion. You consider someone or something successful, which is a perception. And when you are grateful to many other things which are happening to you, whether it is good or it might be little bit bad, if you are grateful to that, it transforms your life, the way you look at life, It will add grace to your personality, okay? Your emotions change, you are more positive. You keep faith on system, you keep faith on people, your own, colleagues, you keep faith on your, staff members. You forgive them for, some issues that they create. You have kind heart. You always help to those who ask for help. You thank them when they help you. You have a good feeling towards others. You believe in not just yourself, but those around you. That is what sets you apart. You have the right attitude towards different things. You always appreciate what others are doing to you as well as doing to others. You appreciate they are doing great work. You are always empathetic either to patients, your colleagues, or many other things around your life. So I think that's what is most important law of success, that once you have this, all other things will become successful. So thank you so much. That was my 2 cents about laws of life. So thank you. Thank you so much for joining us for last 2 days, and hopefully tomorrow will be an even nicer day. And yes. So after this, we have a very, very nice talk, and I would say it is going to influence you for life, by my father, Dr. Dilip Patwardhan, and he is going to talk about stress management, which is the most important thing in our lives nowadays. So he is going to talk about that. I would like to invite him, as well as I would like to invite my mother, Dr. Madhavi Patwardhan, Dr. Deepak. We have Nidhi. We have a small inauguration of the e-book, because last year also we made an e-book. So it's kind of a PDF, and where it is written in the form of book, but you have video links. So once you click on that PDF link, you can directly go. So basically this, Priyanka. He could have, Rupal madam. Yes. So basically this concept came to us because of one of our consultant, Dr. Abhay. And when he joined me, he asked me, how should I read? Because I keep seeing your videos on YouTube, but I don't know which book to read. So I said, what you do, you see all my videos from my YouTube channel and you write something about it. Okay, whatever you have learned from those videos. So he made that nice compilation initially, and I thought that let's publish it as an e-book, because many times people don't know where to watch, what to watch serially. So this is kind of an e-book, and this year Dr. Priyanka Thuma, she is my ex-fellow and now consultant at Nandadeep Eye Hospital. Where is Priyanka? She joined us and she has refined it even further. One of our consultant, Dr. Smith, he also contributed one of the chapters in that book, and we'll keep updating it. This is the new generation books, you don't have to publish it on a paper. It's just a PDF which we can change and modify multiple times. So I would like to request Abba to just inaugurate that ebook, and we'll share that PDF very soon once the links are there.
Yes, please.
Hello, 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 hello. Good evening. Good evening. Tired of academic sort of a full meal of academic, education. Of course, I'm not going to talk about academics at all. Absolutely, it will be a totally different type of lecture. Not lecture, rather. You will find many things useful in your life. Okay. Yeah. This is my biodata. Because my son never introduces me, so I have to introduce myself. This is my biodata. By the way, so what you are learning, Phaco and everything, I learned it in 1996, okay? And that time there were no workshops like this. We used to learn on our own, all parameters, everything we learned. But then two things he told about I tell you the definition of luck is that hard work in the right direction marriage with opportunity, that is called luck. He says the same thing. Secondly, he told about the failure, fail. Fail means what? First attempt in learning. And learn again, don't repeat the mistake. So I just to continue that. So let us start. See, I come from a Jivan Vidya mission, which is a sort of a spiritual NGO. And we always start any lecture with this prayer. So I request you to just follow me. It's quite good universal prayer. Say, oh God, bless all with health and wealth. Bless all with money and harmony. Oh God, bless all with peace and bliss. And bless all with wisdom and your devotion. Yeah, there are two very important factors in this. The all is the word which is continuously repeated, isn't it? So we think of all. Not I. I leads to illness and we leads to wellness. Always remember that. Secondly, wisdom. Wisdom. The difference is we never ask cleverness. See, cleverness you can get sometimes genetically also, but wisdom is totally different. It doesn't get from your parents, Wisdom is what? Application of your intelligence, isn't it? Means creating a nuclear power required intelligence, but using it, creating atom bomb and destroying 2 cities was not wisdom, isn't it? To convert it into electricity is the wisdom. So application of intelligence, that is the importance of this prayer. Now, let us go to basics. You may be doctor, you may be engineer, you may be architect, you may be anybody. What do you want in life? I will tell you a story. Yes, happiness. Perfect. Actually, that was the answer. I will tell you a very nice story. 9th year students were there and their madam gave them assignment. That was the last lecture. She gave paper slips to everybody and she said, what do you want to be in life? 9th standard students. And of course, when somebody wrote, I want to be architect, somebody wrote, I want to be doctor, engineer, like that. And one student was scratching his head, not deciding what to do. And ultimately, he wrote down something. Every student used to come, give the sheet to the madam to read, oh, very good, go. He has to go out. And lastly, that student came, and exactly he wrote the same thing. Madam said, hey, come here. She was going out. You didn't understand my assignment. The assignment you didn't understand. See, everybody has written architect, engineer, like that. And what you have written? He said, I want to be happy. I want to be happy. That student said, madam, no, I did understand the assignment, but you don't understand the life. Isn't it? Ultimately, what do you want in life? You want happiness. The concept, how to get happiness, where to get happiness, differs. Okay? I will give the conceptual clarity about that. Okay? See, in life, your ABCD of life you should know, isn't it? Birth, you don't have control. Isn't it? D, death, you don't have control. But the C in between, choice to live, is you know, isn't it? So, you are not winners, born winners, not losers. We are choosers. So you choose your life. Very simple. How to choose, that is very important. Many times, people have got different liking. Can I get water? Please. So people have got different likings, isn't it? And they have got aptitude different, but they are forced somewhere, isn't it? In something else, which they don't want to do, real aptitude. I don't know how many of you really wanted to become ophthalmologist. Now you are in ophthalmology, it's okay, but sometimes no, it is not so, isn't it? Yeah. Why specifically I asked for this? Because you must have seen, we are seeing plastic, this thing, we never use plastic, we always use steel. That is also one lesson. So sometimes your parents force on you, peer pressure, your brother is doctor, this is doctor, you become doctor, something like, isn't it? So there is a very nice video I have got, which definitely gives you a very nice idea. Just listen to it.
एक आदमी एक सूटकेस लेके सर्कस के मैनेजर के कमरे में गया और उसने कहा कि क्या आप अनूठी चीजों में उत्सुक हैं? मैनेजर ने कहा कि निश्चित, हमारा काम ही अनूठी चीजों का है। क्या अनूठी चीज है? उसने कहा मेरे पास एक कुत्ता है जो पियानो बजाता है। मैनेजर की तो आंखें फटी रही, कुत्ता कहाँ है? उसने सूटकेस खोला, एक छोटा सा कुत्ता उसमें से निकला और एक छोटा सा पियानो उसने निकाला सूटकेस में से, पियानो रख दिया और वो कुत्ता बैठ के पियानो बजाने लगा। क्या गजब का साज उसने छेड़ा! मैनेजर तो भौंचक्का रह गया, सांस रुकी की रुकी रहेगी। बहुत खेल देखे थे दुनिया में, उसने काम ही उसका ये था, इसी तरह की चीजों पर उसका सर्कस चलता था। और तभी एक बड़ा कुत्ता अंदर आया और उस छोटे कुत्ते की गर्दन उसने पकड़ी और बाहर ले गया। मैनेजर तो देखते रह गया, वो आदमी भी देखते। मैनेजर ने कहा भाई ये मामला क्या है, ये कौन कुत्ता है? उसने कहा ये इसकी मां, वो उसको डॉक्टर बनाना चाहती। एक आदमी एक
That is the problem, isn't it? Parents sometimes force their own ambition. It's not so. So I will tell you that is, I want you to understand what to do in life, isn't it? Choose your life properly. Now, about the stress. Simple. Stress is not bad. Total stress is never, some stress is, that's a use stress, isn't it? Positive stress is needed. Otherwise, you go very much relaxed. When few students are so relaxed, go for exam doing no study, I am relaxed. They fail, isn't it? Some stress has to be there, especially driving in India. Oh, you have got some stress, 100%, isn't it? Otherwise, the donkeys will come and anybody will come in front of you. So, some stress, that increases your efficiency. See, the bow is there, unless you stretch it, you cannot shoot arrow, isn't it? Some positive stress is a must, but when it becomes pathological, well, you have to tackle it. People say stress management. Sorry, that is a wrong word. See, family has to be managed, company has to be managed, stress has to be tackled. Correct? So that is the thing. Now, simple equation of stress. Just you are learning everything. Exactly what he was telling. Increase the efficiency. Expectations minus ability. Are your expectations were very good to do premium lenses, but are you able? Are you able to do that? So increase your ability. Of course, that definitely stress will be less. Expectations minus ability is a simple equation of stress. If you want to reduce the stress, either increase your ability or keep low expectations. As simple as that. Okay? Right. This is the same formula given. Now, ultimately, one wants to be happy, isn't it? One wants to be happy. Very simple. Now, usually, we are Indians, and our Indian philosophy always says, Satchidananda, isn't it? Where is joy? It is within. Every philosophical person tells, you have to prove it. No, we are scientific people. You have to prove that joy is within, isn't it? And most important thing, there is a law of, laws of nature are absolutely consistent. There is no exception. Law of nature is that action, reaction. You do action, there will be reaction. Kriya hai to pratikriya hogi. Action, reaction is the law of nature. There is no expectation, no exception for that, 100%. So, now simple question if I ask, if you want to have joy, you want to be happy, what should be done? We have to give it to others. Very simple. So, giving others only will give happiness. You cannot scratch happiness from somebody. You have to first give. Then only you get happiness. It is as simple as that. Then what happens? See, if you have got money, they can you give others, no? Similarly, you should be first happy, no? I will tell you, the real thing is that everybody is happy itself. He, by a lot of efforts, makes himself unhappy. We people do so many things to make himself. Other, your happiness is within. Problem is that you try to search happiness outside by using our sense organs, isn't it? Seeing a good movie, hearing a very nice song, eating a very good food, or hearing a very good joke, isn't it? So you try to search outside, but the direction is wrong. Direction is wrong. It should be inside. Then you have to prove it that is inside. So whatever you have got, that only you can give others, no? I will prove that joy is within. Simple? Scientifically, I will prove. Now, you must have seen small kids, 8-month, 9-month old child, isn't it? You ask any pediatrician, oh, why pediatrician? You are all mothers and everything. The child smiles or laughs at least 350 times in a day, isn't it? Cries only when either he is hungry or having pain or something. Otherwise, why he laughs? Law of cause and effect. Effect is that the child smiles. Effect is that child laughs. There has to be reason, no? You may not know the reason, but reason is that the joy is within, which is the fountain of joy. It is a representation of smiling and laughing of that joy within. He experiences that joy within. Are you getting it? That is why he is laughing. Otherwise, why he should laugh? There is no reason. Nobody tells him joke and he understands the joke. No, isn't it? He laughs because the joy is within and it is experienced by the child and he laughs. See the saints also, they are always smiling, isn't it? They are smiling. Why? They don't need outside anything. We call Vishyananda. We don't need it. We don't need. You can be just happy without external senses. Are you getting it? So joy is within. Child, you understood that? Another thing I'll tell you. See, suppose we feel that, we went to concert of Lata Mangeshkar. Imagine. Everybody likes Lata Mangeshkar. Nowadays, Arijit Singh is very popular with young, isn't it? Frankly speaking, we old fellows, we don't much appreciate Arijit Singh. I always feel whether he has got constipation or what. Like that. But nowadays, they like it. We used to like Muhammad Rafi and all those things, our times. Anyway, but like suppose, think that you got a prize and you are given a prize that the Arijit Singh will come to in front of your home, okay, with orchestra. And he will sing a song which you like. Must, huh? Everybody is happy? Yes. Then he asks you, what song you want? He tells, okay, this song. And he sings that song. You'll get happy, isn't it? Yes, definitely you become very, very happy. There is no doubt about that. You will become very happy. But then Arijit Singh feels, he likes this song. He sings again the same song. Okay? Of course, you still become happy, but slightly less, isn't it? When fifth time Arijit Singh sings the same song, what will happen? Arey bhai, mere ko kaam hai, chalo. The inference in that, when first time Arijit Singh started singing, your inner joy was stimulated. It started vibrating. It is a fountain. Then you experience that joy within, so you were happy. Fifth time, it did not stimulate. You were not happy, isn't it? The same joke we are telling 5 times. Will you listen? Arey ja. Isn't it? So remember, this is the thing. The joy is within. Most important thing. Now, I will tell you, you know that usually we don't remain in present tense. Either we think of wrong things in the past or think of imaginary dangerous thing in the future, isn't it? As he already told, devil is not terror as is painted. But we are worried about, so it's like a pendulum. Think of past, think of future, both ways wrong. So that is why we say that past gives you tears because you think wrong things. Suppose 5 times somebody has helped you and once he gets, there's some disagreement, you remember only that thing, isn't it? You don't think good things. 5 times he has helped you, you will not you will forget that. That is happening. Secondly, future, unnecessary. Fear means what? False estimate of actual reality is the fear, F-E-A-R. Get it? You never remain present. That is the problem. If you remain in present, you will be damn happy. Take it from me. Simple thing. 2-3-year-old child goes on moving around here and there because he is very joyful. The reason is he doesn't have past. He doesn't have past and he is not bothered about future. Isn't it? So he is always happy. So be like a child in your mind. Age may grow, but your child. Okay? Secondly, I will tell you, when you remain in present, what happens, the very great advantage. I will tell you, our conferences in Delhi usually are held in such a way that there is a full moon day in between. You must have seen. So that we can go to Agra. Isn't it? And I will tell you, same thing happened. Myself and one of my colleagues in ophthalmic conference, we went to Agra. And well, on full moon day, they keep it open up to 12 o'clock. And I tell you, it's a sight to be seen. Glittering, complete marble. When I saw it, I just lost my mind. I just kept there, totally. After 10 minutes, I came to senses and I look at my friend. Do you know what he was doing? Taking photographs like this, videos like this. अरे अरे देखो ना ताजमहल सामने दिख रहा है. नहीं नहीं, I have taken a nice photograph. I will go home and then see it. He was never experienced the present tense. That was happened because many professional photographs are available. No, why you want to take? Just so be in present. I will tell you a very nice story. You know what happened. One person was there from Madurai. He landed in Mumbai and he wanted to go to his relative. Okay, so he hired a taxi. And in taxi, he told him the address of his relative, and the taxi was going. Suddenly, he realized, I'm going to my relative after a long time, so I should take sweets. Very simple. You always take sweets, no? So what he did, he tapped on the shoulder of a driver to attract his attention and told him, see, in case you get a sweet shop, please take to the left side, park it. I will go take the sweets and go to the my relative. Oh my God, very funny thing happened. When he tapped on his shoulder, the driver started trembling in terror, started perspiring. He could not keep that this thing. He felt so guilty. I'm sorry. He did not talk. By a lot of efforts, he went to left side, parked his car and started wiping his sweat, you know. He said, I'm very sorry, I should not have done this thing. No, sir, you don't worry, it is not your mistake. It is my problem, it is my problem. My problem? What happened? Did you have a heart attack or what? No, it's not your problem. You are not guilty. Don't be guilty. It is my problem. What is the problem? The problem is that he said, last 26 years, till yesterday night, 8 o'clock, I used to drive a big lorry. Today only I am driving this small cab. But it's okay. How does it matter? Big lorry, but you are driving quite okay. Only I started tapping your shoulder to attract the attention. This thing happened. No, that is not your this thing. This is my problem only. Then what is the problem? Then he told the problem is that till yesterday night 8 o'clock, 26 years, the lorry in which I was taking the lorry, only dead bodies I was carrying. So once you get a hand on the shoulder, what will happen? So you remain in past. So this is what happens. You dig out all the dead bodies, all old wrong memories and spoil your present tense. That is the message, isn't it? I will tell you one important thing. Now my granddaughter is here, Swara. She is very much here. I will tell you, I used to go to Mumbai many times and I used to give a call home, talking with some of Saurabh like that. And she lifted the phone. She was 3 or 4 years old that time. See how kids are really in present tense. Unbelievable. She taught me how to remain in present. Because she lifted phone, so I just thought, "Kya kar rahi hai beta? What are you doing?" Of course, I was expecting she will say, "I am playing," or "I am studying," or not studying that age. Maybe I am eating, something like that. Do you know what she answered? "Abu, I am talking to you on phone." This is what is remaining in present tense. Can you see that? We don't do that. That is the problem. Now, this is the problem. Understand from all sides. We don't understand. That is the problem. Samanjasya we call. It has to be must. See, he is also right, he is also right. But you don't understand the both sides. Suppose a flag is there on one side, there is blue color, other side red color. This side people say it is a red flag only. He will say blue. Both are right. Understand of the situation from all sides. That is very important. These are very nice statements he did. I want to just listen to that very few simple sentences.
Strange, but true. 1. In spite of so many colors, white is considered class. 2. In spite of so many voices and sounds, silence is considered ultimate. 3. In spite of so much to eat, fasting is considered healthy. 4. In spite of having many places to travel and explore, meditating in solitary place is considered superior. 5. In spite of so much to see, closing your eyes and looking within is apex. 6. In spite of listening to all the outside world, voice from inside you is eternal.
I hope you agree. Right. Now when I said you have to give joy to others, give means immediately one hand goes to pocket, isn't it? Give means money. Money seems to be a wrong concept. Money cannot be given. We cannot purchase. It's not a commodity we can purchase, isn't it? So what you can give, we don't have to spend a single pie. Simple thing, smile, isn't it? When I smile at each other, everybody has happiness, no? I always tell my granddaughter in the morning, you get up, see in the mirror and smile. You are, isn't a reflection also give you a smile? Smiling is a simple thing. It is the shortest distance between two people, isn't it? A smile, shortest distance between two people. You should smile. People, I will tell you, if you frown and do like this, it requires more calories. We are all doctors. For smiling, less calories are required. But we don't do that. Especially in India, in the morning you see many old people going for a walk. How they are going, how is the face, this thing, their face? Like this. Why? Why you can't smile? But in Western, you must have gone to many foreign countries. They are smiling, isn't it? They will say good morning, even if you don't know. Here we don't say good morning also, isn't it? Of course, we are not so bad, but sometimes suppose a acquainted or known person comes from, definitely he smiles. And if it comes near, immediately he will ask, how is your blood pressure? How is your sugar? Why I should ask these things? That doesn't create joy, no? So remember that. Go and always smile. Of course, I go to many colleges. I tell in India, be careful for young boys. Don't smile at somebody. In India, it may not be taken as a right thing. So be careful. So give smile, isn't it? It's a simple thing. So from tomorrow onwards, start smiling. Secondly, appreciate. Appreciation is very important, isn't it? Our Indians are very, don't appreciate others' success. Suppose I tell my hospital, somebody else does good thing, his colleague, I would have also done, what is there, isn't it? Appreciation is very important. Ultimately, you must have built many house and everything. You do housewarming ceremony, isn't it? And then what happens, suppose you do, why you do housewarming ceremony? Simple, you need appreciation from others, isn't it? As simple, suppose you do good, you have done nice interior, this thing, nobody comes to you. Not enjoyable, no? So you do housewarming. Call your friends and this thing, isn't it? And to give them lunch and everything. Because you want appreciation, very simple. Especially ladies, what they do? Their friend comes, they will snatch her to kitchen. Kitchen is their field, isn't it? And she will tell, see how innovative ideas they have done. See, this is there, this board is there. When I do it, it becomes stable. When I do it, it becomes mirror. Oh, the guest immediately shows appreciation. Now you can take lunch. Otherwise, you don't get lunch, remember. If you want to go earlier, always start appreciating, you will get lunch immediately. There is a funny story I will tell you. One very, very big, very rich man was there. He had a palatial home and there was a nice swimming tank in front of the home. On both sides, there was a lawn. And he purchased one dog. We also purchased dog, Alsatian, Bulldog and all these things we purchased. But he had a special dog. Do you know what dog was that? Dog used to actually walk over the water. Not swim, walk over the water. A special dog, he was very rich. Have you seen such dog anytime? No, I also not seen. That is the story. So what happens, see, only 2-3 persons came in 1 month. So he gave a party. 4-course dinner, okay? All friends were called. On this side lawn, there are so many. On this side lawn, were there many. And then they served soup. Here also they give soup, no big spoon, and they started drinking. Now he said, this is the time to get appreciation from others. Ultimately, he wanted though. So what he said, Tommy, come here. Nowadays, dogs' name are only English. I don't know. In our time, it was Motia, Bitya, but that is gone. Hey, Tommy, come here. And what he did, he took a ball and threw exactly in the swimming tank, that part of side of that swimming tank. And tell Tommy, come on, get it. Tommy, now that was the time, no, he was just waiting, no. See, people were drinking soup. When they saw dog walking over the water surface, coming back, what did I done? Isn't it? This expression he expected. Oh no, our Indian people, they started only eating soup. Nobody appreciated. He said, I wasted a lot of money, just wasted money and nobody is appreciating. He was very nervous. But then ultimately one friend of his was standing there. He asked, did you not find something different in that dog? That friend said, of course, I noted it 100%. He was very happy, at least one noted that something. Then he said, come here, take this mic and tell everybody what you appreciated, what you saw. And then he stood like this. Now he will tell. He said, your dog can't swim. That is the problem. We don't appreciate. That is a big problem. Other things, what you can do? Respect. You can give respect, take respect, donate money and everything. But very nice video. I was really surprised that in Europe, there is a very nice, restaurant. Just observe it, then you will come to know what is that restaurant.
Vi bringer en servicemeddelelse. Som et forsøg vil dørene i dag kun åbne sig for smilende kunder. Husk at smile, hvis du gerne vil ind.
Unless and you smile, that door doesn't open. Isn't that a good idea? If such a scheme is done in India, the door will remain always closed. What do you think? That is the problem with people. Okay. Now, these are simple. You go on Google about stress, this thing tackling. You know that. Exercise, sex, laugh, yoga, routine meditation. That's correct. They're absolutely true also. Exercise especially, you know that it releases endorphin and dopamine also. These are happy hormones. True. They are correct thing. But smile or laugh is a natural thing. As I told you, it stimulates the inner joy. See, suppose in a big hall, in the corner, few ladies are crying. Do you cry? No, you don't cry. If you come to know the cause, you may feel bad, but you will not cry. But have you attended Laughter's Club? Anybody? You should attend Laughter's Club. Laughter is infectious, you know. You may not know the absolute cause of that, why he's laughing, but Laughter Club, they are in group and they start laughing, who in a different way. You also start laughing, but I have to prove it. Just watch this. This person beautifully tried this. Watch this, beautiful. You will also start laughing, I can 100% sure. You can also laugh. There is no restriction. Isn't it? Yes, happiness. Correct? Few of you I could see still very face like this. Come on. There is something simple thing, isn't it? Another few things. Comparison. Never compare with anybody else. We are unique, isn't it? 750 crore population there, everybody's thumb impression is different. Everybody's face is different. The way it talks is different. When he walks, isn't different, isn't it? We are unique. And we are medical, you know, 100 million sperms had to fertilize one home, isn't it? And the competition. So we are unique. Everybody's different ability, every different. Why compare others? Don't compare. People have got habit of comparing. I will tell you, one lady was there. She was staying in a home, and the next neighbor, that house was vacant. And somehow one new tenement came there and stayed there. And she was very good natured. She just saw and she told her husband, see, these new people have come there. They probably don't know which washing powder is to be used. You know, they used to put that drying, outside in the courtyard. They used to put for drying the clothes. They were there, even after sort of washing, they look dirty. So please tell them this washing powder or something, you tell them. Husband was in hurry, okay. And usually husband don't listen to their wives, He was in a hurry, went away. Next day again, you should tell them, see, they're so dirty, I feel. Should I tell? Husband said, no, tomorrow I will tell. What happened? Third day, in the morning, she was so happy. She said, oh, you told the neighbor, now the clothes are very clean and very nice, very good. So you told them. He said, no, I never met him, but I cleaned our own glasses. That is the problem. We only compare, isn't it? Secondly, competition. Don't compete with others. No. Compete with yourself. So you improve your own technique. Yesterday, what you are doing, not good chopping. Next day, you improve your chopping. Something I just. So compare with yourself. compete with yourself. Remember, competing with yourself is important, and there is nobody else to think, isn't it? I will tell you why I am given this example. Sergei Bukka was a pole vault jumper. At that time, nobody jumped 6 meter height. Fact. That time, nobody was near only, and he finished and he got gold medal in Olympics, you know. Then nobody was there. He should have stopped. No. He broke his own record 35 times. Imagine 6.15 was own record. He did not compete with others. He owned record. So try to break your record. Very important. Okay? Right. Priorities in life. Very important. You should know your priorities in life. Okay. Very nice, very small video. Just watch it.
There's a well-known story about a university professor who wanted to make a point about how we make the most of our time. The professor stood before his class with some items in front of him. When the class began, without speaking, he picked up a large empty jar and proceeded to fill it with rocks about 2 inches in diameter. He then asked the students if the jar was full. They agreed that it was full. So the professor then picked up a box of pebbles and poured them into the jar. He shook the jar lightly and watched as the pebbles rolled into the open areas between the rocks. The professor then asked the students again if the jar was full. They chuckled and agreed that it was indeed full this time. The professor picked up a box of sand and poured it into the jar. The sand filled the remaining open areas of the jar. Now, said the professor, I want you to recognize that this jar signifies your life. The rocks are the truly important things, such as family, health, and relationships. If all else was lost and only the rocks remained, your life would still be meaningful. The pebbles are the other things that matter in your life, such as work or school. The sand signifies the remaining small stuff and material possessions. If you were to put sand into the jar first, there is no room for the rocks or the pebbles. The same can be applied to your lives. If you spend all your time and energy on the small stuff, you will never have room for the things that are truly important. Pay attention to the things in life that are critical to your happiness and well-being. Take time to look after your health, play with your children, go for a run, write a letter to your grandmother. There will always be time to go to work, clean the house, or watch TV. Take care of the rocks first. The things that really matter. Set your priorities. The rest is just pebbles and sand.
Isn't that a great thing? You agreed? Agreed? I will tell you what are the priorities. I ask many times because I go to many colleges. Everybody different career. No. Do you know? I will tell you the priorities. First should be health. Health is lost, everything else. If you are not healthy, what is it? You may be a very good doctor, but not health is good. Health first, then family. Third comes career, and last is social. People don't have wrong idea. People are social people that are doing everything that is wrong. First is health, then comes family, then comes career, and last comes this thing. Now, attitude. Your attitude makes matter. No? The Aditya Birla saying, brighter side of life, isn't it? Always see good thing. Simple thing. I will tell you a very nice saying in English, 99 Club. You know that? I will tell you. What happened? One king was there, and his sweeper was there in palace. Okay, he didn't have great salary, but he used to, while sleeping, he used to sing a song and very joyful. So, king, he was there for 20 years. Ultimately, king saw, this sweeper doesn't have, but he always happy, smiles and sweeps the palace. And I have got everything, I can have anything, whatever I want. But I got so many tensions about enemy, about popularity. He is so happy. So he asked his Prime Minister, Mr. Pradhan, how is it that he is so, Pradhan said, should I make him unhappy? He said, challenge. I have been observing for 20 years. He is always happy and having a happy face and everything. He is very satisfied person. He said, I will accept the challenge. Okay, why what? You should give me gold coins, and one bag to keep it. Okay, he gave him. You know what that he did? When the sweeper's home, when he was closed, at night time, he told his servant to keep that bag outside his door. Okay. In the morning, he got up, and he saw a bag. What is that bag? He saw here and there. Nobody was there early morning. So he just opened it for gold coins. Oh, he said, God has gifted me because I am doing a very sincere work. So it's my luck that God has gifted me this thing. So he opened and counted those. They were 99. He said, no, God cannot give 99, no, full figure. He will give 100, isn't it? So again counted, again 99. So he asked his wife, come on. She counted 99, son. Then he got annoyed. Oh, somebody has taken away that, isn't it? So his Face immediately become absolutely smile gone from his face. He said, okay, doesn't matter. I will work overtime. I will go and in the evening I will do another job. He went to palace, but the face was having no smile. King was surprised. He asked, what magic you did? Simple. He had joined our 99 club. We are all 99 club. Whatever you have got, you forget. That is the problem. Whatever is not there, you only think of that. Whatever you have got cycle. Come on, people don't have cycle also. People, you have got scooter, you have got car. So that is, remember, very important. Yes. And what is success? He was talking, I will say success is journey, not destination. Or enjoy the process. That is important. Enjoy the process. Success is not a destination, it's journey. You see, you will definitely like this video. Success is an absolutely variable thing. It varies with age. This one is mine. This one is mine. Alzheimer's, isn't it? Wasn't that good? Agreed? When success of what he was talking, there are three things. Growth. 10% growth is taken as success in any industry. Anything. But this 10% can be ethically or unethically, isn't it? It should be ethically, then it is called progress. But the real success is when progress with peace. You may have got a lot of money if you don't have peace in mind. It's not. That is why I shown a photograph of whom? Tata, isn't it? Now just watch this video, you will come to know what Tata is, and just see this.
Common perception in India. However, it's essential to recognize a fundamental difference. The Ambani family has climbed the global wealth ladder with the primary goal of wealth accumulation. In contrast, the Tata family has made a conscious choice to allocate 66% of their earnings to Indian orphanages. How substantial is this contribution? It's not merely 2-3 crores. Ratan Tata's donations to underprivileged children and orphans surpass Ambani's entire wealth, amounting to approximately Rs 8.5 lakh crores. What do you think about this man? Leave a comment.
That is why I say Tata is a successful person. Are you getting it? Success is what? When you get peace of mind. And peace of mind comes only when you start giving others. Giving is the only way to get peace. Isn't it? Very simple. So remember, Ambani has got $106 billion property, $106 billion. And Tata has donated $103 billion up till now. He has not become poor. No, no. He has purchased Air India. Come on. So you never become poor by giving it to giving. Okay?
Common person.
What else? Yes. Now about, of course, this I tell to students. On everybody also, ultimately there are many coals in the population. Very few diamonds are there. Why? The difference. Coal and diamond, both are having periodic table C. Carbon, no, both are carbon. But then, if I give 1 gram coal and ask me 1 gram gold, diamond, will you give? No. Why? The difference is that coal is a very simple, it's formed in the upper layers of earth, buried, plants buried, it's called carbonization. But diamonds are found in very deep layers of earth. Pressure is approximately 725,000 pounds square inch, and temperature is 2200 to 2200 degrees Fahrenheit, 100 miles below the surface. So, if you want to be successful, be ready for any stress. Try to give your best. So, hard work is very much important. Then you become diamond. Other coals are so many. Not you all. I'm just doing that. There are very few diamonds, remember. So, this is important. Then when there are eruption, then the volcanoes, then the diamond comes in upper layer. So, remember, this is very important thing. See how that girl does fantastic. You need guru. As I told you, luck means what? Hard work in correct direction. Then gives you. So, direction, guru tells. What guru told? Okay, you have so many failures, doesn't matter, keep quiet. Yeah, I must tell you, suppose you do PCR, don't panic, keep quiet. Take deep breaths. When you take deep breaths, you start seeing the solutions. If you start panicking, you create more complications. So the child did the same thing, kept quiet, took the deep breath, visualize that it's going to stand on a stool. You visualize first your result. First you visualize, then only it can happen. What you think you become, always remember that. Right. It's a simple thing, no? It's nice. And wine is wine if the grapes are not pressed. There is no perfume if the flowers are not crushed. Never be afraid of pressure in life, as it brings best out of you. Remember this thing, very important. About ego problem. Nowadays, ego, the word go is there, but it doesn't go. Ego contains go, but that doesn't go. That is the problem. And nuclear families, that is happening, So there's one nice story. Just married couple was there, both were earning, and Sunday morning was there. There was a sound outside the door. You know that newspaper comes in the morning. Everybody wants to read newspaper, isn't it? Both husband and wife ran at that. Husband opened the door and the wife lifted the newspaper. Male ego, isn't it? Male ego. Husband said, give me that paper. See the action. Give me that paper. I will read it first. That wife is not Sati Savitri like old. No. She said, why? I have taken the paper. I will read it first. Simple. Then he again said, the sound that he went, give me that paper. I will read it first. He said, no. Then I funnily say, that husband attended our Jivan Vidya course where we tell to suppress your own ego. But he said, why not to try one more? So what he said, if you don't give me that paper, what wife said, what you will do? He said, okay, you read it and then give to me. Simple solution, no? And that is what happened. But the thing is that female's brain is totally different. Do you know what happened actually? The wife gave her in paper also, as well as prepared pohe and tea, That is the way, create joy in your life, okay? Very simple thing. And one more thing. Nowadays, what do you call it? There is premacha spot hoto and lagna zalar ghata spot hoto. That is horrible. There is no understanding. There is no absolutely adjustment at all, Adjustment I call not A-double-D, just adjust. You should adjust. Be flexible. Remove, then only, and families are required, I will tell you. Single mother, single father, no, that won't do. See, this is a beautiful video. Observe one small kid over there, and you will come to know how it is important. Observe that kid. That child is not seeing her parents. How, and she sees the joy. See the joy of, isn't it? Oh, what a fantastic. So, married people always remain together. You are married, you have got kid, no? No, it's responsibility. Adjust. No, divorce is not the solution, See the child, very important, isn't it? One more thing. Okay, not only, in family, I always tell you, eat together. At least one dinner or lunch should be together. And keep that latest organ which has been developed, keep it in other room. That organ, everybody knows that organ. Mobile, you should keep outside. And talk, fight with each other, doesn't matter, but remain connected with each other. In family, what happened? You are in contact but not connected with each other. Remember, remain connected with each other. This is a simple thing. Always you do it. Dine together, dine together. And now one more thing I'll tell you. Now because I am grandfather, I will tell you grandfather is also needed in life. Just watch this, just watch this. I will always prove everything. Isn't that? So, joint family is a very good thing. It requires adjustment. Some space you lose, but then it is fantastic thing. I can tell you, nowadays joint family is not. Sometimes people say if the husband and wife are together, that can be called a joint family. that is the big problem. I will tell you, yes, grandfather, grandmother needed. We have got nice 3 granddaughters. We enjoy so much. Yes, that is very important in life. Always remember that. Okay. Yes, empathy. You should have empathy. These are human values. This photograph, I have seen this actually match. Have you seen that? When Federer was getting retired, Nadal, his ardent rival, when Federer started crying, Nadal was crying much more. You have seen that? I have seen that live match. Empathy, he could feel, embody himself. While retiring because of some problem, other problems, he felt that he was crying. Nadal was crying like anything. This actually, I have seen that match, this empathy, you should embody others. Gratitude is important. See this photograph, have you seen in Times of India, this photograph? Yeah. Narayan Murthy, Infosys chief, when he was felicitating Ratan Tata, Lifetime Achievement Award. It is the other way around, no? Who is felicitating, he should, no, what he did? Narayan Murthy touched his feet. It was in 5-star like this, all Western people were there. No, he did not. He is not ashamed to touch the feet of Ratan Tata. Do you know why? Gratitude. Because Sudha Murthy, his wife, first service she did in Tata Motors. You know that? Yes, Tata Industry. And that time JRD Tata was there. They were not allowing women to on floor, Then she said, why not? He wrote it, she wrote it, and she got the job. So that for gratitude, Narayan Murthy touched the feet of, so be grateful. Saurav told the same thing, grateful to everything, grateful to your instrument also, grateful to everybody you help. And in life, our Jivan Vidya Mission tells, write down gratitude diary. Our granddaughters do write there. Gratitude in whole day, who helped you? Yes, grateful. Grateful heart is close to the universal forces. Is very important, very important. Now I will tell you the last video of today's this thing. It will give, just introspect yourself, work-life balance, how it should be and why it should not be. Thank you very much. Thank you. Thank you. Anybody else to give comment on this? Or anybody experience something like this? It must have touched definitely few of them, isn't it? It's our life. It's our life. Yeah, please.
The video you shared, it just explained my life. Recently, I lost my father and he wanted me to see. But I didn't go busy in routine. And you showed about the diary. Later on, I read his diary and everything. It came just back to me. Thank you, sir.
I know it always touches because we professionals are so busy in our profession, we forget what life is for. The basic things we forget. Ultimately, at the end, well, everybody feels I should have done that, but the time is gone. You can't purchase time, isn't it? So, present, live in present, enjoy, and priorities. I told you health, family, then career, and then social. Very important. So, thank you very much for your kind listening. And I think that you got something, some message from this. Yeah, thank you. Thank you.
Tomorrow, I think we are starting early, 8:30 a.m. Dr. Safran will be joining us. So breakfast will start at 7:30 and 8:30 will start the session. Thank you, sir.